Ona predsjednica skupštine kad je ubijen Đinđić. So, good morning, everyone. In this obviously early session, but we find it very interesting and useful. And we will talking about cancer prevention and screening in Serbia. How can we do better? And it is my pleasure to announce Dr. Wim Selin from European Cancer Organization, and it's our pleasure that he has accepted to give his lecture about screening activities and strategies for the future.
Well, thank you so much for the introduction and for the invitation. Yes, my slides are there. So I'm working as a surgical oncologist, in fact, in Ghent, which is in the north of Belgium, as you may know or not know. And I'm currently a board member of the ECO, the European Cancer Organization, and I'll tell you something about it in a few minutes. So the topic of my talk today is how the European Union
know her. And our invited speaker for this session is Dr. Metzger, Otto Metzger, who is coming from Dana-Farber Institute, and he's doing clinical research in breast cancer, and if I may say, in two breast cancer types, lobular, invasive, and HER2 positive. So that is. But now we are Dr. Metzger. I'm sorry. So will give us a lecture. Yeah, this is adjuvant chemotherapy for ER-positive breast cancer advances and a critical overview of therapy de-escalation. So, Otto, you are here.
Good morning. I'd like to thank the organizing committee for the kind invitation to be here. It's my first time in Belgrade, and it's nice to be here in the hometown of a close friend of mine, Dr. Ivana, who is seated here. Ivana and I, we did a research fellowship together in Belgium many years ago, so it's very special for me to be here and talk a little bit about this topic that it's still an old topic, but I think it's interesting, which is adjuvant chemotherapy for estrogen receptor-positive breast cancer. When we think about adjuvant chemotherapy treatment decisions, and I know that we also have fellows here in the room, it's very important for us to remember the value, the prognostic weight of classical things, such as nodal status. Patients with large cancer, large number of positive nodes, they have a very high risk of relapse over many years, not just in the initial 5 years. And more recently, over the past 10 years or so, we adopted this novel genomic tests to tailor chemotherapy recommendations, but I think we need to interpret this with open eyes, given that we have the data. And when we think about these novel tools, it's important for us to really understand what we're trying to achieve. Are those tools, the genomic tests, Oncotype, MammaPrint, giving us prognosis? Are they stratifying this population in terms of risk? Or they are really informing at the cancer biology level which cancers are more likely to benefit from a certain regimen, which is chemotherapy. And to answer that, which would be a predictive role of this test, is you look for what's called an interaction p-value. You need to see if there are differences in magnitude of treatment benefit by different levels of a given biomarker, low or high risk. So, and most of these studies started with node negative, patients with 1 to 3 positive nodes, and it's a sort of like a low-risk population from an anatomic standpoint. And in the next few slides, my question that I want to answer is, do high-risk genomic subsets provide us with predictive information, or this is just prognostic? So we have large clinical trials. The first that was presented and published is the TAILOR-X that use Oncotype DX, and randomized patients with Oncotype in the recurrence score from 11 to 25 to get chemotherapy or not. The study was a non-inferiority study. We can see here the curves, and I'll come back to that later, but this is telling us that patients with low Oncotype, they do well from a prognosis standpoint, from a risk standpoint, and you don't gain much benefit by adding chemotherapy. The curves are overlapping. When we go to the younger patients, and this is a common theme across these studies, we do see that chemotherapy adds a little benefit to this population, and I'm going to get back to that later. The MIND-ACT study, which is a European study that was being conducted when I was in Belgium, randomized patients who had discordance between a MammaPrint classifier and a clinical risk classifier. But the primary endpoint of the study focused just on patients who had a high clinical risk, but a low genomic score defined by MammaPrint, with the hypothesis that these patients would have a good outcome. And the study was positive. You can see here the 5-year distant metastasis-free survival, which has been updated since the initial publication, showing that these patients, they do have a favorable clinical outcome. So this study was basically designed to show the prognostic value of this test, which it does show here. It's important for us to go back and see how MINDACT was conducted. As I said, it's a randomized study, and as a secondary objective, we had the evaluation of the benefit of chemotherapy versus no chemotherapy for this population. And we see here the results with a separation of the curves in favor of chemotherapy for the overall study population. And here we're talking about distant metastasis-free survival, and we can see here that in ER-positive disease as a common theme, we need to follow up patients for longer. And as we follow up these patients for the overall study population, we do see a benefit with the addition of chemotherapy, not a large benefit, but close to 3% in distant metastasis-free survival. So if this were a new drug, maybe this would be widely used, but this is just our old chemotherapy regimens. In the MINDACT, when we break down this population by age, we can see that the majority of the benefit for chemotherapy is seen among patients that are younger in the premenopausal setting, where we see a larger separation of the curves. I'm going to just bring up that those are studies that were not designed to show that there were differences by age. Those are additional things that we're seeing but consistently across these studies, indicating that there could be differences for younger versus for pre versus postmenopausal patients when we think about who benefits from chemotherapy. The R-Exponder, which is a third large clinical trial that was conducted in the US with support from the NCI. It's a study that included patients with node positive, 1 to 3 positive nodes. When we go into the publications and the actual details of this population, despite being a node-positive population, it's still on the lower risk in terms of the anatomic burden. We have very few patients that had 3 positive nodes, a lot of patients with micrometastatic disease. But anyways, the study did randomize patients with oncotype recurrence scores that were up to 25 to endocrine therapy versus chemo plus endocrine therapy. And I want to bring your attention here to the primary endpoint and the primary hypothesis, which was basically, R-Exponder is a study that was designed to demonstrate a positive interaction test of chemotherapy benefit with increasing recurrence score values. So it's a beautiful study that was designed to show that Oncotype DX could be a predictor, identify with the idea that as you increase oncotype recurrence scores, you get more benefit with chemotherapy. So it's very elegant from a statistical analysis standpoint, but I don't think that the discussions and the publications really highlight the fact that the study is totally negative. What is the hypothesis and how this was created as such? So these graphics here show in the x-axis we have the recurrence score. And here we have what we're doing, we're plotting as a hazard function the risk over time. So here we're looking at risks across patients who would get chemotherapy versus not, using data from the SWOG 80/80/14. And the idea here was that, based on data from the SWOG and the initial publication, was that the chemo benefit would be greatest with a recurrence score reaching 25. We see here the curves is crossing, and would decrease as recurrence score decreases. So this is what was seen in the SWOG study. It's a retrospective analysis of the SWOG clinical trial that, from a retrospective standpoint, does point out to an interaction between oncotype recurrence scores and chemotherapy benefit. And we, as a breast oncology community, and many of us believe that this was the case. So our Exponder was designed to demonstrate this prospectively, and what was shown was the opposite. The chemotherapy benefit in reality in the study was larger for patients with oncotype scores closer to 0 than 25. So the study is negative, indicating that, one more time, Oncotype DX does not predict for chemotherapy benefit, but it does have some prognostic value. As for MINDACT, when we look for the actual randomization, chemo versus not, we do see a benefit for the overall study population with a hazard ratio of 0.81. But when we break it down by menopausal status, it's the same story. In the postmenopausal patients, you don't see as much benefit, while most of the benefit is for younger patients in the premenopausal setting. So what this is telling us about? Someone may say chemotherapy doesn't work for postmenopausal patients. I would argue and say chemotherapy is not needed for this population. When we look into the results of the chemo versus not, the hazard ratio is 0.81. But it's not needed. Maybe these patients, they have more favorable outcomes for things that we don't know. And there are additional topics related to the younger patients that I'm going to highlight briefly. So what are the take-home messages for this low-risk subset of patients? I think there is too much weight on the utility of Oncotype DX and MammaPrint. This is commonly used in the US and in many places as part of the routine clinical care. If you ask me if it's useful, yes, it gives us prognostic information. I think that it's overused, and I think that they can be overinterpreted. They do facilitate treatment optimization for postmenopausal patients with node negative or limited nodal burden. There is a lack of clear benefit for premenopausal patients. So there's a lot of discussions about potential indirect effects of chemotherapy taking these patients into menopause and potentially indicating that that's why there's these differences. I would argue that there are differences in the chemotherapy regimens that were used in these clinical trials that have been not much discussed or even published in details, and it's clear that a younger patient gets more intense chemotherapy regimens than a patients in their 70s for all the obvious clinical reasons. So there could be differences there as well. And there are probably additional intrinsic biologic variables that we don't know and have not been tested on these clinical trials. But again, for this low-risk population, I think we need to interpret with caution what we can achieve with the incorporation of this genomic tests in clinical practice, because a lot of the information is already available through pathology report and a careful clinical evaluation of tumor burden. I think what's interesting here is that what we do with the higher risk ER-positive subset. And I'm not going to define what is higher risk. I think that we as clinicians, we have a good sense of what tumor burden brings in terms of risk, age, and additional characteristics. And again, I think it's important for us to see what are the population included in these 3 clinical trials that I mentioned, that they do have a very low anatomic risk. So, and the problem here, and I think that the problem that we have in the United States where we use these tests often is an intrinsic bias that exists in our minds in terms of the value of these tests given the prognostic associations. And sometimes we have patients with node-positive disease with larger tumor burden but very low oncotype, and this may lead clinicians to choose chemotherapy regimens that be less effective. And I think that the jury is out there, and we need to be careful with these interpretations. There's a lot of debate as of today about who should get anthracycline. I think that the last Oxford meta-analysis that was published last year, it's a very good manuscript that I encourage everyone in breast oncology to read. It brings this very good discussion about, on average, what can you get with anthracycline-containing regimens versus the taxane-based regimens, which is basically TC, that's widely used. And on average, the anthracycline regimens, they bring us a 14% lower recurrence rates when compared to non-anthracyclines. We also have this updated analysis for dose-dense chemotherapy versus not, also showing that the dose-dense chemotherapy is more effective. So we need to interpret the available data with a lot of caution when making clinical decisions for the high-risk subsets. And again, I don't think it's appropriate to bring data that we have from the lower risk subset with these genomic tests to make these clinical decisions. We need additional tools. And this led me to do this research that's going to be published soon in JCO, where we use data from the CLGB, the dose-dense clinical trial, CLGB 9741, and we evaluated the new biomarker within this study. So briefly, the CLGB 9741 was a study conducted by the NCI many years ago that showed the ACT given in the dose-dense fashion was more effective than no dose-dense regimens with the same agents, and the concurrent versus sequential didn't matter much. But it's the study that led to the common use of dose-dense ACT in the US and in many places. So this new test, the SET, is a test that was developed by Fraser Simmons at MD Anderson. And the whole idea here, when Fraser was developing this test, and I was working with him through Alliance, was to evaluate it to try to measure endocrine activity, because we rely on estrogen receptor to make treatment decisions. But the idea was, well, our estrogen receptor positive breast cancer, they are really sensitive to hormonal therapy. So this test basically has what's called a SET-ERPR. Those are genes that are consistently expressed with the estrogen receptor and excludes genes related to proliferation. And I think that this is interesting because with MammaPrint, with Oncotype, with PAM50, they are highly enriched for proliferation-related genes. That's why they're good prognostic tools. And so SET basically measures genes related to ERPR and exclude the proliferation-related genes. It's adjusted for these prognostic factors, including intrinsic subtype, tumor size, and older status. So the initial results and the most updated results that we have as of today for this clinical trial, the 9741, were published many years ago now in 2006. And when we have this publication from Don Barry in JAMA, we had this impression that dose-dense therapy would be more effective for the subset of ER-negative patients here on the left. For the ER-positive subset, you wouldn't see much benefit. But given I was doing this biomarker analysis on this clinical trial, I managed to get permission to do a 12-year updated overall survival analysis of this clinical trial. And this is going to come out in the JCO hopefully very soon. It's accepted for publication. And here, what we're seeing is that dose-dense chemotherapy works very well for ER-positive disease as it does for ER-negative patients. I'm not showing you all the curves that are going to be in the manuscript, but I can talk about them. They're under embargo for the publication. But what is interesting here is the fact that when we focus here on the left side, left plots of this slide, and look just into the ER-positive subset, you're giving dose-dense chemotherapy at the time of the diagnosis, and you can see that these curves, they start to split just later on. So for ER-positive disease, for us really to understand what we're trying to achieve with any intervention in the adjuvant setting, we do need long-term follow-up. It's a disease that has a long natural history. We could hypothesize why this happens, but it's really interesting to see that there is a benefit in terms of disease-free survival for ER-positive patients as we see for ER-negative patients. I can tell you that this difference is not driven by menopausal status. Most of the benefit was seen in the postmenopausal patients who had higher risk. So it's not a same story that we had for the initial studies. And when we adjust for additional clinical pathological variables, and as done in the initial analysis, all these results remain positive, including for survival outcomes. Well, let's go back to the biomarker information here and what we're trying to achieve. What were our questions here? The question was, would dose-dense chemotherapy be more effective in patients who had low SET, estrogen receptor positive patients, but with the ER pathway not active? So maybe there's a subset of patients who benefit more from a more intense chemotherapy regimen. Second question was, what's the prognostic value of this tool? And third, I wanted to do a direct comparison with PAM50 to demonstrate that this is not the same, a measurement of prognosis and proliferation. So we used samples for which we had PAM50 results and performed the SET assay on the same samples. So here we have the distribution, the classification of the samples according to PAM50 and SET, and I want you to focus just on the right plots. And here on the first plot within the pink square, we have patients with SET low, indicating low endocrine receptor activation, low estrogen receptor transcriptional activity, and the distribution of intrinsic subtypes. So we have luminal A, we have luminal B, we have HER2 enriched. In the right side, the right plot, for patients with SET high, ER pathway is activated, half are luminal A, half luminal B. SAT, as a biomarker, is measuring a different biological phenomenon than we have with PIM50 and intrinsic subtype. And what this is telling us from a prognosis standpoint in terms of overall survival. So here on the left, we have just the SAT curves, high SAT shown in black, low SAT in red. We can see this marked separation of the curves at 5 and 10 years. The prognostic value of the assay is really real here. We see that patients who have high SAT, they do much better than patients with low SAT. And it's interesting when we plug in the PIM50 measured here about ROR, we see that basically SAT is giving us most of the information in terms of our ability to stratify risk to this population. In the manuscript, we describe with more statistical analysis that you don't gain as much by measuring both variables. So it's really a tool that has this very robust prognostic value, and this has been validated before in previous publications, and we have a separate manuscript using data from PALAS showing the same. But what is important here is the predictive value, and here I'm going to go straight to the results, where we have just the module of the SAT that's measuring the ER-PR-related genes. And we look here on the left side, patients with SAT ER-PR high, the curves are overlapping. We don't see a separation for those dense chemotherapy benefit versus not. While for patients with SAT ER low, we see a marked separation of the curves. And as I said before, whenever we're looking at prediction, we know what's the interaction between your variable and the benefit. And here the P for interaction is 0.03. So basically our hypothesis was confirmed, indicating that patients with low SAT, they do benefit from a more intense chemotherapy regimen. I would say again, one more time, that the results were consistent for pre- and postmenopausal setting, for both the prognostic value and the predictive association. Those studies are old. They were conducted before we had HER2 testing, so we did take that into consideration and adjusted to make sure that our results were not a reflect of HER2 positive versus negative. So it's really indicating that SAT ER-PR low, they do benefit more from a more intense chemotherapy regimen, and the intrinsic subtypes did not predict for the same information here. Luminal B versus luminal A had no ability to identify who would benefit more from those dense versus not. So in conclusions, for the low-risk subset, the genomic tools and the first-generation tests, they have prognostic utility. I think that for places where this is not being used routinely, as most of the places outside of the US, I think that some thoughtful criteria for ordering this would make sense. I would argue that we as clinicians were able to identify these patients very well, and we probably don't need Oncotype or MammaPrint for the majority of patients. When chemotherapy is considered, I would say that those dense ACT should be the standard for high-risk patients. We as clinicians, again, we should be careful and be able to identify subsets who have more or low risk, comorbidities, and make these decisions, but the data shows that those dense ACT is the best regimen, no doubt. The SAT assay, it's an assay that has been validated from its prognostic value. Our manuscript is the first manuscript that's showing that a biomarker is able to identify who benefits from those dense ACT versus not. There will be more interesting data coming from a presentation in San Antonio looking at this predictive association, so I think it's very interesting to see how this assay is evolving. And when we make decisions for patients with early-stage disease, there are many additional factors, as I said. There are comorbidities, there are different aspects that we're paying more attention today that have a lot of benefit in terms of risk reduction, in terms of management of obesity, physical exercise. There are clinical trials ongoing. And again, there's a lot of space for thoughtful judgment. And I think that we as oncologists, we should say that the goal is not to have a recipe and say anthracycline for everyone versus not, but really to be critical and to interpret the data without bias and avoid over-interpreting data for this oncotype and MMFprint studies in higher risk patients, which is a problem for us in the United States. Thank you so much.
Thank you, Dr. Metzger. I have just a few quick questions. Do you expect that SET will enter the routine practice soon or not? So this is the first question. The second question for all of you, do you think that Oncotype DX is not predictive? And the third clinical question, do you think that anthracyclines are indicated for all high-risk patients with HR-positive, HER2-negative breast cancer? I'm not talking about comorbidities and et cetera. Do you think that there is an age limit for adjuvant anthracyclines? So the first question, Seth,
So I think that for us to adopt a test in the clinical practice, the clinical validation is very important. And what we have for this test are retrospective validations. My take on that is if we're really to show a predictive value in identifying certain or more intense chemotherapy regimens versus not, I see this with a lot of clinical utility because it's very hard to dissect risk in a high-risk subset, patients with node-positive disease, and I think that this could be very useful in the clinical practice. So the prognostic value of the test has been validated across several publications now. This is the first information that's giving us predictive information, and we'll have more coming up, like that's going to be presented in San Antonio. So I hope that we'll have, as a collective community, some clinical judgment to evaluate this new test and hopefully adopt it before having prospective randomized clinical trials, as we did for other tests. But I think that the retrospective information that we're going to have here is going to be more robust than what happened in the past with Oncotype, for instance.
Thank you. Oncotype DX, would you answer? Is it predictive or not? Do you think that it is predictive or not? Oncotype DX.
So I think Otto clearly demonstrated it was stated it's not a predictive test regarding the importance of the chemotherapy impact. So it's clearly prognostic for me.
It's clearly prognostic, yes, okay. And the third question is, do you think that anthracyclines for all, let's say you have a lady, 75 years, she is fit, but 75. And she had a lot of lymph nodes and adjuvant therapy. So what would be your, judgment?
So you are asking me about anthracyclines because I am problematic, right? Okay, good. I see. Okay, so there are prospective clinical trials, Plan B, for example, and others, showing that in the ER-positive field, the role of anthracyclines might be much lower compared with triple-negative breast cancer. So I think that in TNBC, anthracyclines are clear. In HER2 positive, we can discuss, not for all patients, but we can discuss. In ER positive, I strongly believe that the role of anthracyclines is very limited. Having said that, if you have a young woman with a lot of lymph nodes involved, I think that's something reasonable to use. But for postmenopausal, for node negative, or 1 to 3, I have started to decrease the use of anthracyclines.
Okay, thank you.
So the last question about early breast cancer. So when we will start to use ribociclib in adjuvant treatment, is there any group of patients with high risk hormone receptor positive disease in which chemotherapy can be omitted?
Well, in the NATALEE study, also in the Monarch E, which is higher risk, there were a number of patients who did not receive chemotherapy and were randomized to receive or not CDK4/6 inhibitors. So the first answer is yes, it could be. If the question is, if I believe that a patient should receive chemotherapy, whatever the reason is, do we have enough data to omit chemotherapy and going for CDK4/6 inhibitors? The answer is no. There is an ongoing clinical trial that is going to be started soon which is going to be a large 3,000 patients or so led by the French folks to try to answer this question. My first answer is I'm sure that there will be a group of patients that with CDK4/6 inhibitors we will not need chemotherapy. My comment is I think that we do not need 3,000 patients to demonstrate this. We have to, again, going back and to discuss about strategy-based clinical trials with about maybe 7, 8, whatever number of 100 patients is, to demonstrate that that's something that can be done. So the answer is yes, we will do it, but no today, in my opinion.
Okay, thank you. So we have to proceed. We are out of time, so Simone and I prepared, we were much more diligent than Lilia and Natalia because we prepared 4 cases. But of course, if we had no time, we will skip them, or we will give up on those cases we have no time for discussion. So the first clinical situation actually is the first line. Therapy for HR-positive, HER2-negative metastatic breast cancer patients. So I am going to present 2 cases simultaneously, and I hope that it wouldn't be confusing. So the first case is, I'm sorry, that's my. Okay. So the first case, this is just to set the scene. She was diagnosed with breast cancer in September 1994, so 30 years ago, at the age of 40. She was going straight to operation, and it was breast conserving surgery, and pathology showed that it was 10 millimeters lobular invasive cancer, grade 2, with 1 positive lymph node. At the time, ERPR unknown. And she got postoperative radiotherapy and then 5 years of adjuvant tamoxifen. So the second case is also a young lady at the age of 30. She was diagnosed with stage 3B breast cancer in March 2021, so 3 years ago. Biopsy showed that it was invasive ductal carcinoma, grade 2. ERPR positive, HER2 negative, Ki67 10%. She was BRCA negative. We have do the test. The test was done later. So she got neoadjuvant chemotherapy, anthracyclines, and docetaxel, and with the GnRH analogs. And after that, she had a radical mastectomy in November 2021. So she had residual disease with T2 and 5 lymph nodes, ER positive, PR negative, HER2 negative, and Ki67 15%. So she was postoperatively radiated and then continue with adjuvant endocrine therapy with GnRH analogs plus tamoxifen. So what happens next? So the first patient, she was after 25 years of her operations, she just was complaining on dyspnea on exertion, etc., etc. So CT imaging showed that she has pleural effusion and both and metastasis in both lungs, but it was less than 10 metastases. So pleural biopsy showed that it was the metastasis of adenocarcinoma of the breast, ER positive, PR positive, HER2 negative. So at that time, she was 65. She was very fit and very active physically. She was running her business. And the second case, so what happened to her? So she also experienced disease relapse after 18 months of operation. She just to bear in mind, she was a CT body scan 2 months after relapse occurred was clear. So she had no metastases, but her relapse manifested with jaundice and mild fatigue. She was physically very active, 32 years, and CT and MRI imaging showed that she has a massive liver metastasis, pancreatic metastasis, and retroperitoneal lymph nodes. So the first, she was doing supportive surgery because they did some operation just to allow for bile drainage. So, and after that, I forgot to say that she had also a high level of bilirubin and elevated liver enzymes. So after the operation, the bilirubin and AST and LFT began to low. So here are our first questions. For the first lady, so long disease-free, limited organ involvement, ECOG1 elderly, the first question is, what would you recommend? Standard endocrine therapy or standard endocrine therapy with CDK4 inhibitors? And the second one, if CDK4 6 inhibitors is a recommendation, which one would you prefer? Palbo, Ribo, Abema? Which one? Okay, should I say, okay, start.
Okay, this is much easier than the second one. So for me, it's very clear, IA plus CDK. That's an easy question. So I think that it's difficult to imagine today who will not need CDK4 and 6 inhibitors. We can discuss who will need chemotherapy because the patient in the right were not exploring clinical trials, okay? The right choice did not include this patient. Now, the second one, okay? And I want to be very, very honest here. When I have been giving talks about Avastin, bevacizumab for many years, I've been giving talks about everolimus for many years, and I always say the same. When you design a clinical trial for a primary endpoint, you design a clinical trial for a primary endpoint. So all these trials, Mona Lisa 2, 3, 7, Paloma 2, 3, Monarch 3, 2, all of them have a clear primary endpoint, progression-free survival. And the hazard ratio is exactly the same in all trials. It is true that when you look at the overall survival, it seems to be different. It seems to be different in Paloma 2. So Paloma 3, when you look at the hazard ratio, not the p-value, the hazard ratio, Paloma 3, all the others are very, very similar. So if the question is, do I think that palbociclib is inferior to the other ones? For me, the answer is clearly no, it is not. But it is true that Paloma 2 had a lot of caveats and they had the results it had. So I feel comfortable with all of them, okay? So I think that for this patient, both Ribo and Palbo would be my first options. I would leave abemaciclib for maybe higher, or patient with higher risk, but again, all of them are good. I think this is something you should discuss with the patient, but Palbo, Ribo for me would be very good options here.
Okay. Thank you very much. Would you like to answer?
No additional things. Use the one you might have in your institution, because in some countries you don't have access to all of them. And then the easier is to use usually the drug when you have the inability to use it. I mean, looking at the side effects and looking at the monitoring. So I will not have any preference here.
Thank you. Naoto?
I also feel the same, and I think that unfortunately there's a lot of overinterpretation of secondary endpoints in terms of difference in survival outcomes for these trials. The studies, as Javier mentioned, they are exactly, even with like the nominal estimate in terms of the benefit that you get once you add a CDK inhibitor in the first line setting, it's exactly the same, the benefit. Who knows what patients got in terms of second, third line across these trials, the differences that exist in populations in terms of endocrine sensitivity, how long patients were out from the adjuvant setting until they're included in these clinical trials. Those are things that may have impact on survival outcomes. But the point is, one should not interpret a secondary objective of clinical trial to make decisions here in terms of these agents. And the correct is to say that any of these drugs can be used. I tend to use palbociclib or ribociclib in the first line setting because I think they are easier from a patient perspective in terms of not having the GI side effects. And as we get more data, we know that abemaciclib is a medication that can be used in later lines. So I really prefer to keep it as a medication that I will eventually use, or we may have a different CDK inhibitor for these patients. In terms of the first-line treatment recommendation, I would say that the correct answer is to always consider and discuss with patients what you can gain with a CDK inhibitor in the first-line setting. For this patient, I would most likely consider using a CDK inhibitor. But we as clinicians, we should have the freedom to discuss with patients and say that we believe that in specific occasions, patients with limited disease burden, patients with comorbidities, elderly patients, that we should consider using monotherapy for some patients. And after a discussion, I think this is totally reasonable. And I really feel that based on all the data that we have, treating a patient with single-agent AI and then consider adding a CDK in the second-line setting, there wouldn't be compromises in terms of survival for these patients, as we would extend as much as possible the duration of endocrine therapy or oral medications for a disease that could be indolent. So I really feel that we as clinicians, we should have the freedom to consider single-agent hormonal therapy for a few patients.
Thank you. So let's go to the second hour case. So this is a short disease-free interval. She's young. She's with initially elevated bilirubin and liver trans enzymes, and that's true. She does not fulfill the criteria for right choice. But what would be your recommendation for first-line chemo or endocrine therapy and CDK4 inhibitors? I think that we have already answered. And if chemo is considered, which drug would you recommend? Mono, chemotherapy, or combo?
May I be provocative? She was HER2-low.
Could you speak a little bit louder?
Yes, sorry. I said she was HER2-low. To be honest, if I have access to T-DXd, I will use T-DXd. The response rate is so high, I will not discuss about any chemotherapy. Mm-hmm. But we don't have access to T-DXd. So then move to the second. But my message was, here what we want is clearly a huge response rate and a quick response. I will prefer to use T-DXd if it's available. But then move to chemo.
Yeah, I would agree. Now, we don't have T-DXd, nor SG. This is a primary resistant situation with very bad features. This patient will die in less than a year, for sure. So because she was quite resistant to taxanes, to anthracyclines. So what to do here? So I don't know, to be honest. I would like to see which is the levels of bilirubin and transaminitis at this time. I guess that even if they were lower, they might be in the range of 2 to 3 at least. So this is really difficult for me. So maybe I would explore weekly paclitaxel plus bevacizumab, or even pacli, carboplatin, and bevacizumab if available. If you don't have bevacizumab here, I don't know. I don't know, to be very honest. I don't know. I don't know, maybe, I don't know, maybe paclitaxel plus doxorubicin together in a weekly regimen, or maybe eribulin, one of those strategies, but I don't know.
Just one additional comment. The definition of disease-free interval means, because we are in the metastatic relapse, she was metastatic since the first day. We didn't see the mets. I don't discuss about if we use PET or not. I'm not discussing about that. It's micrometastatic disease. But that means that she had 18 months disease control in a metastatic situation. And this is from the end of the adjuvant trial until the relapse. So I do agree that I will use chemotherapy. However, it might be that we have some signals of some endocrine sensitivity. It's not an immediate relapse.
Okay, Otto, do you want to add something or not? So we are out of time.
Yeah, those cases are always challenging. We always get concerned when we see elevated bilirubin, and I don't think that there is any right or wrong answer here. There's a lot of variations when we see these patients in clinical practice. I have a similar patient recently for which I treated her with eribulin and as a way to rescue from like the liver dysfunction, which is a regimen that's well tolerated, and patients when are having a lot of symptoms from metastatic disease could be a good rescue option.
Okay, so what we have done, the first patient, she got letrozole. It was 5 years ago, so we have no CDK6/4 inhibitors. And the last checkup was in October 2024. She is in complete remission. She's, what Americans said, great. She's great. And I have a question for her. In this situation, suppose she continues letrozole without progressive disease, and adverse events emerge, joint pain, osteoporosis, angina, pectoris, etc., etc. So would you consider a treatment holiday for these patients? So I'm asking first Dr. Gligorov, because he had a lecture about the treatment holidays last year and at ABCS Consensus Conference.
She's in complete remission.
Yeah, it's incomplete. 5 years. Is it 5 years?
I mean, why not? Treatment holidays, it's a deal you have with the patients, to be honest, regarding the benefit of continuing and the side effects. So if the side effects are too important and she wants to have holidays, I will consider it, why not? But saying to her that clearly she's in a metastatic disease at that one moment, first we have to follow and to be sure that we'll not take any risk. But I'm not against the treatment holidays.
Okay, so maybe switch to tamoxifen if she had adverse
Nobody
events.
knows.
Okay, so we are proceeding with the second case. So what she got vinorelbine monotherapy, and from June 2023 to January 2024, so CT and MRI scans show that she had lowering her metastases in liver. Her labs are within normal limits, and now this is question 3. After disease stabilization, what would you recommend as maintenance therapy? Standard endocrine therapy, in her case it is GnRH analogs and aromatase inhibitors or something else, and or standard endocrine therapy plus CDK4/6 inhibitor.
Well, if she's Catholic, I would look at a miracle here, okay? So vinorelbine single agent, a partial response in this patient population, is it a real case or not?
Real.
Really?
Real case,
Really?
yes. She's
So
real
next
case.
patient like
She's
this,
coming to me.
I will send her to you, clearly. So, no, the question is very well taken. We do not have any data at all to give endocrine therapy as a maintenance after chemotherapy, but that's something that we do in the clinical practice. My comment here, if she's doing so great with vinorelbine, I would not stop vinorelbine. Vinorelbine, you can give it even an oral drug.
But she doesn't want.
She doesn't want, okay. So, yeah, I think that, in my opinion, I would continue with analogs, like IA, and I would add CDK4 and 6 inhibitors. No data at all, but that's what I would do. And here, I would use ribociclib.
Others in the panel? So CDK4 inhibitors plus endocrine therapy. Is this the consensus here or not?
I would also use CDK inhibitor.
CDK, yes. So what happens next? So maintenance, we gave her ribociclib, GnRH, and letrozole. So what? Last checkup was in October 2024. So she's in PR in maintenance. So she's good. She's in ECOG1. I don't know. We are going on with the same therapy. Thank you very much. Now I give the microphone to my co-chair.
So now we will discuss the second line therapy for hormone receptor positive disease. So this is the patient, 63 years old, with primary metastatic disease. Initial workup at the diagnosis showed bone lesions with spinal cord compression at the level of 12th thoracic vertebra and 3 liver mets. Biopsy showed invasive ductal carcinoma, grade 2. Estrogen receptors were positive in 80% of tumor cells, progesterone receptors 50%, Ki67 20%, and HER2 status was negative, actually 1+. So she got palliative therapy with corticosteroids and analgesics, and she was irradiated on the affected thoracic spine. And she started with first-line therapy with letrozole ribociclib in December 2022. Time to response was 6 months, partial remission in liver mets and stable disease in a bone. And duration of response was 15 months, and after 21 months, disease progressed in bones, not in liver. So progression-free survival was actually similar as in clinical trials with CDK inhibitors in first line. So at the progression, she was tested for PIK3CA mutation, and this mutation was confirmed. And now the question, what would you recommend for second-line therapy? Alpelisib in combination with fulvestrant according to SOLAR-1 trial and BELIEVE trial. We know in clinical practice it is hard to treat patients with alpelisib, but anyway. So it's better option fulvestrant in combination with capivasertib or another options. Professor Gligorov?
Okay, we do not have access to alpelisib and capivasertib in France. I will use, since she's a pretty good responder to a first-line endocrine treatment, a second-line, and if I have access, to be honest, between alpelisib and capivasertib, I clearly do not know. I will probably use the first one that we will have, so because we don't have alpelisib, I will probably use capivasertib.
Dr. Metzger, in USA, what is the practice?
So this is one of the questions for which one could go either way, as we don't have a head-to-head comparison of these agents. My limited experience and my interpretation of the results from these clinical trials is that the capivasertib might be an agent that has a better toxicity profile. We've had a lot of issues with alpelisib in terms of toxicity, with hyperglycemia, skin toxicity. It's an agent that it's toxic, so I would consider capivasertib. I also acknowledge that for some patients, after a discussion, we occasionally consider Xeloda as an option. And the factors that I think that are important in deciding how much we're going to expect to benefit from in terms of endocrine sensitivity with targeted agents in the second line, the reality is that all the data that we have compares fulvestrant monotherapy plus these agents, and we see that these studies, despite being positive and despite beautiful science, is showing how we can revert endocrine resistance with PI3K, AKT inhibition. What you get in absolute terms, it's still far from ideal in terms of our ability to control the disease. While for the same population, we know that sometimes we put these patients on Xeloda, they tolerate better than the novel targeted agents, and they have disease control for a year or two. So, and I think that the factors that are more important to make this decision are the intervals and how much benefit patients had on prior endocrine therapies. Those are things that give us hints about how to go in terms of the choices. And so, but again, we don't have head-to-head comparison of these interventions, and it's not wrong to consider going back to a targeted agent after a prior exposure to Xeloda as well.
I have a question. Imagine. Now I'm calling you to use your imagination. You do not work in Spain. It does not work in France, and you do not work in the USA. You are working in Serbia. So you have a patients with the PIK3CA mutations. You do not have alpelisib. You don't have capivasertib. So what would you do? Fulvestrant or chemo?
Fulvestrant plus everolimus.
We do not have everolimus. Ha.
That's very nice to hear. So I think that first 3 answers here are good, all of them. Thanks for not including inavolisib there, because that would be even more difficult. So if you do not have alpelisib, you do not have capivasertib, you don't have everolimus, and you don't have inavolisib, capecitabine. That's what I would do.
Not fulvestrant as monotherapy?
Listen, fulvestrant as monotherapy is like
Second
water when you are hungry. So it works because the stomach, but no. I think that fulvestrant monotherapy, the median PFS today in this patient population is lower than 2 months.
Yeah,
So I think that CAPE is a very good drug in terms of toxicity. I would prefer, so it is well done, but I prefer CAPE, and maybe you can continue with fulvestrant afterwards. But fulvestrant single agent, I don't like at all, and more if you have a patient with a mutation in the PIK3CA pathway. That's my view. I don't know.
And how in patients with a shorter progression-free survival, a few months or 6 months, the decision is the same or maybe different?
So let me go back to the first question. If the disease, the progression-free survival is very prolonged and the amount of progressive disease is minimal, you could consider single-agent fulvestrant. If you have less than 6 months after CDK, I would take a biopsy first, always, because many of these patients will have very low ER, or maybe even triple negative. And that's something that we are seeing more and more. So if you have less than 6 months, definitely, I would never use monotherapy, monoendocrine therapy, never, in my opinion. If you have inavo or alpelisib or capiva, if the disease progression is not terrific, that's something you could consider, but only if it's not terrific and you continue to have high levels of ER.
So just let me be the devil's advocate here, and let's imagine if we have a patient who has been on hormonal therapy for a few years in the metastatic setting, the first line, progresses with bone-only disease, and what would you lose in trying fulvestrant as monotherapy for this patient, even if the patient has a short disease progression within a few months? And I'm saying this because in the past, and I was trained in Brazil where we didn't have access to many medications as well, we know that there is a small fraction of patients with ER-positive disease who do benefit from fulvestrant and can remain on fulvestrant for a long time. It's a minority of patients, and even after the CDK inhibitors, probably it's a smaller number. But when we look into all the second-line agents and we look into the curves for the monotherapy with fulvestrant, we see that there is a small percentage of patients who get into the tail of the curve, and they do well with fulvestrant. And what happens with fulvestrant, with or without the targeted agents, is that when we look into all these clinical trials, we start patients on second-line hormonal therapy, and you see a big drop in the Kaplan-Meier curves. There's a big fraction of patients that are not sensitive at all to endocrine manipulations. But my point is, given this is a disease with a longer natural history, I don't think that we lose or we do any harm to patients in trying a second line of hormonal therapy, even if the chances of failing are very high.
I think that 3 comments here. I think it is reasonable. So that's why I think that we have to smell the amount of progressive disease. Okay. Second, if you have a patient with bone progression in less than 6 months, careful, because maybe it could be the flare effect. Okay, and happens, and more with CDK4/6 inhibitors. But if you have a true progressive disease in 2, 3, 4 months after the start, I think that you're right. I mean, you have one new lung metastasis, 5 millimeters, but it's clear. Well, nothing to lose if you continue with fulvestrant. But the the best biomarker for response in the subsequent line of endocrine therapy is the response in the previous line. So I think these patients are very unlikely to respond, but you're right, nothing to lose. In 2 months or 3 months, you will start chemotherapy. It is reasonable.
I do agree. One more comment. There is another option that the biopsy, I do agree with you with the biopsy, it's using a TAP-FES. There are several data actually, particularly with fulvestrant, and the colleagues from Netherlands have demonstrated that one of the issues with fulvestrant is that we do not know what is the optimal dose to block the receptor. And they've made a wonderful work showing that you do a TAP-FES, you give, so then when the TAP-FES is negative, whatever you do, the endocrine treatment do not work. When the TAP-FES is positive and you give fulvestrant, you just repeat the FES. If it's still positive, then you increase the dose of fulvestrant and you will have potentially effect on the disease. So one of the issues of the fulvestrant is from a pharmacological point of view, we clearly do not know what is the optimal dosage. And this might be sometime an issue regarding the fact that we consider that the drug might not be effective, even the receptor are positive, because we are not on the optimal dosage that we need to give. But this is not done routinely in all centers.
Thank you for a really nice discussion. So we haven't time for a fourth case, so I must conclude.
That's great. No
yeah.
third question.
Yeah. I must conclude, and please come back in 10 minutes. Coffee break now. Thank you.
Kako? Pa dobro. Hoćemo li da krenemo? Okay, good afternoon. So thank you very much for staying with us. I know it was a long session, but it is very interesting, and really the panelists are the great. So I need to say, really, I'm very grateful for dedicating your time and staying with us. The panelists and coming here as well. I just hope that it's not too much cases for the morning. We are going to continue with metastatic triple-negative breast cancer, and today I'm presenting the presentation instead of Professor Oliviera Malfeda. She's from Barcelona, but she couldn't come, so I accepted to present cases about metastatic. So I'm not going to, again, represent the panelists. They're all known, well known, and you also know our dear colleague and friend, Professor Lazar Popovic. He's going to present cases along with myself. So this is basically the plan of my talk. I'm going to speak about the clinical things and clinical available drugs that we use in the clinical practice. And at the end of the session, we are going to have only 2 cases, not like Dr. Kashushniar 4, but only 2 cases. So, yes, and we all know that treating triple-negative breast cancer is really a hard job. So it is diverse disease, it is very heterogeneous, and you know that the recent, or let's say the research of the decades has focused on the extrinsic characteristic of the triple-negative breast cancer, and that has shown that it is really heterogeneous, and there is no perfect overlapping with immunohistochemical subtypes that we use in clinical practice. And then we also do know that some of the ER-positive metastatic breast cancer during the course of the disease will become triple-negative. However, we treat those patients as triple-negative regardless of the fact that the genomic profile of these patients is different. Then what we have learned in the recent years that thinking in more holistic way when we speak about triple-negative, we focus our research on extrinsic characteristic, not only intrinsic. And we realize that triple-negative in comparison with other subtypes has a more immune-enriched microenvironment, meaning higher T-cell infiltration, PDL expression, and tumor mutational burden. And we really exploited that in clinical trials. And today we have at least 2 positive clinical trials, which is IMPassion 130 and Keynote 355, proving that this hypothesis, meaning combining immunotherapy with chemotherapy, was very effective. So both trials have been positive, and they actually had a comparative arm, a chemotherapy. So this is the first-line metastatic triple-negative breast cancer. And then what we also have learned, that the best results were in the PD-L1 positive, that in the longer follow-up, only few patients had a long benefit, and we also have, let's say, the most validated only with few chemotherapy regimens. So here are the data from the Keynote 355 for our panelists, just to let him know that immunotherapy nowadays is available in Serbia. We can give immunotherapy Pembro, basically the Keynote 355 regimen only in the first line. And you can see here there is a difference in median progression-free survival, which is about 4 months and 7 months in overall survival. What else we have learned from the clinical trials? That immunotherapy is the most effective if you give early during the treatment. So the effect and the benefit later on is less obvious. Why is that? There is a couple of explanations. Maybe part of that is because immune activation decreases in metastatic disease if you compare with early disease. So here you will see that if you go through the course of the disease in metastatic setting, you will see that there is a lower antigen presentation, but then higher tumor clonality and heterogeneity. And then there is a lower immune enrichment microenvironment. And on the left side, you will see that we usually think about PD-L1 as a static, but it is not. PDL status can change as well. And here you can see that more PDL positive can become PDL negative, but vice versa is possible. So maybe we can speak with our panelists how often they test, because we have validated data only for the first line immunotherapy. Having said that, don't forget that in a Keynote 119 study, patients have been treated at least with 2 lines of chemotherapy, and they have been randomized between Pembro and chemotherapy. And then we saw some efficacy even in the later lines, but the CPS score, so Atezo and Pembro has a different antibody for the positivity and different cutoffs. But here, if you set up CPS score 20 or more, there is actually benefit, even in the overall survival. So maybe one of the questions would be, how often would you test for PDL positivity in the later lines, and would you offer immunotherapy also in the later lines? And preparing this presentation, I have realized that actually early relapsers in triple negative are not rare. We usually say, yeah, it is very bad situation, how to treat, but I didn't realize that about 50% of the patients we can consider as early relapsers. And the outcome of those patients is really bad. So the median progression-free survival is about 3 months and overall survival about 10 months. And even if you take a look on all triple-negative breast cancer, there is still really bad outcome. Let's say that a really small percentage of the patients will be treated after the 3rd or the 4th line. And more importantly, even if we take a look on the recent trials, those patients are not involved in the clinical trial, so we are not going to have data. How should we treat the 50% of the early relapsers of metastatic triple-negative breast cancer? The only trial where the inclusion of those patients is allowed is TROPION-Breast02, but the cap is about 20%. And if you take a look, I'm not going to list those trials, but you will see that at least they ask for disease-free interval at least of the 6 months. And in the last ESMO breast, we also had a privilege to see the results of the IMpassion 132. So this is the only trial which was designed for the early relapsers. So it means those patients who actually relapse within the 12 months from the curative setting, whatever was the last one, either the chemo or the surgery. So the patients, PD-L1 positive patients, have been randomized between chemotherapy plus atezolizumab, or just the chemotherapy arm, which is CarboGem or capecitabine. So we actually did participate in this clinical trial, and the primary endpoint was overall survival. So unfortunately, although my patients in that trial had a really long response, I was really thinking that the trial will be positive. Unfortunately, the results are negative. There is no difference in overall survival. So adding atezo to the chemo in early relapser did not change the outcome of the disease. So you can take a look, still median PFS is about 4 months, and then OS it is about 12 months. And you can take a look that the median age of those patients was 48. So it is really young population of patients. Majority had disease-free interval less than 6 months and have been treated with carbo. It's a carbo-gem combination. And if you take a look on the Keynote 355, for example, here you can also find patients who were early relapsers and who relapsed within 12 months from the previous curative treatment. And it seems that in that population of patients also Pembro did not bring the benefit. But here I would like to draw your attention on the fact that those patients that have been involved in the previous 2 trials did not receive all the drugs that they are going to receive today. So today, for example, we are going to treat triple-negative breast cancer with immunotherapy, neoadjuvant and then adjuvant. And in the case they have residual tumor burden, they will got capecitabine or olaparib in the scenario that they are germline BRCA positive. So we are already speaking about heavily pretreated patients. So what we are going to do when they relapse. And this is a beautiful review done by Italian colleagues, pointing out that we should consider early relapsers as a second-line treatment for whom we do not have data how to treat them. And then we already accepted many of those things listed here, that as whenever it is possible, we are going to do the biopsy, we are going to do the PD-L1 testing, BRCA also testing. But what is not clear, even we do have some data, should we consider ER low as a triple negative? We actually had on the last ESMO presentation about Promenade. So it is in the ER low giving immunotherapy, there is really a good benefit and high PCR equally with the triple negative. And the other thing which I would like also to discuss with our panelists, should we screen for the CNS metastasis? There is a difference between CNS metastasis in HER2-positive disease and the triple-negative disease. And now just I'm going through the trials landscape available in the triple-negative breast cancer. So the pivotal trial, ASCENT, is a phase 3 confirmatory study of sacituzumab govitecan, starting from the second line in metastatic triple-negative. So basically, you will see that the patients who have been involved, they had at least 2 lines, but also patients who relapse, like early relapsers within the 12 months, they could be actually included in the trial. So the randomization was between sacituzumab govitecan, that is the antibody-drug conjugate, and it is given 10 milligrams per kilo. It actually is given day 1, day 8, every 21 days, and then the treatment physician choice. And then the primary endpoint was PFS, and PFS for ITT population, and OS was the secondary endpoint. And just for the juniors, and I know that you probably heard a lot, and today are going to listen a lot about ADCs, but sacituzumab govitecan is the first in-class TROP2 directed antibody. Basically, this is the second generation of ADCs, and for the one molecule of the antibody, in this particular case, this is the TROP2 directed antibody, and TROP2 is a epithelial marker, which is highly expressed not only in the breast, but in the other solid tumors. So 8 molecules of the payload, which is basically chemotherapy, and in this particular case, this is SN30A payload, which is compound of irinotecan. 8 molecules of the payload are linked with 1 molecule of the antibody. So this is that antibody-drug ratio. For this particular drug, it's 7.6 to 1. And also, Professor Cortez actually gave us really next generation of the video, how actually ADCs are working, but this is really simplifying, and I think it is important, again, for juniors to take the note that what actually makes second generation of ADCs more potent in the comparison with the first one, it is that bystander effect. So you have like, ADCs are like targeted cytotoxic therapy. You have antigen, you have antibody that is going to be attached, you have internalization, transportation, degradation, then because this is the payload who is going to exert cytotoxic effect and apoptosis, and then usually there are liposoluble drugs that can actually be transported through the membrane, giving that bystander effect in the surroundings, including cells that do not express antigen. And going back to the study, ASCENT trial is positive trial. So you will see that, for example, sacituzumab in comparison with chemotherapy has difference delta, median progression-free survival, which is 4 months, and then about 6 months overall survival. And don't forget that that was a heavily pretreated population of patients. So here it is the median number of chemotherapy lines was 4. So it is really something that we haven't seen in clinical practice often, that we have difference in overall survival. And going back to the second line, because some of those patients, although this is a subgroup analysis, small number of patients and even smaller the early relapsers, but here you can see that even in the second line, sacituzumab govitecan works, but it doesn't mean that this is the highest level of evidence. And then also question how to choose between ADC, let's say in the perfect scenario that we have everything, should we use the level of expression of TROP2? You see here that sacituzumab govitecan works regardless of the expression, but the truth is that even if the TROP2 expression is higher, then the efficacy of the drug is better. And it is even in the high, medium, or low, sacituzumab is effective in comparison with chemotherapy in any of those subgroups. And the hot story, and you heard everything about the HER2 low and during the HER2 session, but that story started to be very in the focus, let's say, and those HER2 negative, traditionally considered negative, now we can further divide to HER2 null or 0, and then HER2 low, which is HER2 1 plus and 2 plus, but without gene amplification. And even in those patients, ASCENT or sacituzumab govitecan works, but still this is subgroup analysis, not designed to answer this question, but at least we have some info. And nowadays we have ASCENT-03 moving sacituzumab govitecan to the first line. So those are patients first line, PD-L1 negative, could be PD-L1 positive if they receive immunotherapy in adjuvant setting, and then randomized between SACI-GOV and then treatment of the physician choice, and we will see about the data. What about the other ADCs? I mean, it is a long story. I will not have time to go through everything. Just to mention that sacituzumab tirumotecan is a drug with positive results and is registered in Asia. And the other one, datopotamab deruxtecan, all of 3 are actually TROP2-directed ADCs. All of them have as a payload a topoisomerase 1 inhibitor. What is the difference? The antibody-drug ratio. For example, it is the highest for sacituzumab govitecan, the lowest for dato, and then it is 4, but then you can take a look, there is a 5 days half-life of dato, and that actually requires to be given every 3 weeks. So there is a differences between them. And then datopotamab deruxtecan prove actually efficacy in the phase 1 trial with the heavily pretreated patients. This is like a platform trial which included a lot of different solid tumors, including triple negative. So what actually we can see here, this is a non-randomized trial proving only the efficacy in heavily pretreated triple negative breast cancer. The objective response rate is high. It is even higher in patients who did not receive topoisomerase inhibitors previously. Median duration of response is about 17 months, median progression-free survival 4.4, and then you have overall survival, which is 13.5 months. And then now, to confirm those results, we have ongoing TROPION-Breast02 results as a trial. As I previously mentioned, this is the trial in actually allowing to be included patients who are early relapsers, so the stratification will be done based on the time of the relapse. And basically, we have first-line PD-L1 negative. The randomization will be done between Dato-DXd and investigator choice of chemotherapy. And then going back again to the HER2 low, as I previously mentioned, why I'm saying about HER2 low in triple negative? Because 1/3 of those patients will have HER2 low expression. And why is that important? Because we have now drug, trastuzumab deruxtecan, again, second generation of ADC, having trastuzumab as a monoclonal antibody and having 8 molecules, again, of topoisomerase inhibitor, working similarly as I previously mentioned. But you also previously from Professor Cortez heard about Breast Destiny 04. So this is pivotal trial in actually introducing TDXD in clinical practice for HER2 low. So it is hormone receptor positive and hormone receptor negative. And if you take a look, the number of the patient, majority of the patients was hormone receptor positive. Only about 56 patients have been triple negative HER2 low. I'm saying that because we still need to take these results with caution. So the randomization was done between TDXD and treatment physician choice. And on the left side down, you will see the objective response rate between triple negative low and hormone receptor positive low was comparable. And on the right side, you see the results for hormone receptor positive, but take a look on the triple negative. 10% of the patients were triple negative. The results are even better in comparison with hormone receptor positive. So it is delta for median progression-free survival, 5.6, and about 10 months for the overall survival. And probably we should have one session just to speak about the ADCs. So those are all ADCs ongoing, and probably some of them will enter clinical practice. I'm just focusing your attention on the right side, the next generation ADCs. This is the story that is going to be developed. So we have like a dual payloads, we have a radio immunoconjugates and different combination, and I'm pretty much sure that some of them will enter clinical practice. And final part of my talk, I will speak about the combination because it looks very promising. So anti-PD-1 or anti-PD-L1 now to combine either with anti-angiogenic factors that unfortunately BEV is not allowed in Serbia. We do not have a good experience with anti-angiogenic factors, then with targeted therapy, PARP, or antibody-drug conjugates. What is the story behind to make a combination? And again, to make a long story short, just to tell you that we have antibody and payload, which is actually the cytotoxic drug. So this is the cell immune circle for the tumor cells. So they are going to exaggerate priming phase, making tumor more hot for the T cell infiltration, for dendritic cell, for natural killers, and making potentially synergistic effect with immunotherapy. So that is simplifying rational. I mean, immunotherapy is pretty much very complicated. So this is Begonia. This is a platform, let's say, first-line metastatic triple-negative breast cancer, regardless of the PD-L1 status, non-randomized, but you will see there is a lot of actually arms, and let's focus only on the 6th and 7th arm, because we have now data. For example, durvalumab combined with datopotamab deruxtecan in triple negative, where the objective response rate is 80%. And then we have also TDXD and durva in HER2 low metastatic triple negative, where the objective response rate is 57%. So those results are comparable with Destiny or even better with Destiny 04. On the last ESMO, also ESMO breast, we had, because this was non-randomized, and this is randomized, Morpheus is randomized clinical trial, now comparing sacituzumab govitecan ADC with immunotherapy and atezolizumab, comparing with, let's say, standard, so it is nab-paclitaxel and atezolizumab, and then you will see that there is a difference in objective response rate, and there is also, it is about the delta 17%, and there is a median progression-free survival about 12 months, so it is really impressive. And now we have a registration trial ongoing. So basically, again, to make a long story short, this is PD-L1 positive. It is allowed to receive immunotherapy in early setting because we do not have that data whether the immunotherapy is effective if it's given in early setting. And control arm is basically 355. So it is pembro chemo, and then the arm who is going to be in the clinical trial is datopotamab deruxtecan durva in TROPION-Breast05 or sacituzumab govitecan pembro in ASCENT-04. And we will see the results. So finally, just I'm not going through the data for PARP inhibitors. We do know Olympia, AD, and BRCA actually introduce olaparib, talazoparib, starting from the second line with a median progression-free survival about 4 to 5 months. My point here is that the combination, we wanted to combine PARP inhibitors with immunotherapy. Unfortunately, objective response rate and the benefit was very similar with the PARP monotherapy. And then finally, with anti-angiogenic factor, again, we know that from some subgroup analysis, the combining Bev with taxane, for example, even in the later lines, there is a difference in overall survival, which is about 10 months. Unfortunately, as I previously mentioned, Bev is not allowed in Serbia. We do not have much experience with the drug. And the rationale behind to combine anti-angiogenic chemotherapy and immunotherapy is, again, because anti-angiogenic factors, beside the fact that they can work through the VEGF, they also can increase immune response, and they can also normalize vasculature, making actually the T infiltration more possible. So on the last ESMO, we had also results coming from the B-specific antibodies, anti-PD-1, anti-PD-L1, and anti-VEGF in combination with paclitaxel or nab-paclitaxel with objective response rate higher than 70%, and this is also regardless of the PD-L1 status. And finally, I would like to conclude. So this is the algorithm that actually is from the Dana-Farber, so it's probably Otto is familiar with this one, how we treat triple-negative metastatic disease nowadays. So if the patient is PD-L1 positive, then we have data coming from Keynote and IMPassion, so it is the combination of chemotherapy and pembro. But if the patient and the tumor is a PD-L negative, then we have options chemo, or if there is a germline BRCA mutation, we can give OLA or talazoparib. Then I think the therapeutic options in the second line, not including those early relapsers, are more or less, it's maybe not hard, but because there is available ADCs, I hope in Serbia are not available, but we have some small experience. So we can choose between SASI or TDXD. So sacituzumab govitecan has a more validated data regarding the TDXD. We will see the results from the Breast Destiny 15. Then will be prospective trial giving the information about the TDXD in metastatic HER2 low. And then starting from the third line, then the things started to be complicated because even the real-world data has shown that the results, ADC after ADC, it's a not big deal, it's not very effective. So personally, for me, I would always go with clinical trial and maybe NGS to consider, again, clinical trial. And with this one, I would like to thank you. So, yes. I got the nice suggestion from Professor Cortez that we can open a little bit floor for the questions. Before going to the clinical cases, I'm going to present case for the metastatic triple negative, and Professor Popovic is going to present case for the early setting. So any burning question from the podium regarding the presentation or regarding anything from the triple negative breast cancer? Maybe they're going to be more inspired when we start with the clinical cases. No, but maybe the audience is a little bit tired. Anyway, so let's start with the clinical case. So all the cases are real clinical cases. So we have a young lady. She actually has a palpable mass in the breast. And then maybe I can also take a seat. Yes, maybe it's going to be easier. It's a young lady, 35 years old. She has a palpable tumor in the breast, and the biopsy was done. And she has a triple negative breast cancer, staged clinically as 3B. So she has a T3, N1, M0. The tumor is really large, 62 millimeters, and she has a clinically positive also lymph nodes. She started her treatment with neoadjuvant chemotherapy. She received 4 cycles of AC and Taxotere. This is usually that we give AC or EC and then taxane. So basically 8 cycles of the neoadjuvant chemotherapy, and for the fertility preservation she receives monthly triptorelin. And after 8 cycles, in the clinical situation that it was actually a partial response, she was operated, skin-sparing mastectomy was done, and sentinel lymph node biopsy. So she had significant residual tumor burden. The tumor in the breast was 35 millimeters, and out of 3, none of the lymph nodes was positive. And then she, at that time, I have 2 actually important information. First, at that time in Serbia, we didn't have immunotherapy. Nowadays is available for the neoadjuvant adjuvant. And we had also BRCA testing. So she's a BRCA1 mutation carrier. And then the tumor board actually have decided to continue treatment with the post-operative radiotherapy. And then she also received, because of the residual tumor disease, she receives for the 6 months capecitabine without any toxicity. At that time, again, we didn't have olaparib. She would be a candidate because of the Olympia, and she had significant residual disease after the neoadjuvant treatment. Nowadays, olaparib is available in Serbia. And we started with follow-up, and she was very motivated for the oocyte preservation. Since she had skin-sparing mastectomy, she was motivated for the secondary reconstruction, and then she did an MRI of the breast, and incidentally, the lung node was seen. So she didn't have any kind of the symptoms. This was incidental result. And then, of course, the staging was done, PET-CT was done, and then we saw multiple nodules in the lung and in the liver. She had some headaches and she had some dizziness, and that's why we did MRI of the brain. We do not work like a screening for the CNS metastasis. We did that because she complains. And then because the metastases were available for the biopsy that was done, ultrasound, leaded biopsy of the liver, and then we confirmed that it is metastasis from the breast, again triple negative with PDL CPS score, which is 8. For the juniors, actually the limit is 10 to give the chemotherapy, to give the immunotherapy. And then, again, at that time in Serbia, immunotherapy was not available. We decided to start it with GemCarbo. So I would like to discuss now with you whether this was a good decision. We have a young lady. She is a carrier of the BRCA1 mutation. She is an early relapser, so it is less than 1 year from the surgery. She had the previous therapy, AC, Taxotere, and capecitabine. We can consider even that she is already heavily pretreated. And then what would be the preferred option? I know that we do not have clinical data. We do not have data coming from the clinical trials, but that is what we have. And we, regardless of the clinical data, we should treat those patients in clinical practice. How would you think about, should you, for example, give doublet? Does she has really a tumor burden for the doublet? Or would you consider PARP inhibitors, taking into account that we do have all those sub-analyses that PARP, olaparib is more effective if you give early in the disease? Or would you consider sacituzumab govitecan? Of course, we are speaking now that in ideal scenario, that everything, for example, is available. So whoever wants to start, it's really... Maybe Lazar can also can add something, but feel free to comment, yeah. Or maybe for the audience as well, it's allowed.
So regarding the fact that you have biopsied the liver and the fact that she was totally asymptomatic,
Yes, she's asymptomatic.
I will probably consider PARP inhibitor as first line here.
I cannot hear you. Can you just...
I will consider PARP inhibitor as the first line treatment here.
PARP inhibitor, yeah. That would be... Yes?
Yeah. So, first of all, imagine that we have all drugs available, okay? Whatever we want to use. In my opinion, we could discuss if we would explore SP142 to see if this patient is candidate for atezolizumab or not, because there is about 25% of patients that could apply. That's something that I would consider with a CPS of 8. Clearly, with a CPS of 8, I would not give pembrolizumab. That's my first comment. My second comment, assuming that this is PD-L1 negative also for SP142, so no atezo. Atezo is not approved in the US, but it is in Europe. Okay? So assuming that no PD-L1 at all, I would agree with Joseph. I think that olaparib is a very reasonable approach. Moreover, in the subgroup analysis of the Olympiad study, in the first-line setting, we also improve survival. The point here is, if we believe that platinum compounds are inferior to olaparib, my answer is no. But the quality of life, the toxicity profile, may give us the opportunity to continue of olaparib until disease progression, something which is very difficult with platinum compounds. In the Brocade 3, it's very interesting to see when you compare paclitaxel and carboplatin with beliparib or placebo, when you are giving chemotherapy, the curves are identical. Why? Because platinum compounds behave as PARP inhibitors. But once you stop chemotherapy and continue with either placebo or beliparib, the curves are clearly different. So I think that the benefit of olaparib is that you can continue forever. So I would go for olaparib here.
Otto, do you want to comment?
Oh, I agree. I think that olaparib, the PARP inhibitor, is a very good choice here because it's an oral medication. Patient has no symptoms. So I would approach this the same way.
Okay, so then the next question is something that Professor already touched, but anyway, so we did, because this was approachable, so we actually make a biopsy of the liver. Would you consider, for example, if there is, let's assume that it's also approachable, some other tissue to test, knowing from some retrospective analysis that some tissues like lymph nodes or skin or lung, they have a higher expression of the PD-L1. So for example, if we receive, because this is also an important question, we receive CPS 8, and then we should convince others in the tumor board that we should do a biopsy again, and the surgeons are here also in the audience. Would you consider testing, for example, lung with a higher probability of the positivity? And I already mentioned here, should we, for example, because Lazar did also work about the antibodies and PDL positivity, we do know that there is no perfect overlapping if we use different antibodies. So I think this is really a nice scenario, although atezo is not available, it's not reimbursed. It is, I mean, it's registered in Serbia, but it's not reimbursed. Pembro is actually reimbursed.
Okay, so there are many questions with difficult answers. So the obvious answer is easy. Go always to the primary or to the lymph nodes because the possibility to have a high PD-L1 will be superior. Okay, that's good.
Sorry, just to clarify for the audience. So you would go first with the primary and then for the...
Wait. So from a theoretical point of view, you try to get the sample with the more chances for the PD-L1 to be positive. And this seems to be the primary, the skin or the lymph nodes. Now, it is clear that in the metastatic disease, you nicely presented before, the possibility to have a PD-L1 high expression is lower than in the primary tissue. And according to the Impulsion 130, it seems that doesn't matter if you look at the data in the primary, whatever. I partially disagree with that. What we do not know is what would happen if you have a PD-L1 positive in the primary and PD-L1 negative in the metastasis. That's something that has not been explored. So that's why I'm a little bit skeptical about that. In the meantime, without this data, I think it's reasonable to try to approach the primary tissue because we might have better choices to have. But again, I'm not sure if pembrolizumab or atezolizumab will work if in the metastasis you have PD-L1 negative, even though in the primary tissue it was PD-L1 positive. I think that's something we don't know. Second comment. I strongly believe, I am biased here, I was the PI of the Keynote 355, but I strongly believe that atezolizumab and pembrolizumab, in terms of activity, in the metastatic setting, are identical. When you look at the data, when you look at PFS in the PD-L1 positive population, the hazard ratio is identical. When you look at the overall survival in the PD-L1 positive population, the hazard ratio is identical. But it's true, when you design a clinical trial, it is not only important the drug, also the design. And Keynote 355, because we were the last ones, we amended the trial to go for the primary endpoint of overall survival only in the PD-L1 positive population. That's why the Keynote 355 was so positive in the overall survival endpoint, but not the Impulsion 130. So my last comment here, I feel comfortable with both, but I want to be honest here. I usually start with a 2-2-C3, but if negative, if I could have the opportunity to use Atezo, I would explore as well.
Yeah, that is a good point. Then let's move to the other question. Let's assume that this patient receives immunotherapy previously. She received a neoadjuvant immunotherapy and then adjuvant immunotherapy, and then assume that she is again PD-L1 positive. Would you consider, it's not only a question for you, it is also for the rest, would you consider giving again immunotherapy? Because we are going to be in that position. Now it's available in Serbia for both settings. Would you consider, so, for example, the time frames? For example, you are going to say, yes, if she's going to relapse within 12 months, I'm not going, but then, or would you consider maybe the level of expression?
Okay, for the three next questions, I will not make any comments. 2 comments here. There is a paper published in Cancer Discovery. In rats, no mice, rats, Spanish politicians, okay? Rats. Now, in that paper, you have 2 groups of treatments. The first one is rats with metastasis, and they gave immunotherapy. The second group of rats were treated with immunotherapy before. They stopped immunotherapy, they removed the tumor, they put the tumor again, and they restart immunotherapy afterwards. The data were much better for the rats that were treated with neoadjuvant immunotherapy before. They have metastasis, and they gave immunotherapy afterwards again. So here, we do not have this data. I think this is reasonable to do something that we do with other drugs. If the disease-free interval is higher than 1 year, I would retreat. If it is lower, I wouldn't.
Yeah, that is good.
I will not answer more questions for the next 5 minutes.
Yes, maybe, but this is important clinical question, so I would like to ask you, both of you, and maybe Lazar also, if he wants, or someone from the audience as well.
I have another question on this. If you don't have any biomarkers, you try DACO antibody, you try Ventana, primary tumor, this one, that one, you do not have germline BRCA. Are you using combination with bevacizumab now? Paclitaxel plus bevacizumab in first-line setting? Because there is actually a data in registrational trial for whole HER2 negative population, but in forest plot, very good benefit from. So you all do bevacizumab. It is very interesting. We are trying now to do that here in Serbia.
Maybe,
Yeah, we don't have bevacizumab approved in the US. My concern with the re-challenge of immunotherapy, it's more related to the potential toxicities that we see in a small percentage of these patients with checkpoint inhibitors. And just when I added that, we usually, in the US, we have one agent approved, so we do just one testing. But I think that as a comment with the checkpoint inhibitors, what is very frustrating in breast cancer is that we don't see much of the beautiful responses, complete responses, like the outstanding responses that we see in different diseases like melanoma, kidney cancer. And I think that what we're doing in terms of biomarker, it's very superficial. And so I hope that at some point we're going to do better with immunotherapy in breast cancer in general. And I do believe that immunotherapy in the early stage setting, it's a different story where we've done very well in triple negative, and I wouldn't be surprised if we eventually use checkpoint inhibitors for high-risk ER-positive disease as well. But in the metastatic setting, it's very frustrating to see how little we can gain in terms of absolute benefits for this population.
Yes,
just two small comments. One is that we usually, when we look at the curves, we look at the median PFS, median overall survival, etc. But with Pembro and Atezo, when you look at the curves, if you look at the right part, there is a small proportion of patients that have pretty long disease control and that might be considered as sensitive to immunotherapy. And we have not identified this subgroup of patients. There is a lot of work to do to just find who are the patients who, within a maintenance, will do well. But back to your question, I think what makes the difficulty of making decision here, if the patient is BRCA mutated, usually they respond very well to chemotherapy and also immunotherapy. And the point is that if she had a relapse, I will probably again discuss more the PARP inhibitor because she has a residual disease with chemotherapy and immune checkpoint therapy in the neoadjuvant setting, which is not unusual, but it's rare comparing to others that are not BRCA mutated.
Okay, so then we can continue. So she receives about 6 cycles of gem-carbo, and then she again had the same complaints. And we did again the MRI of the brain, and then we found MRI metastasis, the brain metastasis. So what we did, we actually, the stereotoxic radiotherapy was done. And the next question is also for you, what would be the next therapy option now? Because extracranial disease was under control. She does not have now anything. I mean, it's a stable, let's say, the liver and the lung. She only progressed in the CNS. How would you continue treatment now? Would you, for example, if the stereotoxic radiotherapy was done and then she's fine without symptoms, would you in any scenario consider to continue with the same therapy, for example, as we did in the HER2 positive, but HER2 positive is more like a targeted treatment, and here it's only chemotherapy. Would you consider now, for example, sacituzumab govitecan or PARP inhibition? So just briefly, she got Talzenna, and then I will give you, of course, for your opinion, but just to tell you that she got Talzenna, and she had a nice response, but basically here PARP inhibitor is more given like the maintenance. She already had stereotoxic radiotherapy, the response was good, and she got the Talzenna. And now, just briefly to present the data regarding the metastatic, because there is a lot of data regarding, for example, CNS metastasis in HER2 positive, but for the triple negative, we have modest benefit for the sacituzumab from the ASCENT trial. I don't know if you have, if you actually take a look on the presentation that Rupert Barch had on the ESMO about Tuxedo-2 trial, because this is the datopotamab deruxtecan after 4 cycles, and we see that there is really impressive result. And then also we have data regarding Talzenna that it is effective for the CNS metastasis. So now in the scenario that she does not have symptoms, the CNS metastases are under control, we gave Talzenna as a maintenance. Would you consider this point when the disease is outside of the brain stable to go, for example, with something else? Because now we have data for SATSI, maybe it's a small number of patients, but how would you consider, because this is really a scenario that we have in the clinical practice.
Well, I think that this patient, considering she had a BRCA mutation, switching her into a PARP inhibitor, it's probably appropriate. I don't know if it would be better than continuing on carboplatin. I think that the problem that we have with triple negative is that once we have CNS metastasis, the outcome of these patients, it's really very poor no matter what's done. These patients usually have additional progression within the CNS within a very short period with a deterioration of general health status to a pace where we don't have even time to try novel systemic therapies. And unfortunately, those are patients who do very poorly in general after the CNS relapse.
And if she, for example, progressed only in CNS and everything else is stable, would you again treat with, if possible, surgery because she had a surgery after and then again irradiate? Would you consider in that case that you already did a local treatment to change systemic? Outside of the brain, everything is fine. I mean, fine, it's not fine. There is disease, but it's not progressing. That is tricky how to, because she already had a couple of stereotoxic whole brain irradiation. She was operated. And she's very motivated, actually, for the treatment. So it's a...
Yeah, I think that our cases are very unique, and I don't think it would be unreasonable to consider switching a systemic therapy without evidence of disease progression outside the brain. And I think that the management has been correct in the sense that you're trying to optimize treatment with radiation, but if the patient is still in good general health status and you're still progressing the brain, a focus on a systemic therapy makes a lot of sense because you're trying to control a disease that's getting worse despite an optimal local radiation and surgical treatment.
There is actually a lot of questions for the discussion, and we should also give time to Lazar to present. Maybe some of those questions that you would like to address, maybe someone from the audience would like the answer of those questions. For me personally, it would be nice, but we will not have time to see how would you sequence, for example, or choose ADC if she's a HER2 low, or maybe would you consider if it's ER low to treat with immunotherapy? This is also a relevant question. We discuss a lot of at our clinic that we should give immunotherapy for ER low. But maybe again, I would like to ask Otto about this precision immunotherapy because it is a beautiful story. We do not think about that. I saw also beautiful data regarding giving immunotherapy in the early morning is more effective, not giving late afternoon. So I assume that at the Dana-Farber you have a lot of trials regarding macrobiota and diets and physical activity. Do you advise your patients anything on immunotherapy regarding those listed here?
No, unfortunately, I think that those things are still very early into research development and they are not in the clinical practice, even in clinical trials. So I think that we have this very comprehensive triple-negative program. We're collecting a lot of information from patients, including microbiota, diet, all those things, but no intervention. And I think we're a bit far from interventions in the clinical setting. You had another question that I think it's interesting about the HER2 low in triple-negative. This agent, trastuzumab deruxtecan, it's impressive in terms of activity, and I've had patients with leptomeningeal disease alive for more than a year on this medication. So whenever available, and for clinical situations where it's difficult, it's a medication that we should always try because it's when we use it, the chances of success is incredibly high in the CNS and outside the CNS.
Okay, now I think this is also a relevant question, but we have about 13 minutes to the end. Maybe just briefly to ask the panelists, because also this is the real case. The lady that has a triple-negative breast cancer, she progressed on the Taxotere, so she got 4AC and then progressed during neoadjuvant treatment. And then we did a test, and PDL is 10, and she receives GAM, Carbo, and Pembro. And after the initial response, actually the tumor was large, really. It is still large tumor, about 6-7 centimeters. We decided after 6 cycles of GEM Carbo to do the radiotherapy and Pembro. And after 2 months of the radiotherapy, she still has a huge tumor. So she's on the maintenance only Pembro. So how would you consider, for example, those complex cases should be? Because she's going, if we don't do something, she's going to progress. She, for the moment, does not have, distant metastases. Would you consider, for example, to add chemo or to change, to switch? Because we have a small experience with SASI and TDXD. So she has 3 lines of the chemotherapy and Pembro and radiotherapy as well. And there is still a big tumor. How would you consider in these, for example, cases? Would you consider to change therapy?
So I see this case in a way that's very similar to how we should approach a metastatic breast cancer, in the sense that I don't believe that taking this patient to the actual surgery is going to have a huge impact on her survival outcomes. So my inclination would be to continue with systemic therapies and as we do for metastatic setting, and use drugs when needed based on progression. Because if you have a patient with such a large volume of disease that you couldn't downstage to take to surgery, I think it's unlikely that you would be adding benefit by trying to change medications or add for a surgical outcome for a disease where the main concern is systemic.
Maybe question, the last question for the Professor Cortes. Would you consider here, because it is a large tumor, there is hypoxia, great hypoxia in the tumor after? Would you consider for this particular patient, for example, because it is still a large tumor with hypoxia, to give, for example, anti-angiogenic factor?
I love anti-angiogenic agents in TNBC. I love them. I have patients with very resistant disease to 2 or 3 lines of chemotherapy with a nice response to bevacizumab plus. So the answer is yes. But the question is, would I treat this patient with bevacizumab plus whatever, or would I treat this patient with an antibody drug conjugate? Okay? I would prefer antibody drug conjugates before. And the second comment is, if I have SG and TDXD, for me, TDXD always for ER positive, but in triple negative, in my opinion, we have many more data with SASI compared with TDXD. I think that both are reasonable, but we have a phase 3 greater than the other one. We have 58 patients. We should not forget. And the objective was exploratory in nature. It was not even a secondary objective. So in TNBC, I prefer SG. In ER positive, I prefer TDXD.
Thank you very much. We have a couple of more minutes, and Lazar will present the early case.
Thank you very much. The working title of the case is How to Treat Triple-Negative Breast Cancer with a Bit Older and a Bit Frail Patient. So this is a 70-year-old female. She had lump in left breast, and with mammography that was a 32 millimeters tumor. Breast ultrasound and MRI showed 30 millimeters of node negative, so radiologically and clinically node negative disease. We did a biopsy. It was invasive ductal carcinoma of grade 3, estrogen and progesterone 0, HER2 1+, Ki67 55%. CT and bone scan showed no distant metastases, but the patient had quite many comorbidities. She had Buerger disease, some kind of autoimmune disease, but 40 years ago and still in remission, so she was treated in her 30s. Type 2 diabetes on insulin, and peripheral vein disease, grade 1 with some skin lesions. Echo performance status 1, 120 kilos, so body mass index more than 30. She had very good still cardiac output of left ejection fraction of 60%. And in family history, it was a long time ago, in the beginning of 20th century, first half of 20th century, her grandmother died at the age of 55, and she had something on her bones, and mother died at age 60 from gynecological cancer. So that was the per-anamnesis. So the question is, I'm not sure she's fit enough for carboplatinum. She had a long time ago some kind of autoimmune disease. How to start the treatment in that patient? Is it classic Keynote 522? Is it modified? Should we use Pembro or should we use Carbo? She's a bit frail.
But she's obese as well.
Should we use surgery in front?
So, no surgery, clearly. Second, I would like to see the germline mutations here. Third, I think that we have the NeoPact, which is platinum compounds plus taxanes plus pembrolizumab with a very huge or very high PCR rate. So in my opinion, first, I don't know what the Buerger disease is. Buerger, it seems to me like hamburger, so I don't know what it is. I would ask someone else, but I don't know what it is. If it's an immune disease.
Yes, I checked the books. I checked the internal medicine books after the case.
So I have to, I would ask, I don't know. But let's assume that she does not have Buerger disease, okay? Because I don't know what it is. I have to ask my folks here. But in case I would be able to give immunotherapy, I would go for platinum for sure, weekly paclitaxel, and pembrolizumab. That is what I would do, followed by surgery. I wouldn't give anthracyclines, and let's see what happens. That's what I would do.
Dr. Metzer, do you agree with the carboplatinum and avoiding anthracyclines?
Yes, no, I totally agree with avoiding anthracyclines, and I think it's very hard when we're making decisions in terms of trying to define how frail a patient is. And the possibility of using immunotherapy with carboplatin and Taxotere based on the study that's available, I think that's the standard for patients who have contraindication to anthracyclines. For elderly patients, it's a very good clinical regimen. And I think that as a comment, and let's imagine if you as her clinician tells me, I don't think that she's eligible for immunotherapy, Taxotere is going to be very toxic, but I do want to use some chemotherapy for this patient. In that scenario, what I would use or consider for chemotherapy, this very old regimen, which is CMF, that we tend to use intravenously, and it does have a lot of the medications, the alkylating medications that are needed for triple negative. So it's not a new regimen, not a fancy regimen, but can also be used for frail patients. And I'm saying this because it tends to be very well tolerated.
For the first time, we have a disagreement here. It's great.
Yeah. And Joseph, when two people have disagreement, the third one decides. So.
I will give a third option that we sometimes use. We don't use the classical TC, which is with Taxotere and cyclophosphamide. I do agree that alkylating agents are crucial here in triple negative disease. So we use sometimes in elderly population and fairly weekly paclitaxel with oral cyclophosphamide every day at 50 milligrams. It's well tolerated, so it's another way to give the TC without using Taxotere, because Taxotere is too toxic at this age. The other point will be to discuss potentially, even sometimes, depends on the presentation, an upfront strategy if the patient is with surgery. Because if the patient is clearly considered not to be candidate to chemotherapy, that's the other point. I know that classically she's eligible for adjuvant after that, but if we consider that it's too risky, potentially it will be also this discussion with the patient to give just surgery and radiation therapy after that, and potentially then the oral CMF as a classical approach.
Yeah, one comment, because you said something important. So you know that TC 4 times or TC 6 times is widely used. So I have changed my Taxotere docetaxel administration, and I have transformed the docetaxel regimen by 3 weekly paclitaxel. So I never use TC. I use paclitaxel plus C. So paclitaxel, cyclophosphamide, pacli, and continue.
And Joseph, if you decide on neoadjuvant treatment, will you use Pembro with TC or no?
I mean, we are out of all, there is no demonstration, etc., etc. Why not? My opinion is that usually in the elderly population, the impact of the immune checkpoint therapy seems not to be equivalent regarding the efficacy. However, it might be considered. I will just try to discuss with my colleague from immunology and nephrology department to be sure that we don't take any risk about the Berger disease.
I will show you the fourth opinion. We started weekly paclitaxel with pembrolizumab, 12 weeks with 4 cycles of Pembro. Already responded after 6 weeks by ultrasound, and we usually test for BRCA mutation during neoadjuvant treatment because we have some waiting time. And we got actually BRCA1 mutation, older patient, and the result of neoadjuvant therapy after surgery is very small invasive cancer with no negative disease, with sentinel node 0 from 3, the same receptor status, HER2 0 this time, and a little bit lower Ki67. So 2 millimeters of tumor. How would you tailor the adjuvant treatment in this case?
No side effect during the treatment?
No side effect during
I mean, it's easier.
Pembro.
I will then, if she had well tolerated the Pembro, I will continue with the Pembro for one year total.
Javier.
Well, this RCB1, clearly. So she has very good opportunities to be cured. So I continue with Pembro, I agree. I prefer Pembro than olaparib here. But the question is if I would add CAPE or not, because CAPE is a very cheap drug. She's has a lot of comorbidities, maybe I will continue with pembrolizumab and that's it, maybe.
Otto, the Pembro or PARP? And you?
Honestly, I don't know. Probably because she's heavily, with comorbidities, she has a very good response. Probably would continue with Pembro, but honestly, I would think about olaparib because she's BRCA mutated. She has a residual disease, 2 millimeters. She sees only 6 cycles of paclitaxel, right? 6 application actually, like 2 cycles. Three applications is one.
She had 12 cycles.
She had.
But she responded already after 6 weeks on first checkup.
And she's still 120 kilograms.
Yes.
So I don't know what I'm doing with the dosage of an oral drug in this situation, to be honest. I mean, regarding the olaparib.
I don't know the data, but you see, we have data for the Taxotere that there is a lower efficacy in obese patients for Taxotere. But you see, she receives Pacli, it's effective even in the 120.
So, what we did, it doesn't work, so you won't see. I don't know why.
Maybe.
Huh? What is that? No, we did olaparib. We started last month olaparib actually. And we are out of time, but
Yes.
she will relapse, maybe not. And we already discussed that we are going to repeat immunotherapy probably. But the question is, theoretical one. We know the regimens with chemotherapy in Keynote 355. In that kind of frail patient, you decided to do Pembro. Will you ever do Pembro with capecitabine?
So this 2027, we are in 2024, so I would go for a CT scan every month to try to avoid this situation. No. So I would go for Pembro, clearly, with a CPS 10 or higher, and I would combine in this situation maybe with Abraxane, with nab-paclitaxel or with cisBRCA.
We do not have nab-paclitaxel registered.
cisBRCA.
It is registered, not in reimbursed.
No, not reimbursed, yes.
cisBRCA. So I would consider, again, paclitaxel, carboplatin weekly plus pembrolizumab. That's what I would do.
At that moment, we'll have results from a trial called REPARP when we re-challenge patients with PARP inhibitors.
Okay,
And a novel PARP inhibitor.
I think it is time to finish the session. Obviously, we have a lot of questions, but anyhow, we should deal with this in the clinical practice. And we should also base a little bit on the experience. So thank you very much for being with us. I hope that the session was interesting. I hope that it was not very tough for you. Thanks. Ja se zahvaljujem svima na pažnji. Ja bih voljela da vas pozovem sada na Rošov simpozijum. Biće jako interesantan, treba nam samo par minuta da postavimo slajdove, tako da ako neko baš mora da žuri, da izađe kratko i da se vrati. Hvala vam puno. Hoćemo li isto onako da stavimo da nam bude malo lakše za gledanje? Ovdje smo rekli.
Da, mogu samo da, pošto imamo i neki će ovako, neki će
Priča o lečenju HER2-pozitivnog karcinoma dojke počinje otkrićem značaja ekspresije HER2 receptora i signalnog puta koji aktivira. Priča o trastozumabu, leku kompanije Roche, počinje u ranim 90. godinama kada je pokazano da blokada HER2 receptora značajno produžava dužinu života ovih pacijentkinja. Mi u Institutu za onkologiju i radiologiju Srbije imali smo tu privilegiju da primjenimo trastuzumab pre više od četvrt veka i da vidimo kako se pred našim očima dešava nešto neverovatno. Pacijentkinje sa izuzetno lošom prognozom prevode se u grupu sa dobrom prognozom.
Savremeni princip lečenja HER2 pozitivnih karcinoma dojke donosi svevrsnu evoluciju u pristupu. I svaki naredni korak, počevši od razvoja mono preko anti-HER2 dualne terapije, odnosno blokade, rezultira novim ciljanim terapijama. Sve to deo svevrsnog kontinuiranog progresa, čiji smo svedoci, i u kom je savremena sistemska terapija, odnosno medicina, redefinisala način na koji se leče pacijentkinje sa karcinomom dojke. Postoje dokazi da patološki odgovor nije samo indikator trenutne efikasnosti terapije, već da je i on sasvim sigurno osnova za kreiranje novih strategija lečenja.
Dolaskom subkutanih formulacija leka imamo više vremena i energije da se posvetimo onome što je suštinski deo naše uloge, a to je pacijent, da pružimo negu i brigu pacijentima i podršku koja je od neprocenjive važnosti na njihovom putu kroz lečenje.
Očekivanja kako lekara, tako i pacijenata evoluirala su sa napretkom lečenja, pa se od novih terapija očekuje ne samo postizanje kontrole bolesti, već i produženje ukupnog preživljavanja uz očuvanje kvaliteta života i teži se personalizovanom pristupu lečenja. Put lečenja pacijenata sa HER2 pozitivnim karcinomom dojke od mračne prošlosti preko svetle sadašnjosti i obećavajuće budućnosti simbolizuje kako efikasne terapije transformišu biologiju tumora i koliko je važno ulaganje u klinička istraživanja. Sa druge strane, subkutani način primene lekova predstavlja simbol tihe revolucije, a svaka nova terapija za lečenje ranog karcinoma dojke je nova šansa za izlečenje ove ozbiljne bolesti.
Poverenje.
Ciljana terapija.
Biološka terapija.
Moderna onkologija.
Liderstvo.
Verni partneri.
Personalizovana medicina.
Profesionalizam.
Doslednost.
Budućnost.
Inovacije.
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 Hello, good afternoon. Thank you very much for coming to the symposium organized by the Roche. So this is actually a symposium dedicated to the HER2-positive early breast cancer. And yes, about the slides can go on. Okay, this one. Okay, thank you. So I'm very grateful for moderating this session, and today with me are our dear guest, distinguished Professor Cortez from Barcelona, my colleague Mariana Milović-Kovačević from the Institute for Oncology Serbia, and dear colleague Professor Lazar Popović. So this video that you have saw, it's really a great introduction to the story that we would like to share with you today. And this is basically Herena's story. Herena's story is a patient journey, patient of the people, of the women who had HER2-positive early breast cancer. So the study have been conducted in several centers in Serbia, and with me, Lazar and Mariana will present the main results. After the Herena story, Professor Javier Cortez will also present the data of the FAIRGAIN trial. FAIRGAIN trial is a very smart design. You will see why, because it is the design of the de-escalation of the treatment of the HER2-positive early breast cancer. And then finally, we will have about 15 minutes for the discussion, and I hope that we will have at least a couple of minutes again to open the podium for the questions. So to start about the Helena story, this is a real-world research of the treatment patterns in early HER2-positive breast cancer patients treated in Serbia and Montenegro. So this is a retrospective, multi-centric study of the patients who started their treatment between January and December 2022. As I previously mentioned, 5 centers in Serbia are involved. Those are the tertiary centers where actually the therapy, targeted therapy is given. And today we are not going to present results. We are not going to present results from the Montenegro. So this is the design of the study. 189 patients have been involved. The main inclusion criteria actually was to have pathologically confirmed HER2-positive breast cancer, and then to have patients with clinical stage 2 and 3 eligible to receive neoadjuvant chemotherapy and, of course, anti-HER2 therapy. So the primary objective of our study was to calculate the frequency of neoadjuvant treatment among those patients. And we also had a couple of secondary objectives. We wanted to see the percentage of pathological complete response, and then we wanted to see the type of the surgery that was done after the completion of neoadjuvant treatment, and we wanted to see the timelines during the neoadjuvant or adjuvant treatment. So the baseline characteristic of the patients were the following. The median age was 58. Only 1 male have been included, and then 68% was postmenopausal. 63% also had hormone receptor positivity, and if you take a look on the clinical stage, you will see that 2/3 of the patients actually have had a clinical stage 2. This is the main result of the trial. So the frequency of the neoadjuvant treatment initiation among patients with HER2-positive early breast cancer, stage 2 and stage 3 in Serbia is about 86.8%. So it is really an impressive result, although there is still space for improvement, meaning that 25, this is the absolute number of the patients, so 13.2 patients went on the upfront surgery. If you take a look on the right side, the surgery place, so those are the surgery including upfront surgery and surgery after neoadjuvant chemotherapy, you will see that majority of the cases, in about 80%, let's say, the patients have been operated in the tertiary center. And then we have secondary healthcare centers, 14%, and private hospital, which is 6.3%. And then, of course, if we take a look on the type of the upfront surgical procedures that has been done in the 25 patients, you will see that the majority of upfront surgery was done in 2A clinical stage. So those are the patients who might have, for example, 20-something millimeters tumor and then node negative. So 60% of them had actually 2A clinical stage. And then looking on the right side of the slide, you will see that among those patients from the clinical stage 2A, 57% went on the radical mastectomy. Speaking about the place where actually that was done, basically the upfront surgery was done in the secondary healthcare institutions, 56%, private hospital 20%, and tertiary hospital 24%. And again, the most common type of the surgery was mastectomy. That was done in 60%, basically without immediate reconstruction. And now I would like to ask Mariana to continue. Maybe you can stay. It's easier, just not whatever is easier for you, to present the PCR.
Maybe it's easier for me to be here. What I want to emphasize here that the most of our patients received all 8 cycles of neoadjuvant therapy, AC and THB, but 2 patients received only 4 cycles of THB. But you can see those 2 patients received and achieving pathological complete response. That means that really neoadjuvant HER2 blockade is the most important here. Also, what I want to say that in our study, 50% of patients achieved total pathological complete response, which is defined like absence of invasive cancer in breast and axillary nodes. And it is really very important. It is consistent with the literature data. Also, I want to say that our study have shown that there was statistically significant difference in achieving pathological complete response according to hormone receptor status and Ki-67 proliferative index. That means that those patients with ER and steroid receptor negative and K67 high proliferative index really were more likely to achieve pathological complete response compared to those with steroid receptor positive and K67 low. There was also no change in achieving pathological complete response according to clinical stage at presentation. Also, what is important here that in spite of the fact that there was a really high percent of pathological complete response, it is a much higher use of mastectomy over breast conserving surgery. But I must emphasize here, it is not radical mastectomy. Mostly it was subcutaneous mastectomy with primary reconstruction, so good cosmetic results. But what is the point here that the primary endpoint of neoadjuvant HER2 blockade is not just cosmetic results, it is achieving pathological complete response, disappearance of all tumor cells from circulation and having those long-term outcomes. And also you can see that almost all our patients received 4 cycles of neoadjuvant HER2 blockade. But patients who underwent upfront surgery received slightly more cycles of total anti-HER2 blockade. But average, it is approximately 16 cycles for our patients. And we really must do better. We really need to make a stride and effort to ensure that all our patients get 18 cycles and not instead of 16 cycles, and to ensure good and appropriate intervals within those cycles. But it is not easy. Median time from diagnosis to initiation of neoadjuvant treatment in our study was 5.28 weeks in Serbia. But our study has shown that there was a quite big difference, statistical significant, between those big cities, which is tertiary institutions, and those small cities, which is predominantly secondary centers. And we can see here that the time required from the diagnosis to tumor board decision was quite shorter in big cities compared to small cities, but those time required from tumor board decision to initiation of neoadjuvant therapy was much significantly higher in big cities than small cities. And it is easy to be explained because you all know that there is a high percentage of patients who are referred to tertiary centers, and we really make a quite big effort to ensure that all those patients receive and get right amount of cycles in the right and appropriate intervals, but it is not really easy because it is really quantity, very big burden. And we really need to do something about that through the process of decentralization, and we need to get better redistribution of our patients. Also, our study has shown that patients waited 5.43 weeks from surgery to after neoadjuvant treatment in Serbia, and median time from surgery to initiation of adjuvant treatment was 4.3 weeks. There was slightly more, like 7 days, like 1 week more time required for those patients from secondary centers, and it is easy to be explained like the administrative reasons. They need to go to local centers to obtain referral to tertiary centers. But what is the most important, my message from this part of lecture is that in tertiary centers we have so many patients that we are not capable to really obtain adequate therapy in adequate intervals, and we need decentralization as soon as possible. So I think Lazar will continue.
Ženski centar Milica je od septembra 2023. godine do februara 2024. godine sproveo anketu put pacijentkinje sa rakom dojke kroz zdravstveni sistem. Obuhvaćeno je bilo 834 žene obolele i lečene od raka dojke sa teritorije Srbije. Anketa je imala za cilj spoznati izazove sa kojima se pacijentkinje susreću prolaskom kroz zdravstveni sistem. Podatke smo prikupljali uglavnom online ili direktnim anketiranjem uz podršku zdravstvenih ustanova i instituta. Prosečna starost ispitanica u trenutku dijagnostikovanja karcinoma dojke bila je 47 godina. 63% žena pripadalo je grupi od 30 do 49 godina. 10% žena se izjasnilo da je prvo imala operaciju, pa je posle poslato na konzilijum, da o daljem lečenju odluči multidisciplinarni tim. Ono što je izuzetno važno jeste da kod 4,6% žena nisu prepoznate simptomi i nisu upućene na dalju dijagnostiku. U anketi 21% žena se izjasnilo da nije radio biopsiju pre lečenja, dok je 8,3% reklo da je na prvom konzilijumu određeno dalje lečenje bez biopsije. Što se tiče čekanja na lečenje, 10% ispitanica se izjasnilo da je čekalo na početak lečenja duže od 3 meseca, dok je 35% ispitanica reklo da je taj period bio od 1 do 3 meseca. Preko 45% žena putuje preko 50 km do svog referentnog centra da bi primilo terapiju, a od toga 22,7% putuje i duže od 100 km u jednom pravcu da bi primilo terapiju. Što se tiče kvaliteta života, 84% ispitanica se izjasnilo da je imalo izuzetno veliku opterećenost finansijsku tokom lečenja, dok je 23% žena moralo da prima neku vrstu pomoći podrške tokom lečenja da bi finansijski moglo da izdrži.
Hvala Vesna za ove rezultate. I will continue with our HERENA analysis and I will try to put in the context with all the other real-world data trials and classical randomized trials with the result of anti-HER2 therapy. And for the beginning, why we did it? Why we did HERENA trial? We know that from 10 or 15 years ago, when you have real-world data trial, all the journals said to you, we doesn't care. And nowadays, the real-world data is much, much more important. Even there are some journals, new journals, with receiving only real-world data papers. So, of course, when you want to register a drug, you have to have a head-to-head trial, or you have to do a little bit into more evidence with different trials showing similar or different results. You go to meta-analysis. But the problem of head-to-head trials or clinical trials that you have a huge list of inclusion, exclusion criteria, where all the patients with comorbidities, special situations like CNS metastases or bad laboratory values are not incorporated in this trial. So the problem of real-world data trials are few of them. Of course, we have heterogeneous population. We do not have intervention there. We have maybe even heterogeneous treatment options. But on the other side, we can do head-to-head comparison of the drugs like Palmares trials. We do not have head-to-head any data on CDK4/6 inhibitors. Now we have from Palmares. And we can do real-world data on CNS metastases, different patient population. And what is the very important, and why we did HERENA, to see where are we now with our data and how we are working and how we can improve. And I will go throughout the results. And first of all, very important result, only 30% of patients with stage 2 or stage 3 receive upfront surgery. So probably didn't go to a multidisciplinary team. And this is a result which is very good. I think it is very comparable to other Western Europe countries. So we have to be very proud on our multidisciplinary teams and decisions. And when we look at the other data, there is a elevation of utility of neoadjuvant treatment during the years, especially in HER2-positive disease and triple-negative disease. The problem is 20% of those 13%, so meaning around 2%, were stage 3 and receive upfront surgery for HER2-positive disease, so we have to improve this part. Are we doing better with survival if we start neoadjuvant treatment? We don't know, and we do not have data with the exception of this relatively small trial published in Frontiers of Oncology. This is retrospective analysis showing longer disease-free survival when we use first neoadjuvant versus only adjuvant treatment, but this is very, very small data. And what is also very important, and Mariana said about that, even we are obtaining PCR and we see that on radiology, that there is probably no tumor, still we are doing a lot of mastectomy. So we have translation from the goal of neoadjuvant treatment, from 80s or 90s, where we have inoperable tumor to make it operable, or very large tumor from mastectomy to some breast conserving surgery. Now we have very beautiful outcomes with subcutaneous mastectomies, with implants. And we have now other goals for neoadjuvant treatment to start systemic treatment for aggressive disease like HER2-positive or triple-negative disease, and of course, to tailor the treatment after the result of PCR and non-PCR. And if you look at the data from other trials, also there are a lot of mastectomies in the last few years. If you look at the data KEYNOTE-522 from triple-negative breast cancer, also there are no changing in mastectomy data. So this is very important, changing the goals of neoadjuvant treatment. What about PCR rates? We had 50% of PCR rates. Count on that we include around 63 or 64% of hormone receptor positive patients, and we have for those patients lower than 40% of PCR rate and almost 70% in hormone receptor negative. So if we compare with this registrational trial or those real-world data trial, I won't go into numbers, but we are here around the 50 to 60% of PCR rates, which is quite good. What about our timelines? The timelines is a little bit problem for those patients with small CVT. Also, Vesna discussed about how much time the patient needs to come to multidisciplinary team from a smaller city, which is very important, but still 5.2 weeks, what Italians said, not too bad. So 2 to 4 is better, but 1 week later, it is more or less okay. And also this is into a guideline timelines of 4 to 6 weeks within surgery to start adjuvant treatment. We are here around 5.4, so quite a good result. And also from those timelines, it's a little bit longer than other real-world data. Few weeks, probably with some postpones of cycles of therapy or something. It is a little bit problematic, but still we are around in few weeks for lasting of anti-HER2 therapy and whole procedure from the biopsy, surgery, and adjuvant treatment. So I think we are quite good at this. There is a place for improvement. PCR rates are quite good, so I think we are here in Serbia more than okay. Do you agree? So, would you like to introduce Javi?
Yeah, I already introduced Professor, but please, yes, you can take a podium. So now Professor Cortez, I hope that he's not exhausted so far, that he's going to present the FAIRGAIN trial, and you will see that it is very smart design how to de-escalate the treatment for the early HER2 positive. So, yeah, the podium is yours.
Great, thank you. Thank you very much. So, I will make many personal comments about this talk, which I think is interesting. It's interesting because what we are going to talk about today is something to de-escalate treatment, but also to de-escalate costs. Because if we gave trastuzumab pertuzumab for, let's say, 100 patients, if in 1/3 of them we are able to remove chemotherapy, this will have immediate consequences also in terms of the costs. So that's why this type of approaches, in my opinion, are also very interesting, because this will not increase a single dollar, single euro, single whatever the coin is, dinner. Okay, and lunch either. So, let's start. Some of the slides also were presented this morning, but we will spend a little bit more time. We were discussing before about breast conservative surgery, about those tumors which are very large. Again, for me, the most important reason to go for the neoadjuvant approach is to be able to give a second choice to the patients to be cured tomorrow. So today with TDM1, tomorrow TDM1 and maybe TDXD. So this is something very, very important. This is critical. My mother, she had a T1B and 0 ER negative, HER2 positive breast cancer. My mother. It was at 9 millimeters. I treated her with herceptin and pertuzumab. Without chemo. No PCR, by the way. And I gave TDM1 afterwards. Let's see what happens. But this is what I did. So, we were discussing about PCR. This is important in terms of the individual perspective. And there are ways to improve PCR, basically with double combination, with trastuzumab, pertuzumab, and chemotherapy. There is no question about that. So it is better or not adding pertuzumab? It is better. For everybody, just give me one reason not to give pertuzumab. I'm not talking about costs today. If we are talking about budget, that's another topic. Happy to discuss, but that's another topic. So it does not increase cardiotoxicity. It's exactly the same, the cardiotoxicity with trastuzumab or trastuzumab plus pertuzumab. The only aspect that is going to be increased is diarrhea. This is the only one, but not the others. Now, do we have biomarkers in the clinical practice from the prospective way? No. Easy. Easy. What about HER2-DX? Let's explore HER2-DX for a minute. So, I have 15 minutes because, a little bit more because they give me some time. So, the membrane receptor heterogeneity, that's something very important that we didn't pay enough attention. So, the heterogeneity belongs to three aspects. Biological heterogeneity is not the same ER negative HER2 positive compared with ER positive HER2 positive. That's the biological differences. And also, the PAM50 is not HER2 enriched or luminal B are different in terms of prognosis. I will make a comment in a minute. So there is another heterogeneity, which is spatial heterogeneity. I will make a comment in a minute. And finally, temporal heterogeneity. We have been discussing many times the plasticity of HER2 low, for example. Okay, so that's something that we should take into account. So this is a slide with different examples of spatial heterogeneity. We can see here some parts of these tumors are very, very intensive or intense in terms of the HER2 expression, and other parts of the same tumor are null for HER2 expression. So these are a spatial heterogeneity. And is it important? A lot. A lot. Look at this paper. Well, basically, if you have something heterogeneous and we go for anti-HER2 based therapy, what might happen is that the HER2 positive cells will disappear, the non-HER2 positive cells will not disappear, and that's something that has been evaluated prospectively. This is a paper by Otto Metzger, published in Cancer Discovery, and they gave TDM1 plus pertuzumab. TDM1 plus pertuzumab, 164 HER2 positive stage 2 or stage 3. Okay? If heterogeneity was observed, forget about the definition now. Pathological complete response, 0%. If no heterogeneity, 55%. Exactly the same data in the Christine study. Remember, Christine was a neoadjuvant phase 3 study, TCHP or TDM1P. Exactly the same. If heterogeneity, 0% pathological complete response. So my first comment is that maybe this is a very easy biomarker to be implemented in de-escalation strategies. My mother Sorry about my mother, poor mother. But when we went to surgery, she had a 4 millimeter residual disease. It was very heterogeneous. It was 4 millimeter, but it was very heterogeneous. Now, what have we learned from the PAN50 perspective? We have learned the following thing. First, HER2-enriched tumors are more sensitive to anti-HER2-based therapy. HER2-enriched tumors basically are those tumors where the signaling pathway downstream is upregulated. Second, the levels of HER2 provides an independent predictive information. So the higher levels of HER2, the higher chances to have pathological complete remission. Third, from the biological perspective, HER2-enriched tumors do have much worse prognosis compared with luminal-like tumors. From the biological perspective, another thing is if you treat these patients. That's another aspect. Last but not least, the immune infiltration provides an independent predictive and prognostic information. By the way, you can share my slides with all of you if you need it. Okay? I give my slides for you. Okay? So, Roche people, happy to do it. Alessandra, you can share with all of them the PPT, not the PDF, the PPT. You can play with that. By the way, thank you very much for the invitation to be here. So, now, what do we know? The more HER2-enriched patient population, the higher HER2 mRNA, the higher proliferation the tumor has, and the more immune infiltration, more pathological complete responses. And the other way around, the more luminal, the more low grade and lower risk in terms of proliferation, the lower PCR rates. And with this, some folks did a signature, and they consider the immune aspects, they consider the proliferation aspects, the luminal differentiation, and the HER2 amplification. They put everything in a box, they moved it, and they had a signature, which is called HER2-DX. Easy. Easy. Is Nobel Prize? No, it's easy. Easy. So which data do we have with HER2-DX? Basically, 3 data. The first one, the level of HER2. Is this interesting? That's fine. 2 important data. The probability to have PCR, high, medium, or low. And second, the prognosis, good prognosis or worst prognosis. These are the 2 pieces of information that might help us to decide, maybe, what to do. And I will give you some data. This is the APT, remember, trastuzumab and paclitaxel. And this is what they reported, very good long-term outcomes. This is the ATTEMPT study, TDM1 or TH, with very good outcome data. Now, when they integrated the data of HER2-DX, this is what they had. So if you give either paclitaxel trastuzumab or TDM1, and you have a good prognostic signature, the event-free survival is near 100%. If you have a worst prognostic signature, it is much lower. So it's nice. It's nice maybe to decide. For example, now imagine that you have a patient who is 35-year-old, and she got a 21 millimeter N0. TCH or TH? Maybe this is something that could help a little bit. And the other way around. This is a patient of, 25 millimeters, but she has 70 years old. Well, again, these are signatures that might help to make some decisions. Now, again, so this is to the biological perspective. Can we help or can we play with the biomarkers to make decisions? So many years ago, we were thinking about, we don't believe in biomarkers that much. Why? Imagine that you have a biomarker A. And with the biomarker A, you have 80% of responses, 20% of progressive disease. If you do not have the biomarker A, you have 20% of responses and 80% of progressive disease. You will say, easy, I would go for the biomarker. If the biomarker is there, I would go for the treatment. If the biomarker is not, I wouldn't go. What would happen if your mother, no mother-in-law, your mother, does not have the biomarker, but she's in those 20% of patients who can do a great response? They can miss a good opportunity. You agree with me? So which is the best biomarker? The patient. The patient. Why not to try the treatment to all of them and be able to explore the response very quickly? If it works, great. If it does not work, let's change the treatment. Do you understand what I'm saying? Of course, this could be even better if we combine both the patient with the biomarker. So this is what we did in FAIRGAIN. In FAIRGAIN, forget about Group A and Group C for now. Let's go to Group B. Stage 2 and Stage 3, the great majority of patients. You can see here that the tumor diameter was at least 1.5. Why? Because we wanted the tumor to be observed by a PET scan. Why did we choose a PET scan? Because it seems to be the more sensitive tool to explore early responses. Okay, I will make a comment about MRI in a minute. So, remember, Stage 2 and Stage 3. We gave, of course, HER2 positive, regardless estrogen receptor. So we gave trastuzumab and pertuzumab to all patients with no chemo. Okay? If ER positive, also endocrine treatment. If ER negative, trastu-pertu alone. 2 cycles. And we repeated the PET scan. If an objective response by PET scan, so it means that the tumor is doing well. I don't care if the tumor has PIK3CA, if the tumor is HER2-enriched, if the tumor is luminal A. I don't care. The tumor is going great. Let's continue with trastuzumab, pertuzumab. And the other way around. Yeah, HER2-enriched, MRI very high HER2, everything is great. Yeah, but the tumor is not responding. I don't care, the biomarker. The tumor is not responding. So then we continue with trastuzumab, pertuzumab, and chemotherapy. Agree? Now, surgery. If trastuzumab, pertuzumab, response, trastuzumab, pertuzumab, surgery, pathological complete remission, for the first time, we didn't give chemotherapy. They continue with trastuzumab, pertuzumab up to 1 year. If no pathological complete remission, chemotherapy, trastuzumab, pertuzumab. At this time, TDM1 was not, we didn't have the data of Catherine. Today, we would complement with Catherine. Now, nevertheless, if TCHP and PCR, HP. If TCHP and non-PCR, at this time, HP. Today, TDM1. Okay? So what does it mean? That there was 30% of patients, 30, who did stop, who start with trastuzumab, pertuzumab, response, and pathological complete remission. So 30% of these patients did never receive chemotherapy. Now, and this is very important, what we wanted to explore here is the strategy as a whole. How did these patients behave? All of them, regardless if they received chemotherapy or not. I don't care. So they start here. I don't care what they received. Which is the outcomes of all these patients. Do you understand this point? Because in many trials, they explore primary endpoint in the group of patients who did not receive chemotherapy. Imagine these are cured in 100%, but all of them 0%. That's not a good strategy. So all the patients, regardless if they receive chemotherapy or no, which is the outcome of the total population, which is the prognosis today with chemo, trastuzumab, pertuzumab, stage 2 and stage 3, 92%. 95%. You can say, well, yes, but by what? By what? So today, if you treat 100 patients with a Fergen strategy, 95% 3-year event-free survival. Well, 3-year event-free survival is not enough. Fuck. No? We all started to treat patients with stage 1 with Taxol, paclitaxel, and trastuzumab with a 3-year event-free survival. All of us. Nevertheless, the trial has been amended and will give the 5 and the 7 years. And now, what happened with this group of patients who did never receive chemotherapy? One local relapse. No metastasis at all. This is not a Kaplan-Meier curve. It's a Kaplan-Meier line. So, we analyze HER2-DX also here. And you can see here no events at all in the good prognostic patient population. We also compare breast MRI and PET scan. There is a bias here because the decision was based on PET scan. So if you had a PET response but not MRI response, we didn't change the treatment. And the other way around, if the PET scan was similar, even if you had a great MRI response, we gave chemotherapy. But nevertheless, look at here the event-free survival after 3 years. It seems to be even better with MRI. We have implemented the Fergain with MRI because it's easier and cheaper. Now, it was published in Lancet, and now we are running Fergain 2. Fergain 2 will be probably presented next year. This is stage 1, and up to 25 millimeters, N0. Same strategy, trastuzumab, pertuzumab. If PCR, trastuzumab, pertuzumab. If no PCR, TDM1. If no PCR and node positive, then chemo. Trastu, pertu, followed by TDM1. Is this recorded or not? No. No recorded? Yes? Great data. Amazing. I think that the number of patients who have received chemotherapy in this 400 patient population, I think was 4. We are going to cure these patients without chemotherapy. This is my presentation this morning, remember? But I just want to conclude with this. Maybe we have to start thinking about the patient, not the tumor, the patient, and maybe the tumor together for the best strategy. So I would like to stop here and happy to ask any questions. Thank you.
Thank you very much, Professor Cortes. This was really great story, and this is something that should be like a more precision clinical trials, how to really get the patients that they're going to have the best result. So maybe to go back to the clinical practice, you mentioned the story about your mother and how she was treated, and then you mentioned that instead there is a, let's say, comparability between PET-CT and MRI, and the results are even better with MRI. So as I understand that nowadays you use this strategy in the clinical practice, but instead of PET-CT, you use MRI, right?
Okay, so the
It's
answer is no broadly.
No broadly.
For example, for stage 3, I never use the Fergain.
Yeah.
I go for classical TCHP.
What is the limit?
But it depends. I mean, I think this is a face-to-face discussion.
Mm-hmm.
But for patients with small tumors, I would say T1C or T2N0, that's something I have started to do. Okay. And patients are, of course, absolutely happy. The insurances don't care, because they will pay even less. So that's something I have started to implement. I have treated last year So for you to know, about 4 or 5 patients. So not for everybody, but for some patients, why not?
Yeah, for the Center of Excellence, because I assume that it is logistically very complex. You should have a radiologist who are very keen, to do that, and then, I don't know, maybe, is it financially, but you have 2 points of them at the beginning, then after 2 weeks, and then after...
No. After, at the very beginning, after 2 cycles. So
2
6
cycles,
weeks.
and then after 8 cycles total. So it is 3, more or less. If we start with neoadjuvant treatment, we have baseline before the surgery, and then maybe it's not very logistically demanded. So yeah, that sounds very good. And just to ask Professor Lazar as well, what is your impression about the fair gain? Because here in Serbia, we still, I think, a little bit overtreat the small tumors. We did not broadly accepted ATP, for example, so we still see AC, but then taxane, for example, for the T3, up to T3, and then node negative. So Lazar, tell me, are you enthusiastic regarding those results? For example, is it possible to think about, because this is something at the beginning, that we at one point might consider this fair gain strategy in Serbia, and what would be the challenges?
Yes, when I discussed a few months ago with those girls in front, they told me Professor Cortez will come.
How lucky you are.
Yeah.
And I have to discuss with ugly men, but that's fine.
We discussed what would be the topic for Professor Cortez. And I said, like this, fair gain. We know everything about affinity, we know everything about Catherine, and you all heard about now about fair gain, which is a great trial, and all the trials from MedSeer are actually great. I have luck to cooperate with the boys and girls from MedSeer, but this is top of the top, and I think this is very important. This is the best way to de-escalate therapy. We had experience with, I don't know, shortening anti-HER2 treatment with Persephone or short hair. This is the way of negative trial for not de-escalating, but what is the most important, which is chemotherapy. We are trying biomarkers with HER2-DX, but this is, I think, the best way to de-escalate anti-HER2 treatment. So the problem in Serbia only would
This
be a
is the
PET
best
CT, but
control strategy. You cannot make mistake.
You control
That
everything.
is my impression.
The point with this type of strategies is that you know what to do all the time.
Yeah.
So, for example, there are great studies with paclitaxel, trastuzumab, and pertuzumab. Very good strategies. So now imagine there is an ongoing clinical trial by the EORTC, which is doing with the HER2-DX, they go for paclitaxel, trastuzumab, and pertuzumab. And they might achieve a 80% PCR. Fantastic. Now, what will we do if we do not have PCR? Tell me.
In Serbia?
No. I mean, in that trial,
in
you
the
go
trial,
for
it's a problematic,
PCR,
yeah.
80%. So the trial will be positive, 80%. We are very happy. Okay, fine. You know what to do with this 20%. But you have 20% of patients who receive paclitaxel, trastuzumab, pertuzumab, no PCR. My question is, okay, you build and study how to move forward afterwards. Now what? You don't have PCR. Anthracyclines, TD1, Trastu-Pertu. So my point is that we have to design a whole strategy for the patients. It is not only about the primary endpoint has to be in one part of the study. No. The primary endpoint has to be in the total population, because if one part of the study is great, but the other one behaves very badly, the study can never be positive, even if this part was very good. Do you know what I mean?
Yeah.
So that's why I think that we have to build studies thinking about how the 100% of patients will behave. Not how about the 20% or 30% or 50%. That's a big mistake, in my opinion, when designing clinical trials.
And I completely agree, because your strategy is good, because on those couple of time points, you are going to control for that mistake. For example, he's not going to respond. You're trying at least to get, the better response. Someone is not responding, you will
and you know how to move forward. So you don't have a PCR. If you do the fair gain, okay, so continue with TCHP.
Yeah.
Now, I would incorporate TDM1, clearly. But that's something that was not available here. Yeah. So the point is that we have to, when we are in the clinic, we have to understand what to do with the patient if we are applying a clinical study. That's why I think that the biomarker studies are not perfect, in my opinion.
Yeah, that is a complex story. But let's go to the real clinical practice, to the Hirena story, because I wanted to comment with you. I'm really satisfied with the results, because I was thinking that we probably will, introduce the upfront surgery in a higher percentage of patients. But obviously, because, we had not only education, but we have available drugs as well. So it seems that actually that story really works in Serbia. So majority, 87%, went to the neoadjuvant. And I assume we always have those patients, for example, in clinical practice, not motivated with neo. They would like to, I'm not speaking about that stage 3. I'm speaking about, those like, borderline, let's say, cases. So I think 13% is not the bad percentage for upfront surgery. Maybe there is a space for the improvement, but it's not bad.
No, I think the ARENA study is terrific. It's very well performed. It's a huge effort with very good data. I have only 2 comments here.
Yeah.
Okay? Yeah. The first one is you have 50% PCR. We have about 60-65%. Yeah. Of course, data are overlapping. My comment here is, are you sure that HER2 positive tumors were really HER2 positive tumors?
I think, of course, I can speak for my institute, but then I think we already had the quality controls with some pathologists outside of the Serbia. So it is really good quality of the, but yes.
But the reason is because we incorporate in that trial 65% on hormone receptor positive. And we have in hormone receptor negative 68% of PCR and around 40%. So this is the statistical reason, because we have more hormone receptor positive than usual real world data.
No, that's one reason for sure. But I look at the split. When you explore the PCR in the ER positive was 30 something, and in the ER negative was almost 70%. But it's true. Usually, sorry, I have a strong voice. Usually, the real world evidence data are worse compared with the pivotal trials.
Yeah, it's less control.
Of course.
And then you will see that.
And patients come with. That's clear. But I think that the data reflects what's happening in the clinical practice, which is very good.
I think the data good, taking into consideration that the oncology is very much centralized. So we have 5 centers in which we actually are giving anti-HER2 therapy. So it is overcrowded, a lot of patients, and probably that's why we have those timelines, because we are trying to make a decentralization, since we have secondary centers with very skilled oncologists.
I completely disagree. I think your timelines are terrifically great. If you go to Spain, I promise that all these timelines are much worse. I promise. No, I know that. So these timelines were terrific. Of course, if you go to the United States, you might say, well, it would be great to have 2 to 4 weeks. Yeah, it would be great to be millionaires. I know, but it is not possible. So these data, in my opinion, are very, very good. And which is more important, is not the time to start the treatment. It's after the surgery, the adjuvant setting.
Yeah.
And you have 4 weeks there. It's terrific. It's very good.
But the time to initiate neoadjuvant is a bit longer. That is the place that we can, waiting maybe for the pathology and things like that. But okay, there is a place. Especially why I'm saying that, for example, in Serbia, for the Fesgo that is available here, you should travel in one direction 300 kilometers just to get that subcutaneous injection and then to go back. It's 1 day. And then still you have, skilled medical oncologists in your center giving chemotherapy. I mean, I don't see the reason why we should do that. You're out of your work, someone is accompanying you, there is, financial, as we saw in the video. But then, yes, because we are a little bit running of time, but maybe there is a lunch, so we can, just a couple of questions. Can you share with us something which is very useful, like your experience from Spain, for example? What did you do to make that trip for the HER2 positive more easier, for example? So our idea is to make a decentralization, okay? But something that you can, for example, share with us what we can improve.
Okay. So first, one thing is the difficult surgeries, I don't know, a pancreatic cancer, whatever. But I think that, at least in Spain, the great majority of centers are able to treat patients with breast cancer. The great majority. I'm not talking about clinical trials. That's another point. Okay?
Are you satisfied with the number of the mastectomy?
But listen, I would like to explore in more depth what happened here, because there might be so many bias or so many aspects. When you look at the data, you make a great table. So in Spain, it was 65% 5%, 64% breast conservative surgery, but in the other two studies were very similar to yours. So I think that there are many aspects to be considered there. But I think that the treatment should be given not maybe in the big centers, could be given in different cities. Maybe you can discuss the centralized pathology report, maybe the surgery, but I think that giving TCHP or HP, I think that's something that could be given in different hospitals. At home, I don't think could be done for two reasons. The first one is that we need a nurse and a physician to be there. We don't have enough physicians in Spain, they're not here, but we don't have them. And second, don't forget that treatment is very well tolerated. Yes. But if something happens, it has to be administered in a hospital. So I think that my advice is administer in a hospital, small, large, or medium. I don't care.
Taking the drugs at home is really not at the moment the idea. It's just an idea to go because we did the not de-escalation but decentralization from the GI, and we actually saw that it works good. So that is the idea for the breast. And then I wanted to ask Mariana about the PCR. Professor Cortes already make a comment regarding the ER and positive and ER negative, but what is your impression about the PCR? Especially now in Serbia, we do have also Affinity, and we have Catherine now. So can you comment? And also we have FESGO. So your experience with new drugs. Yes.
Okay, thank you, Ivana. Actually, from June 2024, we have opportunity to give TDM1 also for residual tumors, so non-PCR, and it is absolutely something that we are waiting for a very long time because of exceptional results of CATHY study. And if our patients achieve pathological complete response, we continue with FESGO. And everything started few months ago, and our experiences are really great because we have opportunity to cure and to heal so many patients because FESGO lasts only 5 to 8 minutes, and before that we used biosimilars and intravenous combinations, and it was it required much more time. So now it's much better for our patients, but we also need to really do de-escalation and to do everything in our opportunity to make it possible for those patients to go to their centers and to receive FESGO because it is really easy administration. It's really is very good because save time and less burden for healthcare professionals. We don't see any reason that FESGO need to be administered only in tertiary centers. So we are very clear to persuade our fund, because there is no any reason, and they cannot find the reason to persuade us not to do de-escalation, because we started it with gastrointestinal tumors, and we will now continue with breast. So decentralization is our second step.
Thank you very much, Mariana. And also, I would like to ask you about the real-world data and real-world studies. So this is the study that we done relatively in short period of time. We was very keen to collect the data. It's probably like every real-world study, there is a biases and it's not perfect, but we actually learned a lot. This is the snapshot, those data, and those data are coming from the 2022, so 2 years ago. We will follow those data. But we do not have registries, for example, in Serbia, and those data coming from, studies like this are very important. So what is the situation in Spain regarding the registries, for example, because we don't know how many women live in Serbia with metastatic?
3 words. Exactly the same.
Exactly. This is really something that, can you imagine we discussed all morning about the different questions that we do not know the answer. Can you imagine having really stratified registry and then go there and see with the long follow-up? That would be my dream. But anyway, okay. And maybe if you have something to add before, I would like just a few words to comment the survey that comes from the patient and from the Milica Bond. She presented the survey which was conducted among patients. Okay, this is probably a biased survey because the median age was 47, so it might reflect the younger lady willing to participate. But anyhow, it gives us some answers. For me, for example, it is I don't know, I would like to hear you, because she said about 20% of the patients goes to the treatment without biopsy. Does that happen in Spain?
No.
No. That is something, for example, for the space for the improvement. Or speaking about decentralization, for example, I think I wrote it down, it is about 45% of the patients travels more than 50 kilometers, and then of them 22 travel more than 100 kilometers. That is the point when we speak with the authorities about decentralization. I mean, it's really...
That's something that also happens in Spain. I mean, 50 kilometers is not that much. We are thinking about Madrid, about Barcelona, and this is not the case.
Your country is big.
Well, good point, good point. But 50 kilometers, listen, is reasonable. Listen, we cannot put a hospital in all houses. This is not possible, okay? So what we have to do is maybe to help patients to arrive at the hospitals. I don't know how.
Yeah.
Maybe we can pay for the car, I don't know. But we cannot put a hospital in each. And I think that in Spain, we wanted to put hospitals everywhere. Listen, these are not mushrooms.
Not realistic.
And afterwards, we have more hospitals than physicians. And that happens in Spain. We have hospitals with no physicians, which is great. There are beds and nurses, no physicians.
Unfortunately, the same situation in Serbia regarding medical oncologists, but then we still don't have hospitals. So before the conclusions, anyone wants to comment anything shortly, just feel free, ask.
Yeah, I want to make a comment.
Yeah, please.
I want to thank Ross, and not only Ross, all pharmas, because you can imagine when the patient smiles and the patient is cured thanks to you. Patients are not cured thanks to physicians and are not cured thanks to the system, are cured thanks to your drugs. And so thanks a million, not of our behalf, on behalf of the patients, because many of them are cured thanks just to you. So thanks for that.
Thank you very much for that comment. My final comment is that, taking, all the survey and looking for the results, I can say that we really do a good job. It's maybe not great, but it is good job. And then the first point is that we should de-escalate, but for the moment, tertiary centers. And then in the tertiary centers to make possible to do smart strategies, as Professor said, about fair gain, and make really a centers of excellence. And then to have those registries and to be more clever and smart to prepare strategy for the treatment. And with this, I would like really to thank you. Thank you to the Roche for all support that actually they gave us during the study, during preparing this presentation. Thank you very much for your very supportive regarding education. I'm really grateful for that. Thank you, Professor, for having time. I know that it's a very busy schedule. So next time when we call you, I promise only one lecture. Thank you, Lazar and Mariana, and all the juniors that actually can help us to collect all the data. So let's see, maybe next year we will have something more. Thank you very much. Hoćemo naslovni slajd. Aha. Dobar dan svima. Vreme je da započnemo simpozijum koji organizuje AstraZeneca. Današnji simpozijum je posvećen jednom dobrom leku, vidjet ćete zašto to i kažem, to je Enhertu, trastuzumab deruxtecan, a cela priča će biti organizovana oko HER2 pozitivnog i danas smo dosta čuli HER2 low karcinoma dojke, govorimo o metastatskom karcinomu dojke. Sa mnom danas su i uvažene kolege i dragi prijatelji, počeši od profesorke Natalije Dedić-Plavetić, koja nam dolazi iz Zagreba, pa potom Simone Boršnar, profesorke iz Ljubljane i naš dragi kolega i prijatelj, profesor Lazar Popović. Na početku, samo jedan uvodni deo da se prisetimo, a mi koji smo već u onkologiji 20 i nešto godina, stvarno smo bili u situaciji da ispratimo ovu uspešnu priču vezanu za HER2 pozitivni karcinom dojke i ona negde kreće od 80. godina prošlog veka kada smo otkrili prvo gen, a potom otkrili taj čuveni protein, odnosno receptor koji se nalazi na površini ćelije. I onda već 98. a kod nas nešto malo kasnije, početkom 2000-ih, počinje da se primenjuje Herceptin, prvo, tako, Herceptin u kombinaciji sa hemioterapijom za lečenje metastatskog HER2 pozitivnog karcinoma dojke. Tu zaista se menja ceo ishod lečenja ove bolesti. Kasnije su se dodavali i druga monoklonska antitela, imamo tirozinkinazne inhibitore, ali suštinska promena, opet kao što je došla sa Herceptinom, dolazi sada sa ADC-evima. A danas smo opet čuli dosta o takozvanim antibody drug konjugatima ili konjugatima monoklonskih antitela i praktično citotoksičnog leka. Znači ono što smo rekli, kao da imate neku navođenu hemioterapiju, ciljanu hemioterapiju koja će se preko određenog receptora vezati i isporučiti taj payload ili citotoksični lek pravo u samu ćeliju. ADC-evi su promenili zaista suštinsko razmišljanje i danas smo više puta videli da će se različiti ADC-evi sa različitim payloadom i pojaviti i kroz istraživanje, kasnije kroz kliničku praksu. Ono što je važno to je da danas imamo već u vodičima, ne samo sacituzumab koji je prvi uveden u trostruko negativno, odnosno lečenje trostruko negativnog karcinoma dojke, već sada etablirani u drugoj i trećoj liniji TDXD za lečenje metastatskog HER2 pozitivnog karcinoma dojke i za lečenje HER2 low karcinoma dojke. Naravno da ovaj skup ne može da prođe da se još jednom ne prisetimo same strukture leka i da se podsjetimo da je to trastuzumab, da je za njega tim praktično klivabilnim linkerom vezan payload. Payload je inhibitor topizomeraze 1, da zaista ima dobar odnos, 8 molekula leka vezana za jedno monoklonsko antitelo. I ono što smo i danas pričali, a opet zaista simplifikovana verzija, oni su efikasni i efikasni od prve generacije, baš zato što imaju tu sposobnost da deluju van ćelije i na ćelije koje nemaju na sebi antigen. I da se podsjetimo, a vidjet ćemo danas i kroz priču koju će nam pričati profesor Lazar, mesto TDXD-a u trećoj liniji, pa onda profesorka Natalija u drugoj liniji, pa će onda i profesorka Simona pričati o mestu TDXD-a u lečenju HER2 low karcinoma dojke. Ono što ja želim da vam kažem u ovom uvodnom delu, to je da je lek registrovan u Srbiji januar ove godine, da su njegove indikacije praktično iste kao indikacije koje prističu iz tih pivotalnih studija. Prema tome, on jeste registrovan za drugu i treću liniju lečenja metastatskog HER2 pozitivnog karcinoma dojke i jeste registrovan za lečenje metastatskog HER2 low, znači radi se pre svega, videli smo danas i po rezultatima, hormon receptor pozitivni, trostruko negativni i to počevši već kod onih pacijenata koji su primili barem jednu liniju hemioterapije. I sa ovim bih završila ovaj uvodni deo i pozvala bih profesora Lazara da nam kaže nešto o mestu TDXD-a u trećoj liniji lečenja.
Hvala Ivana, hvala kompaniji AstraZeneca na pozivu. Pomenula si treću liniju. Mi u stvari u Srbiji ne možemo da damo u ovom momentu prema našim pravilnikom fonda ni treću liniju, nego su tu uglavnom četvrta i još kasnije linija, ali za razliku od većine lekova danas u onkologiji, mi nemamo nikakav dokaz da u šestoj liniji nešto radi, osim kod trastuzumaba deruxtekana, gde zaista postoji studija koja pokaže da kod veoma pretretiranih pacijenata, odnosno pacijentkinja, ovaj lek i dalje može da radi. Ja ću prikazati jedan slučaj iz naše kliničke prakse, to je mlada žena 77. godište koja je tokom 2017. godine lečena od rano HER2 pozitivnog karcinoma dojke, dobila je neadjuvantnu terapiju u to vreme samo sa trastuzumabom, antraciklinima i taksanima, imala je relativno loš patološki odgovor sa prisustvom jedne pozitivne limfnog čvora i dalje i posle operacije to je bio HER2 pozitivan tumor i naravno dobila 1 godinu trastuzumaba adjuvantno do aprila 2019. godine. U avgustu već 2019. godine dobija lentikularne metastaze, dobija kožnu limfangiozu, mi to bioptiramo i dobijamo da se radi o HER2 pozitivan karcinomu s ovog puta sa minimalnom ekspresijom estrogenskog receptora i krećemo sa klasičnim Kleopatra režimom u kombinaciji pertuzumab, trastuzumab i docetaxel, tu dajemo 4 ciklusa, već postižemo kompletan odgovor i nastavljamo samo sa kombinacijom dupla anti-HER2 blokade i dodajemo tamoksifen zbog tog nekog ERA5. 2021. godine dolazi do progresije i pojavljuje se u kontralateralnom pazuhu jedan limfni čvor koji je infiltrisan, njega bioptiramo i dobijamo da se radi ponovo HER2 pozitivnoj bolesti. U tom momentu krećemo TDM1, 12 ciklusa, maksimalno odgovor je bio kompletan odgovor, ali posle 12 ciklusa ponovo se javlja progresija. Ponovo se javljaju limfni čvorovi, suprainfraklavikularna progresija na koži i mi nastavljamo, imali smo već dovoljno biopsije, nismo dalje krenuli da bioptiramo, nastavljamo lapatinib i kapecitabin, već progresija nakon 4 ciklusa i onda u tom momentu nemamo šta da radimo, ajde da ponovimo nešto pre, krećemo ponovo antracikline, opet progresija, ajde da probam karboplatin, to se nekad daje kod HER2 pozitivne bolesti, opet progresija. I u šestoj liniji, u prvih 5 ili 6 ciklusa, pacijentkinja sama sebi kupuje trastuzumab deruxtekan, onda mi stavljamo, dolazi nam mogućnost za član 9 i ona je danas, posle 32 ciklusa, u kompletnom odgovoru. Kao što sam rekao na početku, jedan od retkih lekova koji ima dokazanu efikasnost i u veoma kasnim linijama je trastuzumab deruxtekan i ovo je studija Destiny Breast 1, koja je uključivala HER2 pozitivan karcinom dojke u veoma kasnim linijama. Faza je bila 2, odnosno jednograna studija i ovo su odgovori na terapiju. Kada pogledate ovaj plot, vidite da zaista većina pacijentkinja imala neki odgovor u veoma kasnoj liniji. Vreme do progresije bolesti 19 meseci, a vidjet ćete jedan sledeći slajd zašto je tih 19 meseci veoma interesantno i procenjeno ukupno preživljavanje je 2 godine. I onda ovaj najvažniji slajd. Ako se vratite istorijski unazad i pogledate studiju prve linije sa pertuzumabom, trastuzumabom i docetaxelom, dakle Kleopatra, da mi vidimo strašno dobre dugotrajne odgovore, srednje odgovor je 18 meseci. Ako pogledate Destiny 1 studiju, srednji odgovor, u prosečno pogledate 6. linija terapije, to je ovo ovde, a neke pacijentke su primali i 27 linija terapije prethodno, imate takođe nekih 19 meseci vremena do progresije bolesti, dakle, maltene mesec dana duže od prve linije. To se još, ne znam da li se nekad desilo u istoriji onkologije. Ta studija je bila osnova za studiju Destiny Breast 2 koja je prošla malo ispod radara, zato što je u isto vreme i objavljena Destiny Breast 3 koju će pričati Natalija. Ona je u stvari poredila u trećoj liniji lečenja trastuzumab deruxtekan sa treatment of physician choice, najčešće lapatinib sa kapecitabinom, nakon progresije na pertuzumab, trastuzumab i TDM1. I pokazala naravno duže vreme do progresije bolesti, ukupno preživljavanje. Dakle, ono što mi sad u Srbiji možemo da radimo su kasne linije sa trastuzumab deruxtekanom i zaista smo krenuli različite napore da dobijemo u optimalnom momentu, iako zaista i ovde imamo odlične rezultate i vodič praktično kaže da možete da koristite i u kasnim linijama, ali puno je bolje ako koristite naravno svaki lek ranije i o tome će nam pričati Natalija kako je u drugoj liniji i šta je pokazala studija Destiny 3. Hvala lepo.
Zaista, rezultati su impresivni. Natalija, izvoli, naravno, nego sam samo htjela da komentarišem da su rezultati impresivni u pretretiranoj populaciji, praktično medijana komparabilna sa prvom linijom I naravno kad su rezultati bili tako impresivni, onda iz Destiny Breast 02 pojavila se Breast Destiny 03 i ono što je za mene interesantno, nije prošlo 2 nedelje od objavljivanja rezultata, a vodiči su se već promenili. Tako da Natalija izvoli da nam kažeš te dobre rezultate.
Da, dugo smo čekali i mi ovu drugu liniju, a pogotovo što smo isprobali u kasnim linijama, pa smo bili dosta uvjereni u efikasnost ovog lijeka. Naime, naravno, nakon što je lijek se pokazao efikasnim u kasnim linijama, trebalo ga je u drugoj liniji usporediti sa standardom druge linije, iako naravno nisu tu svi pacijenti bili, ali druga linija. Ono što je važno reći da su ovdje pacijenti morali prethodno biti liječeni trastuzumabom i taksanom u metastatskom ili neoadjuvantnom settingu, ali naravno ove neoadjuvantno, oni koji su bili rani relapseri, ali su bili stratificirani prema tome da kakav im je osjetljivost hormonskih receptora, jesu li prethodno primili pertuzumab, jer nama se i dalje provlači jedan dio pacijenata u kliničkoj praksi koji su nama od prije ere pertuzumaba, ali to su oni sa dugim odgovorima i naravno nije svejedno randomizacija, stratifikacijski faktor tijekom randomizacije morao biti, jer su morale grane biti izbalansirane što se tiče visceralne zahvaćenosti. Znači stavili smo usporedbu staru generaciju ADC molekula s novom i randomizacija je bila 1:1, primarni cilj studije je bio PFS, ključni sekundarni cilj je bio ukupno preživljenje i sad imamo nekoliko još sekundarnih ciljeva, ukupna stopa odgovora, trajanje odgovora i naravno sigurnost. Ono što zapravo ne moramo sad nikome nešto posebno u ovoj prostoriji ko se ne bavi dojkom, pokazati da je jednostavno sigurno bila uključena i ukupno preživljenje. Mi u ukupnom preživljenju vidimo, znači za trećinu praktički 27% smanjenje rizika smrti ako koristimo TDXD nasuprot dosadašnjeg standarda TDM1, ovdje omjer rizika 0,73, još uvijek imamo nekakvih puno više smrtnih događaja u TDM1 grani nego u TDX grani. Sad, iako ovdje nemamo još statističku značajnost, ali jasno je da je. Ako pogledamo što se tiče toksičnosti, naravno što je Lazar pokazivao kada dajemo lijek u kasnim linijama kod nekog koji je imao od 2 do 27 prethodnih linija liječenja, jasno je da su ti pacijenti dolaze sa cijelim svojim teretom, cijelo breme i nuspojava tog liječenja, a i ono kad naučimo zapravo nešto o lijeku, kad imamo lijek u rukama smo puno oprezniji. I ovdje vidimo zapravo da ukupno gledamo, ako gledamo one neželjene učinke lijeka koji su vezane uz samo liječenje, da je njih otprilike gradusa 3 više jednako obje grane, ali se nešto malo ipak ova dva lijeka razlikuju. Ona trombocitopenija koja je nama bila problem kod TDM1, što dobro znamo, je sad recimo ovdje manje zastupljena, dočim je ovdje veća vjerojatnost neutropenije. Jednako tako ovo je lijek od kojeg je jako bitna prevencija mučnine, to je nešto što na pacijente trebamo upozoriti, jer pacijenti kad danas čuju da imaju moderan novi lijek koji je tek nekakva nova pametna terapija, očekuju da nema toksičnosti, jer to su nas naučili neki drugi biološki lijekovi, uvijek misle da će toksičnost biti manja. Ovdje ih nažalost moramo upozoriti da imamo veću učestalost gubitka kose i mučnine. Međutim, ono što je od posebnog interesa, ono što je bilo rezultiralo sa potencijalno smrtnim ishodima, srećom. Kada mi mislimo na pneumonitis, odnosno intersticijsku bolest pluća, kada educiramo liječnike da ga na vrijeme prepoznaju, odnosno bitno ga je zapravo uhvatiti kad on nije simptomatski, jer čim je i malo simptomatski, tu smo već u gradusu 2. Srećom, u ovoj studiji nije bilo toksičnosti gradusa 4 smrtnih od gradusa 5, što je zapravo dobro, iako je nama već gradus 2 razlog za prekid liječenja i to je tih ukupnih nekako 15% pneumonitisa, od čega moramo zapamtiti da je malo drugačije menadžeriranje nego pneumonitis uslijed imunoterapije. Naravno, zadnji slajd bi ostavila zapravo ovaj dijagram u obliku vodopada na neki način, što je jako važno vidjeti koliko smo mi jako ispod recista kad gledamo ukupan tumorski odgovor, što je jako bitno ako imamo veliki volumen bolesti, ako imamo nekakvu prijeteću visceralnu krizu, da mi znamo da se radi o lijeku koji će biti djelotvoran, koji je moćan. I ja moram reći da, osim što sam se uvjerila u kasnim linijama, srećom evo i sada, nakon što lijek imamo na listi u drugoj liniji na teret fonda posebno skupih lijekova i kasnije ga možemo dati u trećoj liniji eventualno na teret bolničkog proračuna, što također možemo, zapravo smo izuzetno zadovoljni. Evo.
Natalija, hvala ti puno. Mislim da je sada možda malo vreme da zastanemo, da zaokružimo ovu priču vezano za mesto Enhertovu HER2 pozitivnom metastatskom karcinomu dojke i odlično si ovo završila jer sam upravo to htjela da te pitam. S obzirom na to da je Lazar prikazao zaista impresivne rezultate vezano za ovaj case, a i opet impresivne rezultate za Brezesteni 0,1, znači baš pretretirana populacija pacijentkinja medijana prethodnih linija 6. Kod nas u Srbiji lek nije dostupan, mi ga dajemo po članu 9, znači imamo neko malo skromno iskustvo, pa sam htjela da te upravo to pitam tvoje, jer imaš, da kažem ti Simon, imate najviše iskustva vezano za primjenu leka, upravo efikasnost leka u tim kasnim linijama. To je za nas sada neki realni scenario, nadamo se da će, opet uzevši obzir odlične rezultate, da će biti brzo dostupan i u Srbiji. Kako bi rekla, znači što se tiče efikasnosti, ono što si ti vidjela u kliničkoj praksi kada si na početku, pre nego što će on doći na listu uopšte kod vas, kad si ga davala, jer su bili dobri rezultati?
Ja moram stvarno zahvaliti što su prije 2,5 godine omogućili zapravo pristup lijeka u kasnim linijama, morale su biti kasnije linije i mi smo, sjećam se tog popodneva, valjda imali smo 10 pacijenata za cijelu Hrvatsku, ja mislim da smo mi u našem centru brzo s nekog ručka poprijavljivali 5 tog trena. Od tih koje smo mi u prvoj rundi 5 prijavili, 2 primaju terapiju još uvijek. Nakon, znači sad su to 2 godine, znači one su uglavnom negdje krenule u kolovozu 22. Preko 2 godine one i dalje dobivaju lijek na, zapravo zahvaljujući ljubaznosti AstraZeneca u Hrvatskoj. Ono što moram reći da su te žene jako, jako zadovoljne i to su žene koje zapravo kažu mi uvijek vodimo isti razgovor. Šta ću ako ja progrediram? Onda mi uvijek kažemo uvijek će se nešto smisliti i ja mislim da činjenica da netko, one su 6., 7. linija, znači one su žene u 6., 7. liniji koje, jedna moja pacijentica, profesorica francuskog jezika u gimnaziji, svako ko ima tinejdžere zna koliko je teško raditi u gimnaziji, nakon što je dobila u 6. liniji Trastuzumab deruxtecan, ona se bojala meni priznati da se vratila raditi. Ja sam se opet užasnula, ali sam shvatila da je to nešto što nju motivira i pokreće. Znači, pazite, žena 6. liniji TDXD-a predaje gimnazijalcima francuskim. Lijek je stvarno moćan, ja to moram reći. Ona je čak imala jedan određen rizik da bude isključena s lijeka zbog pneumonitisa, zahvaljujući činjenici da se kod nas obavlja radioterapija privatno, pa su joj malo previše, ja zovem, popečatirali pluća u oba plućna krila, to svi znaju, i dobila je zapravo pneumonitis, ali koji smo mi onda nakon dugog razmatranja šta je moguće u dogovoru s njom zapravo pretpostavili, ali da je ipak bio izinduciran nečim što nije bilo indicirano, ali to je bilo zapravo zato što smo čekali lijek. Jel? Tako da, nažalost, pacijenti ako nemaju opcija, jel? To je, iskustvo je stvarno jako dobro.
U Hrvatskoj je on dostupan u 2. i 3. liniji. Možete ga davati kasnije.
Druga linija slobodno u svim bolnicama na način da je to iz Fonda za posebno skupe lijekove, kako mi inače svu inovativnu onkološku terapiju dobivamo na te takozvane naše PSL-ove. Ti naši PSL-ovi nose puno administracije, papirnate, ali su po svim, ajmo reći, dostupni su svim pacijentima po istim uvjetima, a mi smo se onako kao kliničari izborili kod naših šefova, jer mi možemo lijek koji je registriran u Europskoj uniji dati na teret bolničkog proračuna, onda smo rekli bolje da svaka bolnica da po nekoliko, nego da nam svi dolaze u jedan centar ako se pročuje da smo dali trećoj liniji, i to se dogodilo, jer zaista kako ćete vi sad pacijentu koji progredira na karcilu reći ja za vas nemam lijek? To je nešto što je apsolutno neetično.
Hvala ti, Natalija. Da iskoristim situaciju isto da pitam profesora Lazara, isto veoma impresivan case, znači ona je dobila treću liniju anti-HER2, a petu sistemsku, je li tako? Imala je impresivne odgovore i na prve dve linije jedino na kapecitabilni lapatinib slabo, tu je progredirala. Očigledno možda je taj podatak da je veliko, da kažem da je izrazita HER2 signalizacija, ona u petoj liniji zaista u kompletnom odgovoru. Činjenica da nema udaljene metastaze, ali ima kožne promjene, lokalni recidiv, tako da je stvarno impresivno. Znam da si davao, Lazare, TEDxD, možeš još nešto kratko da podeliš sa nama, neko tvoje iskustvo, utisci o efikasnosti?
Mi smo nekih 10 ili 12 pacijenti u kasnim linijama, znači četvrta linija anti-HER2 terapije, plus često i adjuvantna i neadjuvantna. I imamo nekoliko pacijentkinja sa dugim terapijskim odgovorima i stvarno je jako dobro što možemo da damo lek i u toj kasnoj liniji. Međutim, Natalija je ispričala rezultate, ono na čemu najviše sad treba da radimo i da dobijemo optimalni moment za taj lek. Lek koji 4 puta produži vreme do progresije bolesti u odnosu na standard of care koji nije loš, standard of care koji nije bio loš, je nešto što nam je prvi prioritet u raku dojke u sledećem periodu i mislim da već smo počeli i mislim da je to jako važno da imat ćemo i više iskustva i zaista na pravi način pomoći tim pacijentkama.
Odlično. Ja mislim da je sada vreme da krenemo u drugu priču za HER2 low. Ja bih molila Simonu da ona podeli iskustvo vezano za Enhertu, HER2 low metastatskom karcinomu dojke.
So I will describe the case of one patient of mine. So the story started actually almost 30 years ago. At that time, she was 49 years old, premenopausal, without comorbidities, and she presented with the 2 centimeter large tumor in the right breast. So fine needle biopsy confirmed adenocarcinoma, and she was operated in March 95, 3 decades ago, and the breast conserving surgery and dissection of axillary lymph nodes was provided, and pathological results showed mixed invasive carcinoma, cribriform and lobular, grade 1, with lymphovascular invasion, and positive estrogen and progesterone receptor. At that time, the hormone receptors were determined with biochemical method in tumor cytosol, and the limit for border for positivity was 10 picomole per milligram proteins. So later on, in this year, re-evaluation of this primary tumor was done, and results were actually similar. Estrogen receptor and progesterone receptor were positive in actually 100% of cells, and Ki67 was quite low, 5%, and HER2 status was 1+. And also, genotypization of the tumor was performed and showed PIK3CA mutation, no other mutation in the primary tumor. So at that time, this is 29 years ago, she was treated with adjuvant chemotherapy. I forgot, the 2 lymph nodes were positive. So she received adjuvant chemotherapy with cyclophosphamide, methotrexate, and PET5-fluorouracil. That was some of standard chemotherapy treatment at that time. So, and she continued with adjuvant hormonal therapy with tamoxifen. However, after 1 year, she declined the further hormonal therapy because of side effects. So, and 92 years later, at that time, this year, she was 77 years old. She became dyspnoic, very tired, and she lost 10 kilos in 3 months. This was almost 20% of her weight. And she was in performance too, with very low body mass index and bilateral pleural effusions. So radiologic exam showed retrosternal tumor mass 6 centimeter large and extensive pleural effusions and small thrombus in the one of veins. And bone scan didn't show any bone metastasis. Cytologic exam of pleural effusion showed some positivity of progesterone receptors in 30%, negative estrogen receptors, and negative HER2 status on cytospin. And also CT-guided biopsy of the mediastinal mass was performed and shows similar result with 20% of positive progesterone receptors. So because of this hormonal positivity of primary tumor and some hormonal positivity in metastasis, we decided to treat her with combination of letrozole and ribociclib, and she started with this treatment in January this year. So also of course, palliative treatment was introduced. She got pleural catheters, bilateral, and anticoagulant therapy, and also nutrition support. And after 12 weeks of the treatment, the first contour CT was performed. Performance status was the same, also pleural effusion. However, CT scan showed some regression of this large mediastinal mass, but progression in soft tissues on the left side of the thoracic wall. And CT showed also pericardial effusion. So again, we performed a biopsy of metastasis in thoracic wall, which showed completely negative hormonal receptors and HER2 status 2+. And Ki67 was 50%. Because of these triple negative features, we also determined immunomarkers, and we found actually positivity of PD-L1 on immune cells, more than 1%, and PD-L1 in this combined score was negative, less than 10. So we decided to treat her with combination of nab-paclitaxel and atezolizumab, and she started the treatment in April in this year. And response to therapy was again mixed. We found actually new infiltrate skin metastasis, quite large skin metastasis of the right side of the thoracic wall. However, a CT scan showed regression in mediastinal tumor mass, but progression in thoracic wall. And we stopped with this treatment with nab-paclitaxel and atezolizumab. And because of this heterogeneity of the tumor, but the main characteristic of HER2 low status, we decided to treat her with trastuzumab deruxtecan. Why with trastuzumab deruxtecan? On the basis of results of Destiny Breast 4 trial. In this trial, this drug was investigated in a patient treated with at least one line of chemotherapy and at least one line of hormonal therapy if tumor was hormone receptor positive. And patients were randomized to receive either chemotherapy of physician choice, capecitabine or eribulin or gemcitabine or called paclitaxel or nab-paclitaxel, or TDXD. Primary endpoint was progression-free survival in hormone receptor-positive disease, and secondary endpoint progression-free survival in all subtypes of tumor and also overall survival. So, and study was positive as in HER2 positive subtype, and the reduction of the risk of progression was 50%, and median progression-free survival was prolonged for 4.6 months. And also there was a 36% reduction of the risk of death and 6.6 months prolongation in median overall survival. So our patients started with trastuzumab deruxtecan in August 2024, this year. And response to therapy was quite significant. Actually, almost complete regression of all skin metastasis, which was erased from thoracic wall. And we removed thoracic catheters because there was no pleural effusion anymore, and we found also further regression in mediastinal mass, in actually complete remission of the thickness of thoracic wall seen before on CT. And also pericardial effusion was not seen anymore. And three weeks ago, she got 6 cycles of TDXD. She's now in better performance status 1. She gained in the weight, and body mass index is now improved from 19 to 22. And she actually is a normal daily active at the age of 77. So this was the story.
Hvala puno, Simona. Jako interesantan case, pokazuje koliko je u stvari bitno da svaki put radimo biopsiju ako je moguće. Ona je dobila i CDK4/6 inhibitore, pa nakon toga dobila imunoterapiju u drugoj liniji, pa onda ponovo, od hormon receptor pozitivnih do hormon receptor negativnih, HER2 se nekako kretao HER2-2, pa 1 plus i tako. I nekako mi se čini za HER2 pozitivnu bolest nam je potpuno jasno. Rezultati su stvarno jako ubedljivi, nemamo nekako dilemu da je TDX mesto mu je tu u drugoj liniji i verovatno kada budu rezultati Breast Destiny 09, verovatno će biti u prvoj liniji. Međutim, posebno mi koji nemamo iskustvo sa davanjem ADC-eva, recimo, a kod vas u Sloveniji je i dostupan sacituzumab govitecan, mi imamo za sada mnogo bolje rezultate za hormon receptor pozitivne tumore, jer imamo Breast Destiny 04 koja ima, koliko je to, skoro 90% pacijentkinja koje su hormon receptor pozitivne, pa onda imamo Breast Destiny 06 koja će pomeriti skroz, znači odmah će biti posle endokrine terapije, znači TDXD, ali za trostruko negativne videli smo rezultate 10%, pa onda recimo sad će biti Breast Destiny 15, gde ćemo imati sve hormon receptor negativne, pozitivne, pa i low i null. Moje pitanje tebi, prosto da znam ja sutra kada budem u toj situaciji, kako da biram u ovoj situaciji gde je ona od hormon receptor pozitivnog prešla u hormon receptor negativne, a opet ima HER2 low, kako si izabrali između sacituzumaba i deruxtekana? To je meni nekako klinički jako teško.
Dobro pitanje. Imamo mi i sacituzumab govitecan za trostruko negativni karcinom, ali ova histologija kod pacijentice je bila vrlo heterogena. Primarni tumor bio je vrlo hormonalno ovisan, a oni metastaze nekako malo, je bila sasvim negativna. Tako da zbog toga je u svih histologijama bilo je HER2 low, a ovi hormonalni receptori bili su ili nisu bili pozitivni, ja sam odlučila da bolje da dobije trastuzumab deruxtecan nego sacituzumab govitecan. Jer mi znamo da rezultati TROPiCS-1 su slabiji nego rezultati liječenja hormonalno pozitivne bolesti sa HER2 low statusom. Zbog toga.
A i stvarno jeste interesantan uopšte tok kretanja. Očigledno postoji taj dinamizam oko HER2. Pošto malo smo možda minut, dva probili vreme, ali ne mogu da vas ne pitam, mislim da je to isto važno za posebno Nataliju i tebe, Simona, zato što imate duže iskustvo nego mi, vezano upravo za toksičnost. Mi, Lazar ima iskustvo, mi smo lečili možda 10-ak, možda i manje pacijentkinja na institutu, nismo videli toksičnost u smislu pneumonitisa, ali nemamo ni jasno razvijen protokol za praćenje toksičnosti jer nemamo leka, pa onda sada stičemo neko iskustvo. Da li možete tako neke praktične stvari da podelite sa nama u smislu tog protokola praćenja toksičnosti? Da li postoji sad, recimo, da skener, svakako ga radite u procesu evaluacije na 3 meseca, da li nešto, da li spirometrija, da li raditi saturaciju, recimo, nešto što možda ranije može da otkrije taj potencijalno pneumonitis?
Prvo je razgovor sa pacijentom. Ja uvijek kažem da ako se nešto promijeni sa disanjem, da odmah dođu natrag. A drugo je, ja još uvijek radim prvi CT nakon 8 tjedna, ne nakon 12 tjedna, kada su na trastuzumab deruxtekanu. Sada, ja mislim da imam već više nego 25 pacijenta na trastuzumab deruxtekanu, većina od toga sa HER2-low bolešću, ne sa HER2 pozitivnom, zbog toga jer nemamo toliko progresa u HER2 pozitivnoj bolesti. Ja nemam još ni jednog pneumonitisa, kako moj pacijent.
Evo, imali smo pneumonitisa, ali stvar je u tome da zapravo sama činjenica, ovo što je Simona rekla, da radimo CT, da je vjerojatnost da ćemo onda uloviti pneumonitis prvog stupnja koji je asimptomatski, gdje ćemo onda napraviti pauzu i moći ćemo dati lijek ponovno, jako važna. Taj CT nama prvi je jako važan zapravo i da vidimo učinkovitost lijeka, a i drugo da ulovimo asimptomatski pneumonitis, jer nažalost, kod ovih koji su simptomatski. Druga stvar je ta edukacija svih liječnika. Mi smo radili edukaciju ljudi koji su dežurni specijalisti hitne medicine u onom objedinjenom bolničkom prijemu gdje ti pacijenti znaju doći vikendom, noću, svakako, to je bitno, edukacija radiologa. Čak je toliko, tako smo možda malo i pretjerali da su sad počeli pneumonitis vidjeti ono gdje ga i nema, ne recimo nekakav radijacijski pneumonitis koji je, znači postoji radijacijske promjene koje su bile i prije uvođenja terapije i sad čim znaju da su na tom lijeku, ali mislim da je uvijek bolje biti oprezan nego ne. Ali nekako smo sad i sa iskustvima da se zapravo uz terapiju povuku i naš neki prvi onaj strah je sada puno manje.
Ja mislim da smo obuhvatili u ovom kratkom vremenskom periodu bitne stvari. Ja želim da zaključim da zaista ispred nas imamo lek koji će po mom mišljenju ući u sve podtipove, karcinoma dojke, ono što je rekao i profesor Cortes, on je u HER2 tu, HER2 pozitivnom, pretpostavljam da će ući u prvu liniju, već je ušao praktično odmah posle hormonske terapije u hormoreceptor pozitivnom i ostaje samo da pokrijemo ovo polje trostruko negativnog da vidimo ove rezultate, ali zaista je lek moćan. A ono što je Lazar rekao, nama ostaje zaista da se borimo da dobijemo lek, jer je lek efikasan. Rezultati su toliko impresivni počevši od druge linije gde je zaista 4 puta bolji odgovor. Tako da nadam se da svi zajedno, na početku da steknemo ovo iskustvo preko člana 9, a kasnije da bude i na listi i da sledeće godine možda malo ili neke, možda previše optimistično, ali u nekoj narednoj godini da prikažemo i neke naša prva iskustva. Hvala puno kompaniji na pozivu, hvala puno i vama što ste bili sa nama. Ako ima baš neko kratko pitanje iz publike, ako nema, onda kolegi iz Novartisa sada pripremaju.
Nastavljamo dalje sa simpozijom kompanije Novartis. Pre nego što počnemo, zahvalio bi se na pozivu kompaniji i mi ćemo napraviti ovaj simpozijum u stvari ne kao klasična predavanja, nego kao jedan prolazak kroz case pacijenta koji je, odnosno pacijentkinje koja je dijagnostikovana davne 2014. godine, koja je lečena tad u ranoj fazi, potom lečena u metastatskoj fazi nešto kasnije i kako bi se to sve sad drugačije dešavalo ako je pacijentkinja dijagnostikovana danas. Sa mnom su doktorka Marijana Milović-Kovačević sa Instituta za onkologiju i radiologiju Srbije, docent Jan Cvetanović iz Univerzitetskog centra Niš. I za početak, ja ću vam prikazati prikaz te pacijentke, odnosno case report. To je pacijentka koja je 2014. godine imala 52 godine i dijagnostikovana je sa karcinomom leve dojke na mamografiji. Veličina tumora bila je oko 22 mm, aksilarni ultrazvuk bez suspektnih limfnih čvorova, urađena naravno kor biopsija, je bio invazivni duktalni karcinom gradusa 2, nuklearnog gradusa 2, sa visoko eksprimiranim estrogenom, progesteronom, HER2 0, Ki67 15%. U tom momentu multidisciplinarni tim je doneo odluku da se radi hirurgija. Urađena je poštedna operacija sa sentinel lymph node biopsijom i dobijeno da postoji jedan pozitivni limfni čvor. Nakon toga je odmah urađena i aksilarna disekcija, gde više nije nađen jedan limfni čvor pozitivan i finalna dijagnoza bila je duktalni invazivni karcinom dojke nuklearnog gradusa 2, hormon receptor pozitivan, HER2 negativan, 23 mm, jedna pozitivna od 18 limfnih čvorova, urađeni su CT pregledi i scintigrafija skeleta bez udaljenih metastaza i pacijentkinja nije imala nikakve komorbiditete. I lečena je 2014. godine ovako, dobila je 4 ciklusa AC hemioterapije, dobila je tamoksifen 2 godine, nakon toga je nastavljen anastrazol 3 godine, urađena je naravno zračna terapija i ona je hormonsku terapiju završila 2020. godine. 9 godina kasnije, dakle 3 godine nakon završetka kompletne endokrine terapije, ona se javlja na redovnu kontrolu, mamografija je uredna, ali donosi laboratorijske nalaze sa povišenim transaminazama. AST je 4 puta povišen, ALT je 3,5 puta povišen, alkalna fosfataza 1,5 puta povišena, hemoglobin minimalno niži, 115. I to nas je navelo da uradimo kompletan staging bolesti, urađen je i skener i viđene su naravno multiple jetrene metastaze, 30 metastaza izbora radiologa od 15 do 45 mm, naravno uz skok transaminaza, viđene su i metastaze u kostima, tumor marker CA15-3 bio je 268, urađena je biopsija tumora u jetri i dobijeno da se radi o sličnom tumoru, dakle, hormon receptor pozitivnog gradusa 2, ovog puta HER2 krst, ali sa nešto većim Ki67 od 35%. Moje pitanje sad je, pre svega za Anu, hoćemo se sad mi prestraviti ovim transaminazama i krenuti odmah s hemioterapijom 2023. godine ili imamo nešto možda bolje i efikasnije?
Dobar dan, dragi kolege i od mene. Nismo više tako plašljivi posle 2,5 godine upotrebe cikliba, mislim da smo se prilično opustili, ali ja ću vas podsjetiti i zašto. Znači, prikazat ću vam Right Choice studiju, podsjetit ću vas na nju, koja je uključila pre i perimenopauzne pacijentkinje koje su imale otprilike baš ovakvu bolest, znači jednu simptomatsku visceralnu bolest ili simptomatsku nevisceralnu bolest ili bolest sa rapidnom progresijom bolesti, performa statusa nižeg od 2 i totalnim bilirubinom koji je manji od 1,5 gornje granice i tu je jedna grana primala ribociklib sa letrozolom, enastrazolom i LHRH ukoliko je bilo potrebno, a kontrolna grana je zapravo primala hemioterapiju. Neki od navedenih režima, vidite, docetaxel sa kapecitabinom, paklitaxel i gemzer ili kapecitabin sa vinorelbinom. I primarni cilj studije jeste bilo vreme do progresije bolesti. Ako pogledate ove krivulje kako se razdvajaju, znači PFS interval je bio praktično dupliran u grupi pacijentkinja koja je primala CDK4/6 inhibitore, hazard ratio 0,54. Znači, zaista impresivni rezultati kod jedne ovako ozbiljne simptomatske, visceralne ili nevisceralne bolesti, znači agresivne bolesti i finalni rezultati su to i pokazali da je primarni cilj studije ispunjen, da su ove pacijentkinje značajno imalo i duže vreme do primene hemioterapije. Vidite, ovaj time to treatment failure je bio takođe dupliran, duže vreme do progresije bolesti i sličan response rate, a mnogo manje neželjenih efekata nego što bi imale sa primenom hemioterapije. Tako da, ako pogledamo ove rezultate, i na zadnjem ABC-u, koji je skoro publikovan, je zapravo glasalo se o tome da li se ovi rezultati mogu primeniti i kod postmenopauznih pacijentkinja, jer su right choice, kao što sam rekla na početku, uključene pre- i perimenopauzne pacijentkinje i ovde vidite da je 95% panela glasalo da se zapravo oni CDK4/6 inhibitori, odnosno ribociklib jeste terapija izbora i kod ovih pacijentkinja sa ovako agresivnom bolešću, a podsjetit ću vas i na ovu polovanu analizu Monaliza studija, Monalize 2, 3, 7 studija, upravo kod pacijentkinja sa visceralnim metastazama, sa metastazama na jetri i sa visceralnim metastazama i sa više od 3 metastatska mesta, gde vidite da zapravo u svim ispitivanim studijama i u svim subpopulacijama je benefit bio jako izražen u grupi pacijentkinja koje su primale ribociklib. Tako da nema sumnje da ovo jeste terapija izbora za ovu pacijentkinju, bez obzira na ovako agresivnu bolest. A Marijana će vam prikazati i Palmare studiju.
Kako ćemo sad u situaciji kad smo rešili da uzmemo CDK4/6 inhibitor sa hormonskom terapijom u odnosu na hemioterapiju, kako ćemo od 2 kod nas, a inače 3 mogući izabrati koji ćemo upotrebiti u ovakvoj situaciji?
Pa da vidimo, a? Pa, studija Palmares je zaista za nas jako značajna, to je multicentrična, populacijno bazirana studija koja je analizirala zapravo 1850 pacijentkinja iz 18 italijanskih centara u nekom 7-godišnjem periodu i probala da negde po prvi put zaista head to head poredi efikasnost palbocikliba, ribocikliba i abemacikliba u realnom kliničkom scenariju. I vidimo da negde u realnoj kliničkoj praksi abemacikliv je negde najčešće davan kod endokrino rezistentnih pacijenata, kod onih koji imaju niže vrednosti progesteronskih receptora, koji imaju jetrene metastaze, nešto ređe kod de novo bolesti, ali ono što je bio glavni cilj ove real world data studije je zapravo taj takozvani adjusted ili prilagođeni PFS u realnoj kliničkoj praksi, koji je zapravo u ovoj studiji iznosio 39,5 meseci. I ono što je studija definitivno pokazala, da su i abemacikliv u odnosu na palbociklib i ribociklib u odnosu na palbociklib pokazali značajno veću efikasnost, ali definitivno nije bilo razlike između abemacikliba i ribocikliba u pogledu efikasnosti, odnosno adjusted PFS je bio sličan. Međutim, ono što je jako važno za nas kliničare posebno je da su i abemacikliv i ribociklib bili značajno efikasniji kod luminal B-like tumora, kod endokrino rezistentnih i premenopauznih pacijentkinja. Abemacikliv je bio značajno efikasniji kod pacijenata sa lošijim ekog statusom, a ono što je važno da je abemacikliv ipak bio i od ribocikliba i od palbocikliba efikasniji kod de novo bolesti. Međutim, definitivno statistički signifikantnu razliku i preimущstvo su imali pacijenti sa ribociklibom kada su u pitanju bile metastaze u jetri. Pacijentkinja sa isključivo koštarnom bolešću i starija životna dob nije bila razlika koji ciklib se primjenjivao. Možemo reći da je Palmares studija zaista za nas kliničare značajna. Prvo, ona je jedna od najvećih studija. Drugo, jako veliku snagu ima i sasvim dugo praćenje. I apsolutno sada, kada ispred nas postoji pacijent sa određenom kliničkom slikom, bit će nam mnogo lakše da odaberemo, naravno vodit ćemo računa o safety profilu, o drug interakcijama, ali ja ako ispred sebe imam pacijenta sa metastazama u jetri, pa neću mnogo razmišljati, ribociklib je izbor. A kada pogledamo sada glavne smernice, naravno da svi znamo da odsustvo visceralne krize, prva linija su ciklibi sa inhibitorima aromataze. Ali pogledajte, i NCCN daje jasnu prednost ribociklibu, kategorija 1 u odnosu na abema i palbociklib koji imaju kategoriju 2A, razloge OS. Kada pogledate ESMO preporuke, ESMO, magnituda kliničkog benefita 4 i 5, najviše ocene, naravno, zbog sjajnih rezultata OS kvaliteta života, daje se ribociklibu. Sve monalize su zaista impresivne. Paloma i Monarch 3, tu su već ocene 3. A evo su jako preporuke ovde koje više nego jasno vidite daju ipak 2+, daju jednu jasnu prednost i prioritet ribociklibu. Tako da, zaista, nama kliničarima nije tako lako, ali sve nam je lakše.
Od nijednog došao sam do 2 mikrofona. Definitivno, kad su metastaze u jetri u pitanju, kad je to pacijentkinja koja ima luminalni B karcinom mlađa, dovoljno fit, mislim da tu zaista je mesto ribociklibu u odnosu na, recimo, palbociklib. Ovde je ova pacijentkinja zaista dobila kombinaciju ribocikliba sa femarom, odnosno sa letrozolom, i ona je i dalje na terapiji. Sad da imamo onu traku u filmu, da idemo unapred, unazad, došli bi ponovo 2024. godina, ista ta pacijentkinja koja je pre 10 godina dijagnostikovana, da li bi se nešto promenilo da je sada dijagnostikovana, da je danas dijagnostikovana u lečenju ranog karcinoma dojke, ona je doživjela relaps posle 9 godina, da li nešto možemo u principu da uradimo sad da možda uopšte ne doživi relaps i uđe u neizlečivu fazu bolesti? Podsjetit ću vas na case, dakle to je pacijentkinja koja je operisana inicijalno, koja je imala PT2 tumor od 23 mm i PN1A sa jednim pozitivnim limfnim čvorom. Jasno je da kad imate više limfnih čvora imate veći rizik za povratak bolesti, a koliki je rizik za povratak ovakve bolesti sa N1 i koliki je rizik pacijentkinje koji imaju N0 da se bolest vrati? Mi mislimo to je dobra prognoza, ali zaista postoji čitav niz pacijentkinja koji će relapsirati.
Pa jeste, dosta smo u zadnje vreme diskutovali o hormon receptor pozitivnoj bolešći i o tome šta je to visok rizik iz razloga što različite kliničke studije različito definišu visok rizik kada je u pitanju ova subpopulacija pacijentkinja. Ono što znamo da u svetu gde screening dobro funkcioniše jeste da se pretežno bolest otkriva u stadijumu 1. Mi smo nedavno i na nekom sastanku sa kolegama iz Švedske vidjeli da to zaista jeste tako tamo gde je obuhvat screeningom visok. Negde 35% u stadijumu 2, 12% u stadijumu 3 i samo negde 5% u stadijumu 4. Znači imamo 3 puta veći broj pacijentkinja koja se dijagnostikuje u stadijumu 2 nego u stadijumu 3, zato se nekako intenzivno razmišljaju u tom stadijumu 2 i šta je to visok rizik kada je u pitanju stadijum 2 bolesti. Ono što znamo o hormon receptor pozitivnoj bolesti, negde 50% pacijentkinja doživi taj rani relaps bolesti, misli se u prvih 3 do 5 godina, a 50% čak i do nekih 20 godina nakon inicijalne dijagnoze i ta kriva za razliku od, na primjer, HER2 pozitivnih i trostruko negativnih pacijentkinja koje pretežno imaju rizik u prvih 3 do 5 godina i onda se kriva spušta na dole. Kada su u pitanju hormonozavisni karcinomi, nekako kriva ostaje visoko i naredne 2 decenije nakon dijagnoze. I taj rizik, kao što možete vidjeti, zaista dosta zavisi od zahvaćenošću limfnih nodusa. Kod N3 bolesti preko 50% pacijentkinja relapsira u tih 20 godina, ali i kod nodus negativne bolesti preko 20% doživi relaps u tih 20 godina, što uopšte nije malo. Zato se intenzivno i misli o tome. Ovo je subanaliza zapravo iz svih adjuvantnih studija koje su ispitivala sva 3 CDK4/6 inhibitora, koja je pokazala da je relaps bolesti u prve 3 godine od dijagnoze, zapravo vidite kod nodus negativnih 11%, N1 bolesti 13% i N2 do 3 24%. Znači kod nodus negativnih pacijentkinja 11% pacijentkinja relapsira u prve 3 godine nakon dijagnoze. Takođe, još jedna analiza koja je pokazala da pacijentkinje sa stadijom 2 ili 3 bolesti imaju 15% recurrence risk u prvih 3 do 5 godina nakon dijagnoze, znači nešto se razlikuje, N0 10%, nodus pozitivne 14%, razlika nije tako uočljiva. Takođe, još jedna analiza, ovo je publikovana na San Antoniju pre 2 godine i tad je zapravo intenzivno i zbog studije koje se rade počelo da se razmišlja koliki je to rizik od stadijuma 2 bolesti, pošto se on i češće dijagnostikuje u većini zemalja, kod nas nije baš tako. I kao što vidite, na 10-godišnji rizik je čak 40%, znači jako visoki kod ove subpopulacije pacijenata. I možda ono što je najzanimljivije jeste analiza na preko 7000 pacijentkinja iz Flatiron baze, velike baze, američke baze podataka, koja je poredila kakav je rizik kod pacijentkinja koji imaju nodus negativnu bolest i nemaju neke dodatne loše prognostičke parametre i one koji imaju nodus negativnu bolest i imaju neki od dodatnih loših prognostičkih parametara kao što su visoke i 67, visok gradus tumora i ostalo. I kao što vidite, one koje imaju N0 disease sa dodatnim lošim prognostičkim parametrima imaju 3 puta veći overall recurrence risk i 4,5 puta veći rizik od udaljenih metastaza. I ako se poredi kakav je bio mortality risk u 3, 5 i 7 godina, vidi se da zapravo te pacijentkinje koje su nodus negativne imaju dodatne loše prognostičke parametre, imaju istu prognozu kao nodus pozitivna bolest. Znači, to su upravo ta grupa pacijentkinja koje zahtevaju neku dodatnu, odnosno bolju adjuvantnu terapiju. To se ovde vidi. Vidite da se ove isprekidane koje predstavljaju nodus negativne i dodatne prognostičke apsolutno imaju isti rizik kao N1 bolest. Kako bi ti, Lazare, lečio danas ovu pacijentki?
Definitivno ono što si ti pokazala je da i te pacijentkinje sa N0 bolešću i imaju određene rizikofaktore koji dovode do relapsa. Dakle, iako mi kada razgovaramo sa pacijentkim inicijalno koji ima N0, kažemo dobro je, N0 je bolest ili N1 je bolest, nije jako strašno, ali zaista veliki procent pacijenta i tu relapsira i trebalo je nešto i kod tih pacijenta da se doda. Prvo je u stvari krenuto da uz hormonsku terapiju probamo CDK4/6 inhibitore kod onih pacijentina sa najvećim rizikom. A pre nego što smo videli Monarch studiju koja je pozitivna i koja je sa abemaciclibom, prve studije su bile sa palbociclibom negativne. Pala studija je bila godinu dana, različiti rizici pacijenti, pa zatim Penelope B opet sa palbociclibom negativna studija i prva studija koja je sa CDK4/6 inhibitorima u ranoj fazi pozitivne Monarch studija. Monarch studija je uključivala visoko rizične pacijentkinje za relaps. Dakle, to su one koje su imali više od 4 pozitivne limfna čvora ili 1 do 3 pozitivne limfna čvora ako je tumor bio više od 5 cm i ako je bio histološkog gradusa 3. Bila je i ova druga kohorta sa Ki67 preko 20%, ali nju neću razmatrati jer nije se pokazalo da je Ki67 prediktivni faktor, samo prognozni i zato ću razmatrati samo ovu prvu kohortu. U prvoj kohorti randomizovane su pacijentkinje na endokrinu terapiju koja je mogla trajati 5 do 10 godina, dakle standard of care, sa ili bez 2 godine abemacicliba i primarni cilj kao kod svih studija sa ranom karcinoma dojke je invazivni disease free survival, naravno sekundarni ciljevi čitav niz, jedan od njih kao sekundarni cilj je ukupno preživljavanje. I ova studija je pokazala se pozitivno, dakle, i u prvoj analizi, ali ono što je možda bitnije je ova updateovana analiza koja zaista sa hazard ratio 0,68 i preko 7%, odnosno preko 7,5% razlike na 5-godišnjem nivou preživljavanja, zaista stavlja abemaciclib kao standard of care u lečenju visokorizičnih pacijentkinja i danas ga koristimo i u Srbiji, imamo ga na pozitivnoj listi, ukupno preživljavanje za rani karcinom dojke treba vam bar 15 godina praćenja najmanje da biste dobili neki rezultat, nije statistički značajno drugačije, ali ima trend sa većim stopom relapsa u onoj grupi koja ne dobija CDK4/6 inhibitor. Dakle, to je jedna stvar za veoma rizične pacijentkinje i onda je došla situacija da, dobro, sad imamo nešto za ove bolesnice, ali što da radimo s onima sa visokim rizikom, imamo N1 bolest i N0 bolest. I onda 2023. godine pojavljuju se prvi rezultati Natali studije. Natali studije kod ranog hormon receptor pozitivnog HER2 negativnog karcinoma dojke ispitivala, odnosno upoređivala standardnu endokrinu terapiju sa inhibitorom aromataze i LHRH nalozima kod premenopauzalnih žena sa ili bez 3 godine ribocikliba. Ali ono što je najvažnije, vrlo slično je bio dizajn, IDFS je isto bio primarni cilj, ali ono što je najvažnije se vidi na ovoj tabeli. Šira je populacija pacijentkinje uključena. To naravno utiče posle na registraciju, na standard of care koji je u budućnosti, ali i teže za dokazati pozitivnost studije. I u taj rizik je ušla kompanija Novartis sa Natali studijom i kao što vidite, za razliku od Monarhi studije, uključivani su one pacijentkinje sa N1 bolešću, sa T2N1, dakle, niži rizik pacijentkinja sa onim pacijentkinjama koje su imale i visok rizik. I Marijana će vam malo više to detaljno pokazati u narednih par minuta. Ja ću vam pokazati rezultate. Prvi put kad sam dobio vest, još nije izašla publikacija, odnosno nije saopštena na kongresu, vest da je ova studija pozitivna, ja sam rekao, dobro, ok, to je zbog ovih pacijentkinja koji su visoko rizik, ne već, to će sve biti isto, nije ni puno važno. Onda je izašla ova publikacija i ja sam i dalje mislio, dobro, statistika je takva, puno je isto visoko rizičnih pacijentkinja, to je tako. Ono što mi je davalo neki signal da možda baš nisam u pravu je i ovaj forest plot koji je na prvoj analizi izašao, koji je pokazao da je i stadijum 2 ima hazard ratio čak i nešto bolji nego onaj stadijumu 3, ali šta je meni u tom momentu bilo važno? Da te 3 godine ribocikliba ne donose veliku toksičnost koja će uticati značajno na kvalitet života. Dakle, uglavnom su toksičnosti gradosa 3 laboratorijske, gde mi možemo modifikovati dozu i tako dalje, ali pacijentkinja ima šansu da bude komplijantna, što je jako važno za 3 godine ovoga leka. I to je otprilike bilo tako i ono što je možda bio najvažniji slajd je ovaj, a to je da kada su ekstrapolirali 600 mg koje je korišćeno u metastatskoj fazi i 400 mg koje je korišćeno u ranom karcinomu, zaista smo dobili manju toksičnost, što je izuzetno bitno za komplijansu lečenja ranog karcinoma. I onda se tokom ESMA pre praktično 2 meseca pojavlja jedan update koji je izuzetno važan i koji je verovatno jedna od najvažnijih studija koja je izašla na ESMA, iako je update koji nama daje ogromnu informaciju. Benefit je veći. I to je logično, videli ste i u Monarhiju da će benefit biti veći ako duže pratimo hormon receptor pozitivan karcinom. Hazard ratio je opet još i bolji, 0,71, ali najvažnija stvar, prvo, pacijentkinja će relapsirati udaljenom metastazom u neizlečivu bolest. Drugo, stadijum 2 i stadijum 3 postoje razlike i kod jednog i kod drugog i najvažniji slajd koji je tad prikazan, da i kod pacijentkinja kod N0 sa dodatnim faktorom rizika i N1 pacijentkinja koji nisu uključene u Monarhi studiju, postoji benefit od preko 5%. Dakle, apsolutni benefit od 5% u ovakvoj bolesti posle relativno kratkog praćenja je izuzetna vest za nas onkologe. I naravno, to je bila izuzetna vest i u Americi i ono sutradan je FDA odobrio ribociklib za lečenje i N0 bolesti i N1 i naravno višeg rizika. I kad FDA to uradi, NCCN odmah update-uje svoj vodič i kaže treba da koristite ovaj lek i u N0 bolesti. Čekamo Evropsku agenciju koja je malo sporija, ali mi se svi nadamo da će biti ista indikacija. I ono što je sad, mislim, važno da svima prikažemo, a to će vam prikazati Marijana, koje su osnovne razlike i zašto je šira populacija za Natali nego za Monarhi.
Hvala. Pa da, evo, sada da pogledam ove 4 studije, odnosno 3 leka, Natali, Monarhi, Palas i Penelope. Mi naravno sve ove studije ne možemo ni slučajno porediti direktno, jer su zaista drugačijeg dizajna. Natali studija je studija koja je uključivala 5100 pacijenata. Rekli smo da je bio i stadijum 2 i 3. Ovde smo imali mogućnost da dajemo i pacijentkinjama sa T2N0, koje su pri tome gradosa 3 ili grados 2, determinisan visokim Ki67 ili situacija gde je visok rizik determinisan visokim velikim genskim ekspresionim profilom. Ribociklib je ordiniran u dozi od 400 mg, endokrini partner inhibitor aromataze i studija, odnosno lek i lečenje trajalo 3 godine. Monarhija u negde sličan broj, 5600 pacijentkinja, ovde vidimo da je ipak visok rizik za relaps 4 više žlezdi ili 1 do 3, tumor je morao da bude tada veći od 5 cm ili gradus 3, a kohorta 2 za sada još uvek nezreli podaci i ta kohorta je podrazumevala da bude determinisana proliferativnim indeksom ako je broj žlezda bio 1 do 3. Abema je kontinuirano davan, znači za razliku od ribocikliba i ovde je još značajno da je od endokrinih partnera, pored inhibitora, mogao da se koristi i tamoksifen i za razliku od Natali gde je davan lek 3 godine, ovde je ordiniran tokom 2 godine. Pala studija je imala sličan broj, oko 5700 pacijentki na stadijuma 2 i 3. Endokrini partner je bio inhibitor ili tamoksifen, 2 godine je trajalo lečenje, a Penelopa B se po dizajnu možda i najviše razlikuje. Ovde je adjuvantni palbociklib kompariran sa placebom u adjuvantnom settingu, ali nakon prethodne neodjuvantne hemioterapije i nepostignute kompletne remisije. Lečenje je trajalo otprilike 13 meseci i obe studije sa palbociklibom, Palas i Penelope, su negativne, tako da ostaju samo Natali, Monarhi i lekovi koje možemo za sada jedino koristiti su ribociklib i abemациklib. Sada, šta je to jedinstveno za Natali studiju? Pre svega jedinstveno je da smo mogli da uključimo stvarno pacijentkinje sa umerenim rizikom, odnosno i one sa nodus negativnom bolešću. Takođe, doza je bila manja u odnosu na onu korišćenu u metastatskom settingu, jer kao što smo čuli od profesora Popovića, definitivno u ranom settingu pokazano je da doza od 400 mg je sasvim efikasna, znači nema kompromitovanja efikasnosti uz, naravno, manji nivo dozno zavisnih toksičnosti. A zašto 3, a ne 2 godine? Pa to je prilično pametna odluka, s obzirom da ipak period najvišeg rizika za relaps jeste unutar prve 3 godine. Međutim, ono što negde još više dokazuje važnost i vrednost Natali studije za nas koji se svakodnevno susrećemo s ovim pacijentima je zapravo sjajna studija sveobuhvatna Paola Tarantina i koautora koja je objavljena sad nedavno na ESMO kongresu, gde je zapravo iz jedne ogromne data analize, elektronske data analize i baze podataka američke, izvedeni su oni pacijenti koji imaju karakteristike Natali studije ili karakteristike onih pacijenata Monarhi studije u jednom realnom kliničkom scenariju. Vidimo da definitivno se radilo o retrospektivnoj analizi i to poprilično dugog trajanja, znači 8-godišnjoj. Ta cela baza se zove koncert AI i kad bismo mi pogledali, naravno, to je ogroman broj pacijenata, 22.600, ali zapravo one pacijentkinje koje smo zaista analizirali, njih je 7.060, to su zapravo one koje su steroid receptor pozitivne, HER2 negativne i kod kojih se razmatra adjuvantno lečenje. I ono što smo u ovoj retrospektivnoj analizi videli, a više nego jasno, ilustrativno isto i impresivni podaci, da zapravo ove real world data analiza je pokazala da više nego 2 puta je pacijenata više u studiji koji su odgovarali svojim karakteristikama Natali eligible kohorti, a samo 14,5%, odnosno duplo manje, je bilo onih pacijentkinja koji bi se uklapali sa Monarhi i uključujućim kriterijumima. Takođe, kada pogledamo nodus negativna bolest, ona je isključivo bila prisutna kod pacijentkinja koje bi odgovarale, naravno, Natali studiji, tu je bilo oko 9,5%, a značajno viša proporcija pacijentkinja sa nodus pozitivnom bolešću N1 su bile one pacijentkinje koje su ipak imale karakteristike Natali kohort studije u odnosu na Monarhi, 92% u odnosu na 46%. I šta drugo reći, znamo da su i Monarhi i Natali apsolutno više nego jasno dali impresivne rezultate i jasnu statistički značajnu redukciju rizika za relaps bolesti i za invazivni relaps i za udaljeni, ali ono što je najvažnije, šta je to što Natali studija nama zaista omogućava? Značajno veću populaciju pacijenata koji zaista odgovaraju eligibility kriterijuma u Natali studiji. I zapravo mi na taj način pružamo duplo većem broju pacijentkinja da dobiju targetnu terapiju za endokrinu terapiju i da zaista imaju značajna poboljšenja u dugoročnim ishodima.
Hvala, Marijana. Mislim da definitivno je Natali nešto što je pokazalo da su CDK4/6 inhibitori, odnosno ribociklib u ovom slučaju potrebni i široj populaciji u ranom karcinomu u odnosu na onaj najveći rizik. I pitanje prvo u diskusiji za obe nismo stavili na slajd i naravno još nismo tretirali pacijentke. Koja bi bila optimalna adjuvantna terapija za ovu pacijentkinju sa T2N1 bolesti?
Pa pitanje je jako lako. Znači, ribociklib i inhibitor aromataze bi bio optimalna terapija.
Da li se slažeš s time?
Slažem se.
Da li se slažete da je to, čekamo registraciju naravno u Evropskoj uniji, čekamo registraciju u Srbiji, da je to nešto što sledeće u ranom karcinomu dojke, na čemu treba da radimo kad je vezano za dostupnost, jer sad imamo abemaciklip, ali definitivno je i real world data je pokazala kolika je stopa relapsa N0, N1 bolesti i definitivno je Natali pokazao. Da li je to nešto na čemu treba raditi u narednom periodu da postane dostupno u našoj regiji i u Srbiji?
Apsolutno, nema šta, znači zaista postoji ogromna potreba, više nego jasna, da pomognemo što većem broju pacijenata da imaju, ako mogu, nikada relapse ili ako treba što kasnije. I ovo je sigurno najveća prednost Natali studije, što zaista čini jednu mnogo veću populaciju pacijentkinja nego što to za sada može Monarhi studija. Tako da to je naš sledeći korak i apsolutno mislim da ne postoji nijedan razlog da u tome ne uspemo, jer se radi uglavnom o mladim ženama ili onima koji aktivno treba da žive svoj život. I tu smo da pomognemo da zauvek ostanu zdrave.
I koje u suštini, kada uđu u metastatsku bolest, ne samo što mi znamo da je neizlečiva, nego to je poseban jedan psihički moment koji je jako težak za te pacijentke, je mnogo teži u suštini nego ta inicijalna dijagnoza da je rani karcinom i da postoji nada za izlečenje. Ono što je isto jako važno, vidjeli smo toksičnost u Natali studiji, recimo bolovi uz globovima, koji su najčešće toksičnost inhibitora aromataze, je recimo manja kada dodate CDK4/6 inhibitori. To može značajno da utiče i na komplijansu i na adherencu ovih pacijentke. Kakav je sad problem sa adherencom i zašto je to važno?
Pa važno je zato što mi smo svesni da nam ni komplijansa sa monoendokrinom terapijom nije baš na najvišem nivou. Iako se o tome jako malo priča i nekako te pacijente i ređe viđamo ih na tim kontrolama, nekad i saznamo kakva nam je komplijansa, nekad nam i ne priznaju kakva je baš komplijansa, ali je upravo iz tog razloga važno. Ja mislim da je tu naša komunikacija ka pacijentu od presudnog značaja, da mi moramo reći da oni mogu očekivati neka neželjena dejstva i koja neželjena dejstva, ali s druge strane ja mislim da je jako bitno objasniti im kakvu bolest najiskrenije oni imaju, koliki je njihov rizik, možda ne pričati baš o procentima koji su nama bitni, njima ne, ali da zapravo to što se nekad kaže, znamo da nam pacijenti nekad kad dođu operisani direktno od hirurga kažu to je najbolji prognostički tip karcinoma, mi koji se ovako malo više bavimo ovim visokim rizikom znamo da nije baš uvek tako. Mislim da je ta komunikacija ka njima jako bitna, jer terapiju neće uzimati kratko, 3 godine nije mali period, oni imaju česte posete bolnici zbog toga što baš ne vole, da kažem, pacijenti, drugo je sa monoendokrinom terapijom, ali mislim da uz jednu dobru komunikaciju između lekara i pacijenta i onoga šta mogu da očekuju, zaista te toksičnosti, mi smo vidjeli i kod, sad nakon 2,5 godine i kod metastatske bolesti kakav je ribociklik Black. Ima tih neutropenija, leukopenija, potpuno nekomplikovanih na samom početku lečenja. Ovde je to dosta manje kada su neutropenije, leukopenije u pitanju i koliko sam ja videla najčešći razlog prekida je zapravo bila hepatotoksičnost kod ovih pacijenata. To je nešto na što manje možemo da utičemo, ali ja mislim da uz jedno dobro objašnjenje zašto je bitno da dobiju lek i kakav lek dobijaju, naravno da mogu da se jave neželjena dejstva, mislim da će nam komplijansa ipak biti dobra što se tiče lečenja. Mislim, uvek se plašimo toga i sad sa abemaciklibom mi imamo neko 6-mesečno iskustvo, još je to rano da kažemo da nam pacijenti odustaju od terapije, sve to, ali se uvek plašimo toga. Ali mislim da ako komuniciramo lepo koliki je benefit, kakva je toksičnost, da će komplijansa biti dobra.
Hvala puno. Ja mislim da je tu najvažnija stvar u stvari da kod ribocikliba pacijent ne oseti toksičnost. Odnosno, ne kvarimo kvalitet života, oni će vaditi krv i vidjet ćemo nekad i hepato, ali pacijent ne oseti i zato imamo šansu za dobru komplijansu. Marijana je prikazala rezultate američke baze, Flatiron. Ono što ja, kao hint jedan, što će se desiti u narednom periodu, mi smo radili zajedno sa kompanijom Novartis jednu veliku bazu ranog karcinoma dojke, preko 1000 pacijentkinja i videli smo da kod nas, nažalost, nije situacija sa N2 i N3 bolesti tako povoljna. Dakle, 5% je u Americi, kod nas ide do 20%. I u toj situaciji, a vezano i za komplijansu, imat ćemo jedan velik broj pacijentkinja koji će moći da dobiju i ribociklib i abemaciklib. Ribociklib se daje 3 godine, potencijalno manje pacijent oseti toksičnost, abemaciklib, postoje potencijalni problemi s dijarejom, ali i do 2 godine. Kako ćemo izabrati, kad budemo imali oba leka, high risk pacijentkinja, naravno, odlično je što imamo N0 i N1, da je samo će nam biti ribociklib. Kako ćemo izabrati kod high risk koji ćemo od ta dva dati i verujem da to nije baš lako pitanje.
To moram da priznam da nije lako pitanje, tako da mislim da ćemo ipak case by case. Ja mislim da 3 godine je lakše možda izdržati nešto što apsolutno ne osjećate da primate, jer ja verujem da ribociklib stvarno ne daje nikakvu simptomatologiju koja bi smetala pacijentu, a abemociklib ipak izvesno vreme, a malo individualno daje dijareje koje umeju da budu jako neprijatne, jer ja kažem i naglašavam, to su radno aktivne žene uglavnom, koje zaista ne žele da menjaju svoje rutine, svoje lepe života. One se osjećaju i smatraju sebe zdravima, tako da tako treba da ostane narednih N godina. Mi moramo da učinimo sve da se one osjećaju da dišu punim plućima i da apsolutno sve svoje uloge u životu mogu da obavljaju kao i do sada. Tako da smatram da je sa aspekta i kad bi neko bio iz ugla pacijenta, eto mislim da je negde ribociklib prihvatljivije jer je lakše duže, a da ne boli, nego možda kraća terapija, a da ipak daje dijareje, ali ne daju ni uvek se ni dijareje ne dešavaju kod svih, nekada jako kratko traju, tako da sigurno ćemo davati oba leka, imati više iskustava, pa ćemo moći malo više i da pričamo iz svojih ličnih iskustava i razmenjujemo ta iskustva.
Hvala puno. Ja mislim da ćemo moći i da, ukoliko se krenemo s jednim pa se desi neka toksičnost i da radimo switch, zato nam trebaju oba. Imamo vremena, ako neko ima neko pitanje iz publike, do sad nismo imali vremena na ostalim simpozijama, ali sad imamo vremena zaista. Ako neko želi da postavi neko pitanje, ako ne želi, imamo vremena za dobar zaključak. I ja mislim da je zaključak prvog dela iz metastatske bolesti ono što kaže Palmares. Pričali smo kako su slični CDK4/6 inhibitori, ali sad je potpuno jasno da ako imate pacijentkinju sa ranim relapsom, luminal B karcinomom, mlađu, jeterne metastaze, da tu definitivno treba da primenimo ili ribociklib ili ako budemo mogli i abemociklib i da to, mislim da više nemamo puno razmišljanja. Možda smo nekad išli random, možda smo nekad išli vamo jedan malo drugi, ali definitivno sad znamo kod kojih pacijenta koji treba da primenimo. A mislim što se tiče ranog karcinoma dojke, da uz ovo što imamo sad za high risk, prva sledeća stvar koja će nam trebati u ranom karcinomu dojke i na kojoj treba da radimo je da imamo iz N0 i N1 pacijentkinje CDK4/6 inhibitor, jer definitivno ćemo izlečiti više, manje će ući u metastatsku bolest i imat ćemo mnogo bolje rezultate lečenja. Eto, toliko od nas. Hvala lepo na pažnji.
Pa ne vidim ovo. To mi je vidi, ovo ne vidim nikako. Jer se čujemo? Halo, halo? Šuška, gde su ovi dečaci? Pa da ovo malo pomerimo.
Pa ja ne znam da li možemo. Nisam sigurna.
Možete ovo malo tamo da bi ja mogla ovo da vidim? Ja ne mogu preko da vidim, zato što imam tu neku čudnu visinu. Sorry.
Ali ne, ona misli da li može ovo postaviti da se pomeri.
To.
E, tako.
Da, danas se mučim, sve ovako gledam. Halo, halo? Da, jer ovo ne vidim ništa. Dobro, nisam prvo.
Koleginice i kolege, dobar dan ili dobroveče. Nastavljamo dalje sa satelitskim simpozijom kompanije Eli Lilly. Imaćemo danas dve teme. Jedna tema je rani visokorizični hormon receptor pozitivni HER2 negativni karcinom dojke. Druga tema je metastatski hormon receptor pozitivni HER2 negativni karcinom dojke. Uvodna predavanja u prvom delu će držati doktorka Marijana Milović-Kovačević, koja će nam pokazati koje su to visokorizične pacijentkinje sa ovim podtipom, najčešći podtipom karcinoma dojke. Potom će profesor Gligorov pričati šta se to novo dešava u adjuvantnom lečenju ovih pacijentkinja sa hormon receptor pozitivnim HER2 negativnim karcinomom dojke. I doktorka Šušnjar će nam ispričati kako se preveniraju i leče neželjeni efekti kod adjuvantne terapije, kako hormonske, tako ciljene, za hormon receptor pozitivni HER2 negativni karcinom dojke. Ja ću pokušati samo da nađem, što bi Crnogorci rekli, ćeralicu. I da probamo da promenimo slajd. Pa neki. Pa slabo radi, ali možda se probudi. I dalje se slabo radi. Može? Zamalo. Aha, promenilo se na kompjuteru, se promenilo na ekranu. Dobro, dok se nama promeni na velikom ekranu ispred nas, imat ćemo za početak jedno pitanje na koje ćete glasati pre nego što počnemo sa predavanjima. Tako da molim vas, uzimite vaše telefone, skenirajte QR kod i onda ćemo i pokazati pitanje. Evo ga. I pitanje je sledeće. Pošto nam ovdje i dalje ne menja, ja ću izaći malo ovamo da pročitam vam pitanje. Odnosno rečenice za koje verujete da su tačne. Prva rečenica, skoro svi pacijenti sa ranim stadijumom hormon receptor pozitivnog HER2 negativnog karcinoma dojke trebali bi biti kandidati za neoadjuvantnu terapiju. To je zamalo tačno, ali i više nije. Biološki faktori, kao što su gradus, ekspresija hormonskih receptora, ekspresija HER2 i amplifikacija, su manje važni nego ne znam, nije nam stala cela rečenica. Anatomski stadijum. Dobro. Disease-free survival, hormon receptor pozitivnih HER2 negativnih pacijenata koji su lečeni adjuvantnom hemioterapijom, hemioterapijom, nema veze, pročitamo pa ćemo glasiti ponovo, je bolji u grupi sa 1 do 3 pozitivnih linija čvora i koji imaju gradus 3 ili, da, ni sad se ne vidi, i više pozitivnih linija čvora, dobro. otprilike 30% pacijenata sa hormon receptor pozitivnim HER2 negativnim ranim karcinomom dojke su sa rizikom od povratka bolesti bazirani na monarhi kriterijima. Monarhi kriterijima i poslednje je u slučaju parcijalnog ili kompletnog odgovora na neadjuvantnu hemioterapiju ponovo treba da se procenjuju faktori rizika, da li je ta pacijentkinja u riziku ili nije, odnosno verovatno je bilo pitanje vezano za sam PCR. Tako da, hajde da glasamo. Jest da smo za malo smo pročitali odgovore, ali nema veze. I evo, 80% je glasalo za ovaj odgovor 4. I možemo dalje da se vratimo na slajdove. I možemo da nastavimo, ja bih zamolio Marijanu da krene sa svojim predavanjima o tome šta je to visokorizični hormon receptor pozitivni HER2 negativni rani karcinom dojke.
Gledam da radi svoje. Drage kolege i koleginice, znači mi ćemo danas govoriti o tome kako se zapravo sprovodi procena rizika i kako se zapravo identifikuju oni pacijenti i pacijentkinje koji imaju visok rizik za relaps, koji su to razvijajući standardi i koje su momentalne smernice. Prvo ćemo vidjeti slučaj pacijentkinje koja ima 62 godine, postmenopauzna. Ona je išla na rutinske mamografske screening analize i nađena je masa u levoj dojci. Mamogram je pokazao 3 cm tumorsku masu i suspektne akselarne limfne čvorove, kod biopsije ukazala da se radi o gradusu 3 invazivnom duktalnom karcinomu, hormon receptor overeksprimiranom, HER2 negativnom. Urađena je čak i biopsija limfnog čvora i potvrđena je metastaza, a na petu je utvrđeno da nema metastaza i germline testiranje je pokazalo da nema BRCA1 i BRCA2 mutaciju. Pacijentkinja je podvrgnuta mastektomiji levostrano i disekciji akselarnih žlezda. Nađeno je da je jedna od 3 limfnih čvorova pozitivna. Tumor je bio 2,5 cm, gradusa 3. Urađen je njenom motivacijom Oncotype DX i recurrence score je bio 21. Ona je dalje nastavila follow-up kod svog hirurga i definitivno sada redovno dolazi naravno na svoje preglede. Pa da vidimo generalno da li ta pacijentkinja i da uopšte procenimo šta je to bitno i koji su to parametri za nas kliničare važni, na osnovu čega ćemo odlučiti da li je neka pacijentkinja visokog rizika. Ta prirodna evolucija hormon receptor pozitivnog HER2 negativnog karcinoma dojke definitivno ukazuje da osnovni faktori koji ukazuju na potencijalni rizik od relapsa su naravno baseline kliničko-patološki faktori, baseline genski ekspresioni profili i biomarkeri i cirkulišući biomarkeri. Kao što znamo, karcinom dojke, nažalost, nije jednostavan i nije jedna bolest, ona je izuzetno heterogena i niz godina unazad, još od 2006. i 2011. više nego jasno znamo da neka prirodna evolucija se potpuno razlikuje između, na primjer, triple negativnog karcinoma dojke s jedne strane i s druge strane hormon receptor pozitivnog. Vidimo da triple negativni imaju izrazito visok rizik da relapsiraju unutar prvih 5 godina, a potom, kako vreme odmiče, taj rizik se drastično smanjuje, a hormon receptor pozitivne pacijentkinje imaju prilično nizak rizik da će relapsirati unutar prvih 5 godina, ali taj rizik se ne smanjuje s godinama. Verovatnoća nekih kasnih relapsa je kod steroid receptor pozitivnih karcinoma i ponajveća. Kada pogledamo ranije studije i veliku meta-analizu Oksfordsku i čuveni zlatni standard tamoksifen koji je pokazao jasno preimujstvo, odnosno observaciju davnih godina, na osnovu analize 7400 pacijentkinja vidimo da redukcija rizika za relaps bolesti je oko 40% ukoliko pacijentkinja pije adjuvantno tamoksifen 5 godina u odnosu na one koje su samo observirane, tako da desetogodišnji benefit je skoro 13%. Naravno, impresivni rezultati i apsolutno, od kako su ta saznanja dobijena, što je mnogo godina unazad, a tamoksifen je apsolutno zlatni standard. A inhibitori aromataze jesu doprineli efikasnosti. Vidimo da poređenje inhibitora sa tamoksifenom, naravno u studiji koja je sadržala skoro 10.000 pacijentkinja, jasno pokazuje da je desetogodišnji benefit od dodatka inhibitora u odnosu na tamoksifen negde 3,6%. Ali nemojte da zaboravite, za sada ni jedna studija, niti meta-analiza, niti overview svih analiza inhibitora nije pokazao da postoji benefit u pogledu ukupnog preživljavanja, tako za nas kliničare nije toliko bitno da li je inhibitor aromataze bitno efikasniji od Nolvadexa, još bitnije kako naš pacijent podnosi koju terapiju i bitno je da bude adherentan i persistentan. Tako ako ne podnosi inhibitor aromataze, naravno da ćemo ukoliko treba da ga u nekim određenim kliničkim situacijama vratimo na tamoksifen. Takođe, velika studija, Oksfordska overview u Lancetu 12. godine prikazana je definitivno utvrdila da hormon receptor pozitivni karcinomi u adjuvantnom settingu nemaju veliki benefit od polihemioterapije. Taj benefit je uglavnom umeren. Ali šta je to što najviše negde određuje da li će određeni pacijent imati rani ili kasni relaps? Pa to je pre svega fenotipski podtip karcinoma dojke, ali naravno i rezidualni kancer burden, posebno 2 i 3 ukazuju na značajno viši rizik za kako rane, tako i kasne relapse. Tako da danas definitivno moramo patolozima skrenuti pažnju da nije dovoljno samo da mi govore da li je patološki kompletni odgovor postignut ili ne patološki, non-pathological, moraju mi dati malo bližu analizu. Ono što je takođe važno da taj čuveni Ki-67 koji je uvek pomalo subjektivan i ne dovoljno objektivan, definitivno nije prediktivan, već je prognostički. A to znači i one pacijentkinje sa niskim i sa visokim Ki-67 imaće benefit od hormonoterapije. A sada, šta su to genski ekspresioni profili i da li nam oni zaista koriste u kliničkoj praksi? Pa prva studija negde 2021. je pokazala NSABP V14 studija gde je adjuvantni tamoksifen davan tokom 5 godina i gde je apsolutno utvrđena rezistencija na endokrinu terapiju koja raste sa relapsom za relapsom bolesti, ali je definitivno ustanovljeno da je Oncotype DX vrlo jedan jasan prognostički model, genski ekspresioni profil, koji ne samo da je jasan i da pomaže, već je on i nezavisan. Multivarijantnim Cox modelom je pokazano da je Oncotype DX i recurrence score dobijen kroz tu studiju apsolutno nezavisan od godina starosti i od tumorske veličine. I vidite ovde da oni koji imaju nizak recurrence score, manji od 18, imaju otprilike samo 6,8% verovatnoću udaljenih relapsa tokom 10 godina, a high risk, ovi sa recurrence scoreom većim od 30, ta verovatnoća raste na 30,5%. Još jednom je to validirano kroz narodnu studiju NSABP B20, gde je pokazano da pacijentke, njih je sad već više, 650, recurrence score visok, znači definitivno samo ta grupa ima korist od dodatka hemioterapije, a sve ove grupe, posebno low recurrence score, vidi se da benefit od hemioterapije ne postoji. A onda definitivno potvrđeno i prospektivno validirano u velikoj studiji Taylor-X, vidi se da Oncotype DX ima izuzetnu korist, na praktično 10.000 pacijentkinja utvrđen je benefit Oncotype DX i poznavanja recurrence score, jer vidite da ove pacijentkinje koje su recurrence score manji od 11, sve su išle na hormonoterapiju, one koje imaju recurrence score veći od 25 su sve išle na hemioterapiju, a sledstveno hormonoterapija, a ove intermediate score su išli jedan deo samo na hormonoterapiju, drugi deo hemioterapija, potom hormonoterapija i vidimo zapravo da je Taylor-X studija, inače kod pacijentkinja koje imaju negativne žlezde, pokazala da sve postmenopauzne pacijentkinje nemaju apsolutno benefit od dodatka hemioterapije ako imaju intermediate, naravno i low score, ali neki manji procenat pacijentkinja mlađih od 50 ipak je pokazano da izvestan benefit od hemioterapije postoji. Vrlo sličan dizajn studije, Eric-Sponder, koji je takođe koristio genski ekspresioni signature, a to je Oncotype DX, je ovog puta uključio pacijentkinje sa 1 do 3 žlezde i definitivno one koji su imali najviši nivo recurrent score, veći od 25, sve su išle na hemioterapiju i sledstvenu endokrinu terapiju, a one sa 0 do 25 su išle ili na hemioterapiju, a potom endokrinu terapiju, ili samo na hormonoterapiju. I pogledajte, sve postmenopauzne pacijentkinje od 1 do 3 žlezde nisu imale benefit od dodatka hemioterapije, ali ove pacijentkinje koje su premenopauzne, vidimo da hemioterapija, bilo da one imaju 1 žlezdu ili 2 do 3 žlezde, imaju benefit od dodatka hemioterapije koji je oko 5%. I tu su silne diskusije oko toga je li to direktan efekat same hemioterapije ili indirektno hemioterapija koja definitivno deluje na supresiju ovarijalne funkcije, ali vrlo brzo čućemo definitivno rezultate Energy 009 offset studije gde ćemo tačno dobiti informaciju je li ovaj efekat hemioterapije ili je ipak jako bitno da sve ove pacijentkinje dobro suprimiramo LHRH agonistima. Međutim, sada sledeći aspekt koji isto može prilično da nam pomogne u identifikovanju onih pacijentkinja koje možda imaju visok rizik za relaps, a to je zapravo analiza cirkulišućih tumorskih DNK. Još 2015. godine Garcia i autori su apsolutno pokazali da postojanje i detektovanje cirkulišuće tumorske DNK i praćenje cirkulišuće tumorske DNK definitivno može da ukaže na postojanje minimalne rezidualne bolesti i vidimo da je kod onih pacijentkinja koje u praćenju nakon hirurgije su se detektovale tumorske DNK definitivno imaju lošiju prognozu i značajno veći rizik od relapsa bolesti. To je potvrđeno 22. godine Lipsikovom studijom da je pokazano da prevalenca cirkulišućih tumorskih DNK pozitivnosti oko 10% i definitivno imamo pozitivan prediktivni value i vrednost 75% vezano za udaljeni relaps. Što znači, nakon medijane trajanja od 2 godine vidi se da onda kada primetimo i detektujemo cirkulišuće tumorske DNK, prosečno prođe oko 12 meseci pre pojave udaljene bolesti. Penelope B studija ovde je važna da vam više pričam o cirkulišućim tumorskim DNK. Da vas podsjetim, to je zapravo studija gde adjuvantni palbocikli kompariran sa placebom nakon hirurgije i prethodne neadjuvantne terapije i nedosegnutog patološkog kompletnog odgovora, studija je negativna, ali šta je ovde bitno? Da kod onih pacijentkinja gde su detektovane cirkulišuće tumorske DNK drastično je kraće vreme do invazivnog relapsa i do udaljenog relapsa. A sada sledeće, šta je to još što može nama kliničarima da pomogne da probamo da pacijenta negde svrstamo u grupu visokog ili niskog rizika za relaps. To su naravno iskustva iz realne kliničke prakse, takozvane real world data studije. One su nekad i korisnije od ovih randomizovanih prospektivnih kliničkih studija, jer su realnije, jer one ne biraju pacijente, već su tu svi pacijenti svih nekih komorbiditnih, specifičnih situacija, ECOG skore i tako dalje, starosnih dobi. Tako da je ovo jedna studija koja je analizirala, inače italijanska studija, analizirala u jednom 5-godišnjem periodu, vidimo u okviru ove databaze bilo je čak 34.000 pacijenata, ali na kraju sužavanjem i izdvajanjem onih pacijentkinja kod kojih su uklonjene žlezde koje su hormon receptor pozitivne, HER2 negativne, rani karcinom dojke, kod kojih je inicijalno bila poznat taj patoanatomski status, njih je ukupno bilo 400, što znači 34%, i vidimo da je 1/3 kod ovih pacijentkinja koje su imale zapravo karakteristike visokog rizika za relaps, kohorte 1 Monarhi studije, pokazano da imaju 13,3% verovatnoću da će iskusiti udaljenu bolest i vidimo da zapravo praćenje je bilo 1,4 godine, a najfrekventnija mesta relapsa su bili kosti, jetra i pluća. Veoma slično je bilo i sa španskom studijom i real world data na osnovu 3 adjuvantna klinička trijala, takozvane GEICAM triale i vidimo da svi oni pacijenti koji su imali karakteristike Monarch studije su zapravo pokazali desetogodišnji verovatnoću za desetogodišnji invazivni relaps više od 40% i verovatnoća za desetogodišnji smrtni ishod 30%. I zapravo udaljeni relaps je bio i najčešće mesto invazivnog relapsa. Takođe i Kanto studija je jedna prospektivna observaciona studija veoma važna, gde su pacijenti analizirani na osnovu kliničko-patoloških karakteristika, oko 1200 pacijenata sa 4 i više žlezde ili 1 do 3 žlezde, ali neophodan faktor je bio 5 i više centimetara tumora ili gradus 3. Vidimo apsolutno da one pacijentkinje koje su imali ove visokorizične faktore su imali značajno veći rizik za invazivni i udaljeni relaps. Takođe, jako važni su Jimmy-MIG triali, odnosno individualna analiza podataka pacijenata iz 3 adjuvantne faze, 3 randomizovanih triala, MIG-1, GIM-2 i GIM-3. Vidimo da od skoro 5000 pacijentkinja, trećina je klasifikovana kao visok rizik na osnovu karakteristika Monarch trial kriterijuma i vidimo nakon follow-upa od 7 godina da je 7-godišnji disease-free survival 87% kod onih koji nisu imale ove osobine visokih karakteristike i visokog rizika za relaps, dok je 69% bio rizik za relaps kod ove visokorizične populacije. U okviru ove grupe, u okviru prospektivne observacione studije italijanskih real world data studija, vidi se da sve one pacijentkinje koje su imale karakteristike Monarch studije zapravo su u većini slučajeva, čak skoro 90%, uglavnom preporučeni režim za dalji njihov tretman i prevenciju, naravno, relapsa su bila kombinacija supresije ovarilne funkcije i inhibitori aromataze, a ne Nolvadex. I ono što je važno, da bi se zaista negde što preciznije identifikovao taj rizik za relaps i da se dobro stratifikuju pacijenti, oformljena je jedna grupa koja se zove IRID Working Group, gde grupa panelista od 25 eminentnih stručnjaka u karcinomu dojke zapravo bila uključena u identifikaciji kliničkih, patoloških, morfoloških i genetičkih činilaca koji su potencijalno povezani sa visokim rizikom za relaps. I na ovom slajdu vidite da sve ovo zeleno, a to je histološki gradus, nodalni status, tumorska veličina i naravno i genski ekspresioni profili apsolutno nude jedan jasan, visoko relevantan podatak o potencijalnom riziku za relaps bolesti, naravno izve one pacijentkinje koje imaju visok rizik za relaps i prema kojima moramo imati jedan poseban stav i lečiti ih naravno skrupuloznije i ozbiljnije. I na kraju, naravno, osnovni faktori na osnovu kojih donosimo odluku da li neka pacijentkinja ima visok rizik za relaps jesu baseline kliničko-patološki faktori, jesu važni genski ekspresioni profili i jeste važno da analiziramo cirkulišuće biomarkere. I sada, da ja sad ovu pacijentkinju ponovo ispričam, znači naša Samanta, još jednom da vam kažem, 62 godine, znači 3 cm tumor, steroid receptor pozitivni, limfnodalna biopsija uređena, vidi se da nema metastaza, germline testiranje negativno, 1 žlezda pozitivna, 2,5 cm tumor i oncotype 21. Tako da, koji su faktori relevantni da se determiniše rizik, da li kod ove pacijentkinje treba dati nešto osim adjuvantnog inhibitora, da li je važan Ki-67, da li biste predložili hemioterapiju oncotype 21, pa da diskutujemo svi zajedno, može?
Može, naravno. Ja mislim da je možda, znači, jedna od 3 pozitivna limfna čvora, 2,5 cm tumor, gradusa 3, što je ključna stvar, i oncotype 21, nisam siguran da je, Josef, nisam siguran da je ovde baš bila indikacija za oncotype da se uradi. 2,5 cm, jedna pozitivna limfna žlezda.
Mi bi radili oncotype.
Oncotype u ovoj situaciji da je gradus 3 tumora.
Da, ima 62 godine, iako je gradus 3, mi bi radili sistematski.
Koja bi ovde bila optimalna terapija u adjuvantnoj fazi?
Kod nas, pošto je oncotype manje od 25, onda bi išli na endokrina terapija bez hemioterapije.
čak i u ovoj situaciji da imamo i taj pozitivni čvor 2,5 cm gradus 3, ništa ne bi opredeljivalo za adjuvantnu hemioterapiju ako je onkotype 21.
Nemci su publikovali u plan B da otprilike 15% do 20% od pacijente koji imaju gradus 3 imaju low recurrence score i da je nezavisan prognostički faktor. Tako da...
Ne, ja hoću samo pitam, to je znači jače od gradus, nekako gradus 3, koliko verujemo zapravo tim gene profiling testovima? Mi nemamo nikakve iskustva, ja samo pitam, zaista. Mislim,
Ne, problem u gradusa je to što ima 3 parametra. Sad zavisi koja je proliferacija. Ili ako može on biti gradus 3, a da proliferacija nije toliko visoka. U tome je. Tako da...
Jasno. Dobro, ovdje recimo u našoj situaciji ne bi imali ovaj onkotype.
Ali upotrebljavamo onkotype samo kad imamo sumnje da možda ne treba hemioterapija. Nikad ne upotrebljavamo onkotype za nisam siguran da li treba, mislim da ne treba, uradit ću onkotype. Znači samo za de-escalate, što bi rekli. Tako da ako nemamo onkotype, u ovom slučaju bi radili hemioterapiju.
Da, ja moram da priznam kada bi meni došao neki pacijent i rekao da li ja doktor imam para, nije problem, platit ću, da li da uradim, ja bih rekla ne, gradus tumora je 3, mislim zašto da neko i ja,
ja sam isto zato pitao, zato što bih ja isto išao, ne bi mi ovdje bila indikacija za onkotype. Imao bi recimo dovoljno parametara da kažem ovo mi je za hemioterapiju, mada ono što Josef kaže da zaista taj gradus je u stvari triki stvar, jer vjerovatno više verujemo panelu gena nego gradusu i to što su Nemci objavili to je tako, ali zaista u ovoj situaciji, obzirom da pacijent mora da plati, što je kod nas dodatni faktor, jel? I da li bi uključili CDK4/6 inhibitor nakon hemioterapije?
To bi bilo drugo pitanje i naš stav je nezavisno od pacijenta da li ima indikaciju ili ne za hemioterapiju. Indikacije za CDK4/6 inhibitori su nezavisni od toga da li su primali hemioterapiju ili ne. Tako da...
Imam još jedno pitanje. A da li je ispitivano kod pacijenta koji su primili adjuvantni abemaciclib, da li sada gene profiling testovi nešto rade? Znači, ako se ne varam, to nije pokazalo neku vezu. Znači, može biti manji, veći, ali čini mi se da ako pacijent ne ispunjava one kriterijume, na primjer, ne, ovdje ispunjava, nego ako ne ispunjava, a ima visok gene profiling test, oncotype DX, da zapravo to nije razlog da se ide na agresivniju terapiju.
Osim kod Natali, tu su genski ekspresivni profili korišćeni, kod Monarhije ne.
Da. Dobro, jasno je, ovdje u našim uslovima bez onkotypa bi išla hemioterapija adjuvantna plus CDK4/6 inhibitor, odnosno abemaciclib i hormonska terapija bi najvjerojatnije išla. Ok, možemo nastaviti dalje sa sljedećim predavanjem, Josef, sa ovim studijama vezano za nove terapije u ranom karcinomu.
Hvala. Ja ću produžiti na engleskom, zato što čini mi se da imam 15 minuta, a ipak malo brže sam na engleskom, da ne bi tražio. Ok. So the question is, what is a new paradigm in the adjuvant setting? And I would like just to come back to very simple definition. First, adjuvant, that means after surgery. No metastatic disease, which is a key point because the way the patient were clearly included in the trial is crucial because we have to know if potentially for patient with high tumor burden and a lot of lymph nodes that are involved, there is always a suspicion that this patient might be metastatic on the time when they were included. So potentially after neoadjuvant treatment, potentially also after overadjuvant treatment like chemo, and we are treating a risk, which is a key point, and the patient might be already cured and additional treatment might be toxic, so we have to be very careful about that. The second point is that when we look at the 4 trials we have actually, the 2 with palbociclib, 1 with abemaciclib, and the last one with ribociclib, you see here that the definition of what is disease severity is a little bit different. I'm not saying that one is better than the other one, but clearly the trial are addressing the question of high-risk population, but the definition of this high risk is totally, it's not equal regarding the different inclusion criteria. and particularly when we look at the PENELOPE-B. So what we know about the risk definition in hormone receptor positive, it was already stated before, according to stage, according to the biology, according to previous treatment efficacy, and I just want to remind you the AJCC8 classification, which is helpful when you go deeply to, I will say, the explanation. One is the staging, the other one, you see there are some risk profile that will just help us to identify among the different stages those who are of better prognosis. And the paradox, I will say, regarding the HER2 positivity is that now HER2 positive disease is considered to be a good prognostic factor, which was not the case 20 years before. The estrogen receptor positivity is also considered to be a better prognostic factor than an estrogen receptor negative. So the best outcome in the same stage is clearly when you have triple positive disease, I will say, and not triple negative. But here we are in HER2 negative population, because we're focusing in this situation, and estrogen receptor positive. And then you look at all the stages, 3A, 3B, 2B, they are all considered to be high risk when we look at the risk of relapse at 5 or 10 years and the overall survival. And for the 2A, we have some discrepancy and we might discuss, but we know that the NATALEE trial demonstrates the utility of adjuvant CDK4/6 inhibitors in this situation. And there are potentially other parameters, it was already stated before, the tumor genomic prognostic assay. The other one is potentially the level of progesterone expression, which is addressed when you use the tumor genomic prognostic assay because you have the degree of endocrine sensitivity. Then the third question is, can we put all the CDK4/6 inhibitors together, considering that they are all equivalent? We had this discussion this morning regarding the metastatic disease and the impact of the CDK4/6. Now we are dealing in the adjuvant setting, and dealing with the adjuvant setting, again, we are just treating a risk. We are not treating a disease that is clearly visible, actually, and we have to be careful about that. I'm not sure that they're all equivalent. From a pharmacological point of view, this is not the case. And should the indication be restricted to the population included in each study for each CDK4/6, or can we conclude that there is a general class effect, and if you have any issue with one regarding the toxicity, you can switch to the other one? There is still no clear answer about that, and probably we will never have this type of answer. And the last but not least, the paradigm, what does it mean? It means that it's a reference model. It's based on a set of results that give you the hypothesis to be transformed into a form of certainty. And the certainty here is that in what is defined as a high-risk population, the gold standard became today to use CDK4/6 inhibitor, which one in which situations. So back to the trial and the results, if you go now to the PENELOPE, PALLAS, Monarchy, and NATALEE, you can see that they are not the same CDK4/6. The doses that you know pretty well are the same in metastatic and in the adjuvant setting for palbociclib, abemaciclib. For ribociclib, it was decreased due to potential cardiac events prevention. And you see that the duration also of the treatment is not equivalent. In PENELOPE-B, it was just 1 year. In PALLAS and Monarchy, it was 2 years of treatment. And in NATALEE, it was 3 years. And for the endocrine treatment partner, for the first trial, the endocrine treatment partner was the standard adjuvant endocrine treatment without any restriction. For NATALEE, it was aromatase inhibitors. We know already why, regarding the risk of QT prolongation when you use tamoxifen in combination with ribociclib. So the criteria regarding the disease severity is not exactly the same. The type of drug, of course, the duration of the treatment, of course, and the standard adjuvant endocrine treatment that you might use are also different. So if we focus now on the PALBO trials, we have two trials. The results were already presented. These two studies, unfortunately, do not demonstrate the benefit of PALBO in the adjuvant setting. However, This is a population, there is no discussion, with a poor prognosis, based on the IDFS data from the control arms. It was already mentioned. So we can consider this population as a high risk potentially. And it is particularly the case in Penelope B study, which is also, I would say, least powerful, with the shorter duration of CDK4/6 and the most ambitious statistical hypothesis. My perception is that Penelope B was underpowered regarding the primary endpoint, and this is clearly a pity thing, because this trial was interesting, but at least we could not conclude about the impact of this strategy in this situation. Then I will switch to Monarchy, because it was the first positive trial that was published. You know that there were two cohorts. One, the cohort very clear, cohort 1, more than 4 axillary lymph node involved, or between 1 and 3 axillary lymph node with a tumor more than 5 centimeters and or a grade 3. And the cohort 2 was a small cohort for patients between 1 and 3 axillary lymph nodes that were involved, and the Ki-67 that was more than 20%. The CDK4/6 is abemaciclib, the dose you know, duration 2 years, standard adjuvant treatment, IDFS, and statistical hypothesis. You see the results, it's positive, and the last update show clearly that you have at 5 years a benefit, and it's not a small one when you look at the results, because it's close to 8% clearly absolute benefit, which is a huge achievement when you compare what we have with the adjuvant chemotherapy, for example, or even when you compare just tamoxifen versus aromatase inhibitors. We are not at all on the same level of benefit. So the criteria regarding the difference that you have here in the trial design, the patient population again, as you see, and the endocrine treatment backbone, the prior endocrine treatment allowance, which is at the beginning seems to be a little bit complicated, but it's just give you the information that you can initiate this treatment with the CDK4/6 inhibitors, not immediately on the same time that the endocrine treatment, but just a few weeks after if you want. The duration of therapy, on study treatment definition, and the protocol-specified criteria for discontinuation that were clear. And you have here the design of the trial with the cohort 1 and the cohort 2, the randomization which was 1:1, and abemaciclib was delivered 2 years again with endocrine treatment therapy, and the on-study treatment period was of 2 years for the abemaciclib and the endocrine treatment. The follow-up period was of 8 years, as clinically indicated, and it will be prolonged to know the last and the long outcome that we might expect in this situation, particularly because you know you have already seen the curves in different presentations. We have these drugs, the carryover effect, and even with the chemotherapy in hormone receptor positive, when it works, we have the carryover effect. And you have seen the early peak of recurrence, what we might have in the estrogen receptor positive, node positive disease. And the more you will win at the beginning, probably the more you will have also impact on the outcome after 5 or potentially 10 years. And preventing the late recurrence is beginning to prevent the early one, which is a very important concept that might also change the strategy in the future. Maybe with this approach, tomorrow we will not have to do 10 years of endocrine treatment, but shorter will be as effective as it was before with a longer duration. So the criteria and the rules are very, very simple. We have 3 of them. T3, more than 5 centimeters, and more than 3 lymph nodes, and grade 3 if you have between 1 and 3 lymph node positive. So this is the population that were enrolled in Monarchy. You can see that the majority of them were stage 3, as you can see, 3A, 3B, or 3C, and we have about 25% of them were stage 2, 12% 2A, and 14% 2B. And again, the majority of the patients, 60%, had more than 4 lymph nodes involved. This was the cohort 1 part with more than 4 lymph nodes. And the other one, 39%, were between 1 and 3 with grade 3, and tumor size more than 5 centimeters, 22%. The staging, initially it was a little bit confusing to how we determine the stage, because some of the patients, 1/3 of them have received neoadjuvant chemotherapy. The stage was based on a clinical staging or on a pathological one when the patient were operated upfront or operated after that. But if they were operated, of course, after neoadjuvant treatment, the initial clinical stage was considered to be the parameter for the inclusion as an inclusion criteria on the trial. So here are the results. You see with the 54 months median follow-up. On the left side, you have the IDFS. You have an absolute difference of close to 8% regarding the IDFS. And when you look at the distant relapse-free survival on the right side, in the cohort 1 again, you see that you have 7% differences. That means that the majority of the relapse that you prevent with the strategy of adding abemaciclib 2 years in combination with the endocrine treatment is clearly on the metastatic disease. When we look at the subgroup analysis, interestingly, I've put it here in red that we don't have any signal that there is a difference between the level of nodal involvement according to the different cohort I mentioned before and the different subgroups. Interestingly also, when you look even at the tumor size line up, you can see that for small tumors with lymph node involvement, it's the same signal. And last but not least, when you look at also the type of endocrine treatment, this is the last line, you can see that even with tamoxifen, the results are on the same magnitude, even potentially better. That means that there is a clear potency between abemaciclib and the endocrine treatment that you might use in general in this population. When we go back now to the type of relapse, you see that during the period of follow-up and the different data cutoff of analysis of the trial in 2021, 22, and 23, you see that there is an increasing difference between the control arm and the experimental one with the abemaciclib, showing that the majority of the difference is driven by the fact that you will clearly decrease the number of metastatic relapse, and the death due to metastatic disease are clearly less in the abemaciclib plus endocrine treatment comparing to the endocrine treatment alone. So the inclusion criteria correspond to, there is no discussion, a population of high or very high risk of relapse. There is a clear benefit in IDFS and distant disease recurrence. This benefit appears to be consistent regardless of the disease presentation, but with less evidence in elderly, we have to be careful. Stage 2 disease or grade 1. For 25% of the patient discontinued abemaciclib before completing 2 years, 18% due to adverse event, 45% as dose reduction for diarrhea, just 70%, neutropenia or fatigue, and dose reduction, this was already also presented and published, do not influence the treatment efficacy. That means that even if you have side effects, and we will probably focus on the next topic, if you manage this side effect and it's pretty easy, then you decrease the dose and you can still achieve the same level of magnitude of benefit. So Natalie, and I have to say here that due to Lilly rules and because Natalie was not already EMA approved, I could not show you the curves, but you have seen it before. Any case, you know that this trial is positive. The difference is clearly driven by the node negative and a more important proportion of stage 2 disease. Ribociclib was 400 milligrams per day, 3 weeks on, 1 week off. It was a 3-year administration in combination with aromatase inhibitors, and the results are positive on the primary endpoint, which is IDFS here. The difference in the trial design are on the endocrine treatment backbone, the patient population, also the prior endocrine treatment allowance, the duration of therapy, which is 3 years, and the on-study treatment definition regarding the different staging. However, this trial also is to be considered to be positive, and particularly the most important information we have here is already driven by the node negative population that we have. Here the definition of the protocol population, as you can see, the N1 to N3, the tumor size and the grade. There were possibility to include the high genomic risk in node negative also disease. And it was possible to include the patient till 12 months of endocrine treatment. The main population, as you can see here, is N2, 30%, and N1, 43%, and N0 represent just 11% of the population, but it's still informative and important. And the neoadjuvant cohort was about 40% of the population. So not the differences regarding, I will say, the results, because of course Monarchy has a longer follow-up, but the first result that we have from Natalie are giving the same direction regarding the magnitude of the benefits with the same follow-up. But you see that the eligibility criteria are different and the population is different. However, here, regarding the Monarchy definition, it's clearly derived from the AGCC anatomical stage. It was possible to include the micrometastatic disease on the lymph node considered to be N1, and the tumor size was defined clinically, particularly for the neoadjuvant population, as I mentioned it before. So in conclusion, I will say that these two trials, and particularly the first result from abemaciclib, and now with a follow-up of close to, I will say, 5 years, we have clear evidence that the new paradigm for high-risk population is clearly inclusion of CDK4/6 inhibitors. It might be abemaciclib, it might be ribo in overpopulation. However, the population here, particularly defined in the Monarchy, is indisputable regarding the high-risk population definition, and the benefit-toxicity ratio need to be discussed each time, and dose adjustment, if necessary, does not appear to have any impact on efficacy with the Monarchy trial. The adjuvant CDK4/6 ought to be considered to be a new paradigm for the node positive, and it might become very soon the same thing for the high-risk node negative. And I think that for the future, we have to integrate this data when we will have the next generation trials. So back to the clinical case. So the question here regarding the patient, we are exactly on the same situation. What adjuvant endocrine treatment-based treatment option would you discuss with and recommend to this patient? What if it was a grade 2? What if the oncotype recurrence score were 5?
Hvala puno. Gledamo sad, razgovaramo o pitanjima, i šta je ako je, stvarno šta ako je ovo pacijentima bila gradus 2 da nemamo oncotype?
Pa, ne bi promenilo ništa što se tiče, mislim, hemioterapije, pošto još manje bi imala indikacije što se tiče isto.
Onda bi imala, po meni, više indikacije za oncotype.
I po meni.
Eto, oncotype je 5.
Onda bi možda i ne bi davali hemiju.
Ok, ne bi davali hemiju.
Da je gradus 2 i oncotype 5, sigurno ne bi dao hemiju. To nema uopšte...
A šta bi vi dali kao adjuvantna endokrina terapija?
Da je gradus 2 i oncotype 5, 7 godina inhibitor aromataze.
Ok. A između tamoksifena i inhibitora aromataze?
Pa, da. Možda tamoksifen inhibitor ili inhibitor, pa onda tamoksifen, može i to.
Aj bi bila za Nataliju,
Možda.
pošto ima jednu žlezdu.
Ne, ona bi možda bila kandidat za CDK4/6 inhibitora, to je tačno. A drugo pitanje, ne znam koja je vaša praksa. Ja sa godinama, u početku sam dao lako inhibitora aromataza i pokušavao da objasnim ženama da to je vrlo važno da ona primi inhibitora aromataza više od tamoksifena. Kad vidim zadnje rezultate između tamoksifena i inhibitora aromataza, mislim, rezultati su stvarno maltene ništa, kao razlika. A što se tiče ipak safety i način primene, ogromna je razlika između tamoksifena i inhibitora aromataza, tako da ne znam koja je vaše praktika, ali ja počinjem sa inhibitora aromataza, ali relativno brzo, ako ima nuspojave, prelazim na tamoksifen.
Ja bih imao dodatno 2 case. Možeš sesti ako te mrzi da stojiš dalje. Možeš da sedneš ako te mrzi dalje da stojiš. Jedan kazus je vrlo interesantan. Gledao sam ženu pre par meseci prvi put, pa sad opet nedavno kad sam dobio dodatne rezultate. Žena je sad 60 godina okruglo, pre 12 godina je imala karcinom desne dojke koji je bio visoko rizičan i koji je dobio adjuvantnu hemioterapiju, hormon receptor pozitivan, HER2 negativan, gradusa 2, dobio adjuvantnu hemioterapiju, 5 godina, ja mislim, hormonske terapije i sad u drugoj dojici dobija karcinom koji je biopsijom, opet gradus 2, hormon receptor pozitivan, HER2 negativan, recimo neki 20 mm veličine i vidi se na ultrazvuku, ne pipaju se limfni čvor, ali 1-2 limfna čvora i na magnetu se vidi 1-2 limfna čvora i sad ona žena neće da dobije neadjuvantnu hemioterapiju, nisam ja baš sklon, kad nisam baš 100% siguran ni koji broj limfnih čvorova i tako. I dogovorimo se da idemo na inicijalnu hirurgiju, uradi se poštedna operacija, uradi se disekcija aksile i dobiju se 3 pozitivna limfna čvora. I sad u takvoj situaciji uradi mama print. Mama print je nama dostupniji, i ona dobije da je luminalni B high risk i tu se dogovorimo, ima za hemioterapiju i ona shvati, žena je vrlo, vrlo obrazovana. I uradimo testiranje na brk umeđu vremena i dobijemo brka 2 mutiran karcinom. Sad, jasno je ona sad već na hemioterapiji, koja je dalje, šta dalje? Da li da idemo sa godinu dana opariba, pa potencijalno dodamo abemaciclib? Ona nije, uzevši u obzir samo klasične kriterijume sa 3 pozitivna limfna čvora, u stvari ne uklapa se ni u Olimpiju, ni u Monarhi, ali ima dodatni faktor rizika na mama printu i brka je mutiran.
Kod brka populacije, high risk brka populacije, ima nekoliko podatke, ne u adjuvantnoj fazi, ali bar u metastatskoj ili u faza 1 trial. Naprimjer, pričali smo za triple negativ i imunoterapija. Imunoterapija i olaparib idu zajedno, nije problem. Ali CDK4/6 inhibitori i inhibitora PARP ne idu zajedno, pošto toksičnost je vrlo jaka i tako da je bolje da se počne sa PARP inhibitora, a kod nas, to što smo rešili kod nas na guidelines u Francuskoj je da kod tih pacijenata posle 1 godinu PARP inhibitora može eventualno da se uključi inhibitora CDK4/6. 62 godine problem je ona ima rizik relapsa koji je, prve 2-3 godine, ali ima isto rizik relapsa posle 7, 8, 10 godine. Relaps posle 10, to znači da će imati 72 godine. A na 72 godine je daleko komplikovanije da se strategija da bude optimalna za metastatsku bolest, koji treba ona nekoliko godine da prima terapije i eventualno hemioterapije, ako može da se izleči, bolje sad. Tako da ja mislim da upfront strategiju, kad već može da se izleči, je uvek bolje, iako ima 60 godina, naprotiv, zato što ima 60 godina i zato što kasni relaps je problem kod tih žena.
Druga pacijentkinja, ovo je, mislim, prilično jasno, bez obzira što su ta 3 limfna čvora, to shvatamo kao high risk i zbog mama printa i zbog svega. Druga pacijentka je klinički problem i to je očigledno svima u svetu klinički problem. 78. godište, isto lumi, 46. Karcinom, isto neki blaži T2, početni T2, 22-3 mm, operisana, inicijalno klinički i radiološki negativni limfni čvorovi, sentinel extempore negativan i finalni sentinel dođe pozitivan kad se završi operaciju 10 dana kasnije. Hirurg neće se vraća u hirurgiju da pokupi još lezda zbog staginga i da nama olakša. Šta tu da radimo? Dva sentinela, jedan pozitivan. I to nije na extempore bio pozitivan, ali nije ni mik pozitivan, nego klasično pozitivan. Šta radite u takvoj situaciji? Kako sad tu strategiju? Da li insistirati da se vraćamo nazad u hirurgiju ili šta da radimo?
Koji gradus je bio?
Gradus 2. Gradus 2.
A veličina tumora, izvini?
22 mm.
Mi bi nezavisno od toga, ako već postoji indikacija za CDK4/6 inhibitora, ubacili bez da se ide na dopunska akselarna disekcija. Zato što hirurzi šta manje i manje idu na akselarna disekcija, ali jeste problem. Problem je zato što ako se gleda tačnost prema inclusion kriterija koje ima u trialima, teoretski trebalo bi da imamo više informacije. Ali rešili smo da kod pacijenti gde mislimo da treba da se da, nezavisno damo.
Znači, ali improvizujete nekada?
Pa, nemamo nikad nemamo uvek baš idealnu situaciju.
Nije nikad sve baš dizajn studij, jasno, modelni klinički.
Dobiti veća informacija, ok, ali ako ne menja obavezno, ako smo već rešili da ima indikaciju za CDK4/6 inhibitora, onda...
Doktor Kašušnjar, izvolite. Treće predavanje je o menadžmentu neželjenih efekata.
Moje današnje izlaganje odnosi se zapravo na to kako mi sada da zapravo prepoznamo, to je prva stvar, znači prvo trebamo da prepoznamo da pacijent ima neku toksičnost, ima neko neželjeno dejstvo i naravno da sa njim o tome razgovaramo. Zašto? Zato što znamo da adherencija i perzistencija u tom slučaju je najbolja, odnosno da će se pacijenti pridržavati našim preporukama. I da se vratimo sada, ja ću naravno sve to ispričati kroz naravno slučaj naše pacijentkinje Samante, koja je, ima 62 godine, samo da vas podsjetim, koja je krenula da prima abemaciclib sa standardnom hormonskom terapijom, verovatno je to neki inhibitor aromataze, i ona sada prijavljuje i ide znači sa klasično 150 mg abemacikliba 2 puta dnevno i 1 tabletu, mislim da je bio inhibitor aromataze. Uglavnom, šta je ona sada osetila? Pored ono, neko je rekao ovde da zapravo CDK4/6 inhibitori sa inhibitorima aromataze kod tih pacijenata manje izražena artralgija, ja tako bolovi iz glave, to jeste stvarno zabeleženo, tako i ona ima neku blagu artralgiju, ali šta je ona zapravo osetila, to je ono što većina naših pacijentkinja koje uzimaju abemaciclib zapravo i prijavljuju, i to je praktično u prva 2 ciklusa imale dijareju. Znači, ta dijareja je bila gradusa, ne piše ovde gradusa 2, ali bila je dovoljno jakog stepena da je ona zapravo prekinula. Dakle, ono što jeste, prekida se sa terapijom, imate kratki jedan prekid da bi se, znači, pražnjenje creva vratilo, znači, na normalu. Međutim, ona je imala još jedan problem. Ona je sada slušala i pričala svojim doktorima i shvatila je da ako ne uzima, dakle, lekove, da sad to može da utiče na ishod lečenja, odnosno da to može da pogorša ishod njenog lečenja, te je ona tako krenula ponovo, znači, da uzima abemaciclib i hormonsku terapiju. Naravno, opet je u istoj dozi, tako i opet je, dakle, iskusila tu dijareju gradusa 2. Sad, šta je zapravo perzistenca, odnosno šta je adherenca, a šta je perzistenca? Znači, adherenca je da se pacijent pridržava oni šemi koja treba da se daje. Znači, ako su to 2 doze abemacikliba ujutru i uveče, onda da ona to ne prepolovlja pa samo ujutru, i da uzima tako, što pacijenti rade. Ako ih malo pitate, mislim, sa ovim hormonskim terapijama, hoće malo tako da svaki drugi dan, svaki treći dan prepolovi tamoksifen i takve stvari, ne pitaju ništa i to prosto tako nekako ide. I verovatno bi se iznenadili koliko to naši pacijenti rade. Mislim, mi to manje više i ne zabeležimo i tako dalje. Vidjet ćete da se u kliničkim studijama to zabeleže, onda možete misliti kako je u rutinskoj praksi. Znači, to je adherence. Perzistencija je sad da oni primaju onoliko dugo koliko treba da se prima. Znači, ako kažemo tamoksifen 5 godina, bude 5 godina, ne bude 3 godina, prekine zato što prosto ne želi da uzme. Ne zbog neželjenih efekata samo, nego prosto i dosta joj i takve stvari ima, ili ako je 10 godina, da bude 10 godina. Od čega zavisi sada, koji su to faktori koji utiču, dakle, na adherenciju i na perzistencu? Imate ovde, znači, više faktora, to može zavisiti, naravno, vezano je za samog pacijenta, a to je zapravo ne tako bitna je stvar, zato što kako pacijent percepira, dakle, tu terapiju koju dobije. Znači, adjuvantnom lečenju vi praktično nemate tumor, vi zapravo dajete lek preventivno, da se ne desi da se povrati bolest, što može da utiče na dužinu života. I pacijent ne vidi to nekako ispred sebe, nekako kada se ipak dešava da bolest se ponovo povrati, pa onda dobije neku terapiju, pa sada vidi, smanjuju se te neke promene ili se one povećavaju, to je nekako realno, tu vidi šta se dešava, ovde ne vidi. I ako ima neželjene efekte koje mi ne prepoznamo i sa njima ne razgovaramo, onda će one prosto logično i to prosto prestati da uzimaju. Znači, neželjeni efekti su jedan od najčešćih razloga zašto one odustaju od lečenja. Zatim, žene koje imaju, odnosno pacijenti koji imaju više komorbiditeta, naravno, neželjeni efekti su kod njih i više izraženi. Zatim, sistem, naravno, healthcare sistem, a to možemo mi da se poželimo, zato što kod nas pacijenta, pacijentkinja ako hoće da uzima abemaciclib, znači neki moraju, boga mi, po 300-400 km svakog meseca da dođu do centra, da uzmu tu kutiju, da se vrate, ali tako kući. Tako da kažem, još i ako ima neko neželjeno dejstvo, pa ne može doktor koji je nju leči, a to je lekar opšte prakse, ali tako, oni su na njega usmereni, on nema ni pojma šta je abemaciclib i tako dalje, tako da da stvarno to može da bude vrlo za pacijenta, da kažemo, nekomforno i da on baci tu kutiju pre nego da sada sve to radi. I naravno, socijalno-ekonomski su faktori vrlo bitni, jer ako pacijent mora da putuje, da plati kartu koja će mu se refundirati neka tamo, nema ljudi, jel tako, ta sredstva. Tako da sve to može upravo da utiče na uzimanje leku. I sad ono što sam htjela da kažem, da zapravo prikažem to je, da mi sada imamo iskustva sa tim dugotrajnim terapijama. Znači, te dugotrajne terapije su problematične u tabletama, pacijent sam to uzima. I mi imamo sada, da kažemo, dosta nekih rezultata vezanih i za mlade žene i za starije žene. Znači, jednako i mlade i starije žene su sklone zapravo da ne uzimaju terapiju. Ovde, levo na ovoj tabeli, zapravo prikazani su rezultati jedne studije koja se zove Kanto, to je jedna kohorta. To su mlađe žene, negde oko 1500 ih je bilo i one su uzimale tamoksifen. I šta je sad? Oni su ispunjavali anketu gde su zaokruživali da li uzimaju ili ne uzimaju tamoksifen, ali im se određenim vremenskim intervalima vadila i krv, je li tako? Pa se onda gledali da li ima tog tamoksifena, odnosno koliko je njegov nivo u krvi. I onda se ispostavilo zapravo da negde neki 16%, skratim čitavu priču, znači 16% njih kaže da uzima, a zapravo ne uzima zato što nema tamoksifena. Znači, i to je još jedna stvar da naši pacijenti, ako se plaše, možda ti kaže, jel uzimaš, a onda uzimam. Znači, to hoće možda malo i da nas prevare, odnosno ne prevare nas, nego sebe, ali zato i to treba tako prepoznati. Ovde je sa desne strane soft i text studije, znate da su to studije koje su ispitivale hormonsku terapiju kod premenopauznih žena, a ovde vidi se, znači dole su navedeni ti procenti u pacijentkinje koje su primale različite vrste hormonske terapije, bilo da je to tamoksifen ili overina supresija sa tamoksifenom ili inhibitorom aromataze, da vi vidite praktično da negde 20 do 24% žena odustane, znači rano odustane, rani prekid sa terapijom. To je praktično svaka peta, svaka četvrta odustane ranije, što je recimo za mene jako visoko. Ove postmenopauzne žene, to je sada ta Big 198 studija koja je bila interesantna sa svoje strane, da se ne pričam, u svakom slučaju vidite da sve su to postmenopauzne žene, tu su bile neke 4 grane i tako, i sad videlo se da recimo do 2 godine negde oko 10% odustane, znači rano prekine, a do 5. godine još nekih 8% odustane, znači 18% ne prima, ranije prosto prekine sa terapijom. Da li to utiče na ishod lečenja? Utiče. Kad je u pitanju, dakle, hormonska terapija, mi smo sad to videli, ovaj levi i desni grafikon upravo govori o tome da one žene koje su prekinule ranije, dakle, sa hormonskom terapijom, da oni imaju zapravo i loši ishode lečenja, to je ova crvena linija, i kod Kanto isto studije, vidite koliko je to, rizik za relaz bolesti 2 puta veći kod onih žene koje su prekinule ranije u odnosu na one koje nisu. Sada vidimo šta se zapravo dešavalo i šta se dešava kod žena koje sada, pored hormonske terapije, to je inhibitor aromataze, dobija još i CDK4/6 inhibitora, to je abemaciclib. I ovde vidimo, znači sa leve strane ovi plavi stubići, to je abemaciclib, jer tako sa desne strane to je abemaciclib sa hormonskom terapijom, se razumemo, a sa desne strane je samo hormonska terapija sa placebom, znači bez abema. I mi vidimo zapravo da je najučestalija neželjeno dejstvo svih gradusa, dijareja, vidite se javlja u 84%. To je dijareja koja je uglavnom gradusa 1 i 2, ali dovoljno je 1 da imate dijareju, to već. Ima manje, naravno, gradusa 3, to su ovi jako tamni stubići, znači dijareja, zatim neutropenija, manje nego sa ribociklibom i palbociklibom, i ono što možda najmanje mi percepiramo, a to je zapravo ta nemoć ili fatige, kako se kaže, 41%. I sad kad gledamo dijareju, dakle dijareja, vi vidite ove stubiće, oni zapravo, to su meseci kada se uzima abemaciclib, i u prvom mesecu je zaista, već kažem, srednje vreme pojave dijareje vrlo brzo, u prvoj nedelji praktično se javlja, i u tom prvom mesecu zapravo su i najviše pacijente koji imaju graduse 3, graduse 2. Posle toga, znači ako se naravno postupa onako kako treba, to ćemo posle da kažemo, taj se nivo, znači taj se broj pacijenata smanjuje i uglavnom su to blage, odnosno dijareje gradusa 1, koji ipak prati negde 30% pacijenata do kraja uzimanja leka. Ono što je zabeleženo u ovoj studiji, to je da je negde prekid terapije, ali potpuni prekid terapije zbog dijareje bio negde oko 5%, nešto malo više od 5% pacijenata je prekinulo i tu treba reći da je negde 3/4 od njih prekinulo terapiju, da prethodno nisu prošli kroz ono smanjenje doza leka, što je jako važno. To možda zato što je to bila studija, pa dijareja, ja ne znam zašto je se to tako postupilo, vjerojatno su možda i pacijenti sami odustali kada su uvideli dijareju. Ovo je sada nešto što je važno, ovo sa leve strane, ok, to je uobičajeno, to je sada kvalitet života, vidimo da je ovaj levi grafikon, znači praktično slično sa kvalitetom života, međutim ono što je ovde, želim da vam skrenem pažnju, to je ovaj desni, dakle, deo slajda, gde zapravo pacijenti sami prijavljuju koliko im smeta neko neželjeno dejstvo koje imaju. U ovom slučaju to je dijareja. I sada vidite, znači na početku, to je ono 0, taj stubić, ono zeleno, to znači ništa mi ne smeta, ali not at all, a ono što je brown, to je praktično very much, znači strašno mnogo mi smeta. I sada vidite naravno da sa 3. mesecom, znači to su sada meseci kako oni uzimaju, da zapravo se značajno smanjuje taj stubić koji je zeleni, da je ne smeta ništa, nego im, boga mi, velikom broju pacijenata, to je više praktično od 50%, oni prijavljuju ili quite a lot, ili samo ili a little bit. Znači, od onoga malo mi smeta do malo više ili boga mi smeta. Tako da kažem, to ne treba da zanemarimo i tokom cele studije vidite, to je tačno postepeno kako se radi, kako se pacijentima savetuje šta da radi i tako dalje ili smanjuje doze, mi vidimo naravno da se polako i smanjuje, da se poboljšava ta situacija, da malo bolje reaguju, da nemaju, znači da ne smeta toliko koliko je to bilo na početku, ali svejedno ostaje jedan, kako da kažem, veliki broj pacijenata, skoro više, nešto malo manje od 50%, koji ipak imaju problem sa dijarejom, smeta im. A kada prekinu sa lekom, praktično se to automatski smanjuje, znači i prestaje, znači to što im smeta, ali tako, sa dijarejom. I sad šta se radi sa dijarejom? Inače, kao i kod svakog CDK4/6 inhibitora, mi to imamo iskustva sa palbociklibom i ribociklibom metastatskom, znači pacijenti moraju da se prate prva 2 meseca jednom u 2 nedelje, znači svaki 15 dana, mi gledamo krvnu sliku, gledamo biohemiju, pratimo transaminaze, a ono što jeste važno jeste da mi praktično moramo da ih pitamo da li imaju ili nemaju dijareju. Oni su uglavnom se žale, imam ili ne. U svakom slučaju, kada je u pitanju dijareja gradusa 1, a tamo vam desno stoji šta je zapravo gradus 1, znači da bismo znali da gradiramo, moramo znati koliko je, da kažemo, koliko puta prazne creva, znači taj ritam pražnjenja creva pacijenata, moramo znati da li je 1 stolica dnevno ili 2 stolice dnevno, što može biti kod nekoga normalno, ili 1 u 2 dana, što je opet za nekog jeste normalno pražnjenje. I vi onda vidite da je gradusa 1, to je povećanje broja stolica za manje od 4, znači 1, 2 ili 3 stolice više od uobičajenog. To je gradus 1. Za taj gradus 1 nije potrebno da se smanjuje doza, ali ako sklizne u gradus 2, što se vrlo često dešava, znači dovoljno je samo još 1 stolica više, ili ako se javi tečna stolica, tako, već onda mora da se prekine, znači, sa terapijom, da se, znači, opet uravnoteži, znači, pražnjenje creva ili da to bude do gradusa 1 i da se onda ponovo re-challenge, što bi rekli, ponovo se da ista doza leka. Ali ako on ponovo uđe u gradusa 2, kao što je naša Samanta, onda mora da se smanjuje doza. To smanjivanje doze, znači imate 2 dozna nivoa smanjenog uzimanja, znači prvo je daje se uobičajeno 150 puta 2, a onda idete na 100 mg puta 2 i na kraju 50 mg puta 2. Znači, posle toga, ako pacijent ima opet neko neželjeno dejstvo, zbog koje bi zahtevao da smanjimo dozu, tu više nema smanjenja doze i onda se lek prekida. U slučaju da se javi dijareja graduse 3 ili ne da baže 4 odmah, naravno, onda jako moramo biti oprezni, tu se naravno odmah smanjuje doza i to je sada, naravno, moramo voditi računa, vidimo ko je ispred nas, jel? Zato što na dijareju ne reaguju svi, tu je dehidracija i tako dalje. Ali to su retke stvari, ja mislim. Sad ovo što smo htjeli da kažemo, što sam htjela zapravo skrenem pažnju, to je sada taj kreatinin. Znači, pošto abemacikliv utiče, dakle, na transportni mehanizam u tubulima, neću da ulazim sad u te detalje, to su neki sad molekularne stvari, nije ni važno, znači važno je samo znači, da se može desiti i dešava se prvo kod većine pacijenata da poraste nivo kreatinina, a da to ne znači i oštećenje bubrežne funkcije. Znači, prosto svi imaju, oni porastu na početku, on se uglavnom je to blago povećanje, traje sve vreme dok se uzima abemaciklit, kad prestane, on prosto padne na svoju normalu. Ono što može da komplikuje situaciju, to je ako imate pacijente koji ima dijareju i koji je došao dehidriran, pa mu onda vidite kreatinin povišan, znači tu moramo biti oprezni i to apsolutno mora da se vodi računa i da se proverava bubrežna funkcija. Znači, povećanje kreatinina, što, kažem, vidimo kod velikog broja naših pacijenta, ali, dakle, on nema one faktore koji govore o insuficijenciji bubrega, znači kao što je glomerulna filtracija koja je okej. Šta se dešava sada? Već smo rekli da je neutropenija sledeće neželjeno dejstvo i ta neutropenija sa ovim drugim CDK4/6 inhibitorima više, dakle veći problem, ali svejedno neutropenija, još ako se udruži sa dijarejom i to je, znači, možda komplikuje situaciju, znači nije svejedno. U svakom slučaju pratimo, znači, krvnu sliku i tu postoji praktično iste preporuke kao i za sve ostale. Kad je gradus 1 i 2, vi ne morate da smanjujete dozu. Znači, neko ko ima kome se kreće neutrofili između 1 i 1,5, može slobodno da dobije lek da se ne smanjuje doza. Ovo je sada, što kažemo, mislim, ovo je dobri su ovo slajdovi zato što prikazuju ono što pacijenti prijavljuju. Znači, ono što pacijent prijavi da mu smeta, jedna je stvar što mi to isto beležimo, svi koji radimo u studijima znamo kako to izgleda, jel? Mislim, mi beležimo, pitamo pacijenta, gradiramo neke neželjena dejstva, a onda oni sami još na onim, posebno nezavisno, znači od nas, ukazuju i pokazuju koliko im šta smeta i da li imaju neko neželjeno dejstvo. I sad vi vidite zapravo da ovo je sa leve strane, znači koliko su pacijenti, koliko im smeta bilo koje neželjeno dejstvo sa abemaciklibom i ovo je dole sa grupa sa placebom. Mi vidimo da ipak kada se prima abemaciklit da su one malo više imaju nekih, da kažemo, situacija da im to više smetaju side effects, jel? A kada pogledamo sa desne strane, to je sada jedno posebno neželjeno dejstvo koje, ja mislim, i najmanje percepiramo, to je taj umor, odnosno možda bi to na srpski bolje preveli kao nemoć, znači fatig, upravo što sam pričala sada prethodno, fatig je zapravo, znači to vrlo često imate gradaciju na tom fatiga, mi to nekako i ne pitamo pacijenti, valjda misle se to podrazumeva, to se dešava sa svakom mogućom terapijom, sa hemioterapijom, ali vi onda vidite sada ovde koliko zapravo to neželjeno dejstvo, taj fatig njima smeta. A kad pogledate malo samo, ali fatiga imate i dole, znači vidite, znači svi koji primaju hormonsku terapiju, ali primaju i placebo, ne zna šta prima, jel? Ali vidite zapravo da je to jednostavno jedna uobičajena, dakle, neželjeno dejstvo sa svim terapijama koje mi dajemo. Jedino je možda malo više u grani sa abemaciklibom, malo više onih somewhat, samo malo više smeta fatig nego možda u grupi sa placebom. Ali suštinski, znači to jeste, da kažem, ovo neće da okretne sad, ja se izvinjavam. Halo? Neće, hoću da okrenem, neće, nešto se ovde pojavljuje. Neće da prenese. Izvinjam se. Neće. Vidi. To je unazad.
Prvo samo da menjamo.
Ali nema veze, mislim. Znači, na sledećem slajdu je zapravo bilo prikazano kako se zapravo sa, da kažemo, naviga i sa tom osjećajem nemoći. To može biti vrlo neprijatno. Ajde, probajte. Ona je tako i gradirana, ali isto imate graduse 1, 2 i 3.
Samo se.
Tehnika narodu, šta bi rekli, dobro. Neće na veliki ekran. A sad ćete, dobro. Dobro, u svakom slučaju, znači kako se modifikuje doza i prema, evo sad je on, dobro. Ovo sad već možemo i da preskočimo, znači kako je gradirana to. Ono što sam htjela samo da skrenem pažnju, to je upravo to, da znači postoje neželjeni efekt, ozbiljni, znači neželjeni događaji koji zapravo su doveli do toga da se ranije prekida, odnosno ili da se, da kažemo, privremeno prekine sa terapijom ili da se smanji doza. Znači to je uopšteno sada, discontinuation je bilo, znači ranije prekid je bio u 18,5% pacijenata, znači nešto malo manje od 20%. Znači svaka peta. Ono što takođe je ovde od tih neželjenih efekata koji jesu ozbiljni, to je venski tromboembolizam i to je negde oko 2,5%, 1% je bila plućna embolija i to je češće, mislim, viđeno sa onim pacijentima koji su bili na tamoksifenu. Znači, od hormonske terapije bio je i tamoksifen i inhibitor aromataze. Ono što je ovde takođe zabeleženo, to je intersticijska bolest pluća, negde nešto malo više od 3%, i ona je bila više povezana sa onim pacijentima koji su bili izračeni. Mi znamo da zračenje, naravno, bez obzira koliko su pluća zaštićeni i tako dalje, evo tu su mi, vidim, kolege radioterapeuti, ne pomeni račune šta pričam, ali principijalno, jesam dobro rekla, da, može, da. Znači, oni prosto mogu da pluća učine osetljivijim, znači, na pojavu intersticijske bolesti pluća izazvane, znači, nekim drugim likovima. I sad, ko je sad u većem riziku? Znači, su videli da je u najvećem riziku zapravo da se prekine sa terapijom ranije, starije žene, naravno postmenopauzne. Mi sada vidimo žene starije od 65 godina, negde posle 6 meseci skoro, čak više od 25% će prekinuti sa terapijom. I isto tako ono što se očekuje i što je logično, svima nama, to je broj komorbiditeta. Što je više komorbiditeta, to je veći rizik da će se terapija prekinuti. Ali ono što je bitno sada, i to sada da mi isto tako što bi rekli adresiramo, tako, bojazan koju je i Samante izrazila, a to jeste da ako smanjim dozu, ako prekinem sa lekom, šta će se desiti sa ishodom lečenja. Znači, kod pacijenata koji su smanjili dozu zbog toga što se javila toksičnost, kod njih nije bilo, znači, nikakve razlike u ishodu lečenja. Ovo je zapravo jedna studija, to je jedna bravurozna, ne znam kako da kažem, matematička ili statistička, znači, analiza koja je upravo to podelila pacijente prema nivou, odnosno prema intenzitetu doze kod onih koji su prekinuli, koji nisu prekinuli i dobili su zapravo krivu koja pokazuje da nema značajne razlike u ishodu lečenja, dakle, između ovih pacijenata. Sad ovo je dat kao neki mali algoritam kako pristupamo zapravo pacijentima koji primaju dugotrajne terapije, to je naravno hormonska terapija. I znači, prva stvar je da treba naravno da prvo detektujete, da identifikujete pacijenta koji ima problem, da sa njim razgovarate, da onda možete da gradirate težinu, znači to je neželjen efekt, da onda u zavisnosti toga šta je u pitanju ga uputite, znači, kod određenog specijalista ili tamo koji treba da, znači, produbi i da svoj predlog. Znači, to je multidisciplinarni pristup kao i svemu, kao i što donosimo odluke za onkološku terapiju, tako treba multidisciplinarno da se povezujemo i kada treba da sagledavamo, odnosno da ublažavamo neželjene efekte. I sad šta možete da date? Znači, postoje različiti načini kako možete da pomognete pacijentu, odnosno u tom ublažavanju simptoma, bilo da su to farmakološke ili nefarmakološke mere. Postoji mogućnost da se uključi neke kliničku studiju, naravno treba edukovati pacijenta i eventualno dati nešto od pomoćnih lekovitih sredstava. Ako vam to, i morate da procenjujete, znači tom pacijentu koji ste dali lek, sada morate naravno i da vam dođe na kontrolu, da pitate da li to radi, ne radi, kako mu je, ako mu je dobro, ako je poboljšanje, nastavljate sa istom hormonskom terapijom u ovom slučaju, a ako ne, onda dolazi obzir, znači, da se ta terapija i eventualno promeni. To najčešće radimo kad su u pitanju inhibitori aromataze, tamoksifen i tako. I sad zapravo koje su te intervencije da bismo mi poboljšali, znači, adherenciju pacijenta, to je upravo to da simplifikujemo zapravo terapijski režim koji postoji. Mislim, abemaciclib je 2 puta dnevno i jednom ide inhibitor aromataze, tako da, mislim, to je relativno jasno, jel? mora da se abemacikli dobije u dve doze. Međutim, mi znamo da kod nekih terapija koje mi još uvek praktikujemo u metastatskoj fazi, na primer kapecitabin i lapatinib, ja stvarno se pitam šta ti pacijenti rade. Znači, dobije šaku lekova, pri tome treba da zna koje tablete pije 2 puta dnevno i da li je pre ili posle, a koje pije jednom dnevno, pa vam se dešava da lapatinib pije u dva vremena, pa onda to bude onda čitava katastrofa, neželjeni efekti i tako. Znači, ovde mislim da je već samim tim ovaj režim dosta simplifikovan. Naravno, treba da im damo jasne instrukcije i tako dalje i ono što je važno, znači to je upravo da treba da razuverimo pacijenta u neke, da kažemo, nešto što ih u šta veruje, a to nije tačno, različite misconceptions, da onda vidimo da li oni treba da ga uputimo kod psihologa i tako dalje. I ono što jeste važno, mislim da to svi radimo, to sam videla da imaju u Kragujevcu, da imaju drugde, to mi pišemo, napisali smo, znači, taj leaflet u brošuricu i sada pacijent za bilo, mislim, bez obzira koji je CDK4/6 inhibitor, pa i za abemaciklim, znači imamo jedan, napisali smo prosto uputstvo pacijentu, kako uzima, šta treba da očekuje, kako da se ponaša i tako. Znači, ako se sad mi vratimo Samanti, šta mi zapravo treba sada njoj da, i kako ćemo s njom da prodiskutujemo? Znači, šta bismo je preporučili u lečenju dijareje, da li da redukuje dozu i tako dalje. Ono što ja hoću samo da kažem, znači, to je žena koja ima 62 godine, znači, približava se onim godinama kada je u riziku da ranije prekine sa terapijom. S druge strane, ona je žena koja se plaši da ako smanje terapiju, da će imati da će imati manji efekat, da će ta terapija biti manje efikasna. Znači, treba je razuveriti u to da smanjit ćemo dozu zato što ne ispunjava kriterijume, da smanji dozu će ući u neku ozbiljniju toksičnost i, znači, smanjujemo dozu, objašnjamo da to neće uticati na njen ishod lečenja i, naravno, dati joj preporuke, iako mi to već unapred i imamo, da kada se prvi put pojavi, znači, tečna stolica, da koristi loperamid, znači antidijarojke, zatim da dajemo i tu jedan predlog dijete, znači šta treba da uzima da smanjite rizike od dijareje, znamo da neke ishrane, ali tako to može da poveća i prosto na taj način i damo je naravno mogućnost da se može javiti uvek kad ima neki problem. Eto, toliko od mene.
Hvala puno. Nastavljamo odmah dalje, malo smo u probijanju vremena. Nastavit ćemo odmah sa metastatskim karcinomom dojke i lečenjem u CDK4/6 inhibitorima. Panel diskusiju smo imali nakon svakog predavanja, tako da ćemo sada odmah nastaviti na metastatsku bolest. Hvala kompaniji Lili na pozivu i na organizaciji ovog sastanka. Ovo su moji konflikt interesa. Šta se desilo Samanti? Nažalost, dobila je metastaze 3 godine nakon završetka endokrine terapije. Dobila je bolove, mi smo radili CT-o i vidjeli smo da ima metastaze kako u kostima, tako nažalost i u jetri. I onda smo načinili biopsiju koja je pokazala da se radi o hormon receptor pozitivnom, estrogen pozitivnom, ali progesteron negativnom karcinomu dojke i pitanje je kako sad ovu pacijentkinju treba da lečimo. Ja ću pričati kako su se razvijeli CDK4/6 inhibitori, šta je najbolje kombinovati sa CDK4/6 inhibitorima od endokrine terapije i kako u odnosu na karakteristike pacijenta izabrati CDK4/6 inhibitor. Prva stvar, ovo svi već jako dobro znate kako se razvijela terapija kod hormon receptor pozitivnog karcinoma dojke od tablete koja je spasila milione života tamoksifena preko inhibitora aromataze koji su postali standard i jedno vreme služili kao standard of care u kontrolnim grupama u studijama sa CDK4/6 inhibitorima, fulvestrant niža doza, viša doza fulvestrant i naravno nakon toga fantastični lekovi počevši sa palbociklibom, a zatim i sa ribociklibom i abemeciklibom i sad sve dalje razvijamo nove ciljene terapije. Kakve sve kliničke situacije imamo kod metastatskog karcinoma dojke? Prilično su različite. Imamo one koji su primarno endokrino rezistentni, koji relapsiraju unutar 2 godine adjuvantne terapije, oni koji relapsiraju do kraja adjuvantne terapije i godinu dana posle, koji su sekundarno rezistentni i oni koji su endokrino senzitivni, odnosno koji su kasnije relapsirali ili imaju de novo metastatsku bolest. Zašto je to važno? Naš dragi prijatelj Matteo Lambertini sa kolegama iz Italije objavio jedan real world data pre ere CDK4/6 inhibitora, gde prognozno u odnosu na stepen rezistencije imamo i različite ishode pacijentkinja. Najvažnije je to da su endokrinosenziti imaju najduže preživljavanje, nešto lošije sa primarnom endokrinom rezistencijom, odnosno sekundarnom, a najlošije sa primarnom endokrinom rezistencijom. I onda su došle različite kliničke studije u metastatskom karcinomu dojke, što prve, što druge linije. Ovde smo fokusirani na prvu liniju. Sve studije su imale primarni cilj vreme do progresije bolesti i u tom primarnom cilju pokazale prilično slične rezultate. Paloma 2 nije pokazala statistički značajno ukupno preživljavanje, Monaliza studije jesu, Monarch 3 vrlo značajnu kliničku razliku i granično statističku značajnost. Dakle, imamo nekoliko terapijskih opcija koje su u suštini u guideline-ima stavljene na isto mesto, ali su prilično različiti lekovi. Tokom vremena smo shvatili da je važnije inhibirati CDK4 u odnosu na 6. Tokom vremena smo shvatili da je možda bolje imati malo prljaviji CDK4/6 inhibitor koji možda inhibira i CDK2 i 9, kao što radi abemaciclib, i ima efikasnost recimo i u CNS-u i ima veću potentnost možda u teoriji u odnosu na ostale CDK4/6 inhibitore. I ponovo studija
inhibitorom efikasna kod pacijenata u prvoj liniji sa pomenutim kardiovaskularnim komorbiditetima, sa leve strane neponderisana, sa desne ponderisana, i vidimo da postoji izvesna razlika, ali dalje ta razlika i kada je urađena ponderisana analiza jeste statistički značajna. I kada je u pitanju ukupno preživljavanje i kada je u pitanju medijana do progresije bolesti. Tako da zaključak ove studije jeste zapravo da je kombinacija palbocikliba i inhibitora aromataze efikasna i kod pacijenata sa kardiovaskularnim komorbiditetima u prvoj liniji lečenja. I za kraj, ovo je svima poznata, više puta pomenuta Paloma 2 studija. Ovdje je rađena analiza u odnosu na ovde pomenute komorbiditete. Ako pogledate vaskularne, kardiovaskularne bolesti, hazard ratio je 0,51. Studija jeste pokazala, to jeste podanaliza, ali jeste pokazala da i u slučaju prisutnih kardiovaskularnih komorbiditeta postoji efikasnost ove kombinacije, a da je ukupno oko 14% pacijentkinja imalo kardiovaskularne bolesti. I sa ovim bih se ja zahvalila i sad predajem moderatoru za završnu reč.
Hvala Ivana. Videli smo definitivno šta treba da radimo sa pacijentom sa kardiovaskularnim komorbiditetom, ali i dolazimo do ovog kompleksnog slajda koji baš nije za ovo kasni sat. I Maja, nisam zaboravio da ima još jedan slajd, ali neću ga vrteti uopšte. Ako hoćete, gledajte ovaj slajd, ali ja ću dati jedan zaključak koji mi ovako više prije, a to je zašto mislim da je palbociklib jako bitan lek. Prvo što je to prvi CDK4/6 inhibitor koji je potpuno promenio sliku lečenja i posle su došli drugi, učili na greškama i napravili možda malo drugačije studije. Primarni ciljevi svih studija su jednaki. I danas je profesor Cortez o tome i pričao, da kada je vreme do progresije bolesti u pitanju kao primarni cilj, kako su dizajnere studije, rezultati svih registracionih studija su jednaki. Treća vrlo bitna stvar je Parsifal Long. Ako i numerički hoćete da gledate, 62 meseca je zaista nešto što je jako važno. I kada kažu, neko kaže to su isti lekovi, ne, to su potpuno različiti lekovi, ali svaki ima svoje mesto. Pričali smo u ranijim simpozijama gde je mesto ribocikliba i abemocikliba i gde bi trebalo te lekove dati. Ali ono što je jako važno za palbociklib, to je lek koji se najbolje podnosi. I lek koji, ako imate pacijenta sa komorbiditetom ispred vas, a takvih je jako puno, to je verovatno lek izbora, i ako imate pacijenta sa puno lekova, sa polipragmazijom, takođe to je lek izbora i zaista sa svojim rezultatima i sa svojim profilom toksičnosti ima veliko mesto i veliku ulogu u našoj praksi. Ja mislim da Ivana i Ana se time slažu. Dobro. I time bi zatvorili satelitski simpozijum kompanije Pfizer. A boga mi i drugi dan kancerološke nedelje. Hvala.